My name is Tom Keene. I'm the National Coordinator for Health Information Technology, and we are going to be holding 3 roundtables to help us how to better understand to provide care for Americans with substance use disorder and mental health disorders. This is an area that is too often forgotten and that is not adequately addressed by our healthcare system. And our illustrious panel here today are all individuals who are deeply invested in changing that, in making sure that mental health and substance use care comes on to parity with traditional medical care so that all Americans can be treated. We will be going until about 4 this afternoon. The conference is being live streamed, and we expect this to be interactive. The purpose here is to learn and to make policy, so I want to thank you all for coming. I have a few opening remarks. Last December, President Trump signed the SUPPORT Act, reauthorization into law, and extended billions of dollars of federal funding for programs aimed at preventing overdoses and strengthening treatment and recovery services. Then, earlier this year, President Trump issued an executive order establishing the Great American Recovery Initiative, which sets the course for a national effort to prioritize addiction treatment and recovery. The Great American Recovery Initiative represents a first-of-its-kind, whole-of-government response to the disease of addiction, which impacts over 48 million Americans. As the National Coordinator for Health Information Technology, my office is charged with improving the access and use of electronic health information, including for mental health and substance use care. There are significant technological barriers impacting mental health and substance use care outcomes. I appreciate everyone joining us this morning to identify the challenges, highlight the successes, and to chart a path forward. As part of the SUPPORT Act reauthorization, my office is hosting this roundtable to inform a report to Congress speaking to how the adoption and use of electronic health records can improve mental health and substance use care outcomes. We are fortunate to have one of the 2 co-chairs of the Great American Recovery Initiative with us here today, who is also the White House Senior Advisor for Addiction Recovery, Catherine Burgum. From her time as First Lady of North Dakota to her current position as co-chair, Catherine has spent years working to eliminate the stigma associated with the disease of addiction to show people that there is hope for recovery. Catherine co-chairs the Great American Recovery Initiative with Secretary Kennedy, who is leading HH efforts in the Great American Recovery and who will be speaking here later this afternoon. We also have former Congressman Patrick Kennedy here. Among his many accomplishments, he was the lead sponsor of the Mental Health Parity and Addiction Equity Act, signed into law almost 18 years ago. Sorry to date you, Congressman. And also here is Senator Roger Marshall, who is a physician and as a member of the Senate Help Committee has been an incredible advocate for addiction and recovery programs and access to coordinated, comprehensive behavioral health care. We have many other great leaders from across government and the private sector here today, bringing their unique perspectives to these important issues. As a practicing doctor and as the National Health Coordinator for Health IT, I cannot stress how important it is to have technologists and non-technologists involved in this conversation. Whole-of-person care and improved outcomes for patients cannot happen in the vacuum of a single doctor's office, a single electronic health record, or a single peer support group meeting. Healthcare technology must be leveraged to give patients and providers insights across care settings and to build connections between systems that are isolated. At ONC, our job is to make sure that healthcare technology enables safe and appropriate access, exchange, and use of electronic health data for both providers and patients. This means that a patient can download their medical records onto their phone, even if they are seen by 8 different providers. This means that a provider will have a patient's complete and accurate lab results before treating them. And this means that medical providers can communicate with housing and employment service providers to provide access to the 80% of recovery interventions that happen outside of the medical care system. The goal is not technology for its own sake. The goal is to use technology to improve access, affordability, and outcomes in all care settings. Mental health and substance use disorder care are just as much a part of a patient's health care as is health care for a patient's physical ailments. Patrick Kennedy helped pass legislation to make insurance companies treat it this way. Catherine Burgum has been fighting the stigma and shame that has prevented people from seeing addiction as the disease that it is. And Senator Marshall has been a tireless champion for legislation that supports the needs of patients suffering from mental health and substance use disorders. Their efforts are making a difference, and we will continue this work today. Unfortunately, the exchange of health data and adoption of electronic health records in mental health and substance use care lags. My office recently published a data brief analyzing a survey of mental health and substance use care providers done in conjunction with Chris Carroll and his team at SAMHSA. We found that most mental health and substance use care providers do have access to electronic health records, but only half use it routinely to send and receive data about their patients. With Secretary Kennedy's leadership, we are taking steps to change that. Together with SAMHSA, ONC launched the Behavioral Health Information Technology Initiative, a $20 million investment funding nationwide pilot programs with 45 exchange partners across 9 states. The BHIT initiative deploys 3 main work streams. First, it tests behavioral health specific data elements in real-world settings. Second, it pilots the exchange and use of these data elements in and across care settings. And third, it develops resources to scale the behavioral health data integration nationally. The initiative looks at the integration of treatment by acute medical providers with the services provided by housing, employment, and community health agencies. It looks at developing methods of computable consent so that sensitive health data can move privately and securely across electronic data systems with the proper patient consent. And it looks at leveraging technology to manage transitions of care so that patients do not fall through the cracks after acute care episodes. BHIT is a critical step towards breaking down the barriers currently impacting the interoperable exchange of behavioral health data across the care continuum. As ONC and the rest of HHS continues to work under Secretary Kennedy's leadership to drive the Great American Recovery, the insights and experiences you all share with us today will be crucial for our report writing and for understanding where gaps remain and for informing our future policy. Thank you again for being here today, and I look forward to candid and productive conversations. Thank you. So now I'd like to give the folks on the panel the opportunity to introduce themselves, tell us a little bit about yourselves and what your hopes both for this panel is and generally for the treatment of substance use disorder and mental health challenges. Actually, I'll start with you, Catherine. Please tell us a little bit about yourself.
Good morning. Super grateful to be here with you all. I am a woman in long-term recovery for over 24 years now. And I'll tell you a little bit more about that. No, we're going around to introductions first, right?
Why don't you tell us a little bit more about it?
Okay. Do you want me to do my whole speech?
You don't have to do your whole speech. You
Okay.
can give us a brief intro.
Okay. So I'm in long-term recovery, and my struggle with addiction started when I was in high school. Most of my life, I was struggling. Started when I was in high school. I guess where I would love to start with is just gratitude for everyone being here. And, I think that this disease is something that is decimating generations of people across our nation. So it affects me because I was someone who started drinking when I was in high school. I had my first blackout in high school. I started drinking because I had voices in my head that would tell me I was stupid. I needed to be perfect, and I couldn't make those voices go away. And then I took my first drink in high school, and they disappeared. And I was like, this is it. It's the solution. It's the answer to all my problems. And but then I had my first blackout in high school. And then I struggled with addiction to alcohol for over the next 20 years. I can share a little bit more in a while, or do you want me to just do my whole thing right now?
Well, I
So I'm
think
happy to do that.
I think that's a very powerful introduction. I'll ask you to share the full story in a little bit.
Okay.
But you know, the generosity that you're showing in sharing your experience and understanding that sharing that experience can help others with addiction and recovery find their pathway to recovery. It's very powerful, and it's really a gift to all of us, and I can't thank you enough for that.
Thank you.
Congressman Kennedy.
Thank you so much, Dr. Keene and Catherine, for your leadership, and Senator Marshall and all my friends and colleagues who are pulling together an opportunity for us to address really the biggest, not sexy part of our challenge, which is data and interoperability and information technology. But in the very title, Dr. Keene of Office of National Coordinator, that's what we need. We need a national coordinator because what marks our illness is fragmentation and duplication and waste and awful outcomes because we've never deployed what works. But when I hear Dr. Keene talk about including those non-medical pieces to recovery, I'm excited because I believe, as Secretary Kennedy has said, that this is a threefold illness. As we say in recovery, it's a physical allergy, a mental obsession, and a spiritual malady. And as a threefold illness with a three-legged stool, you don't pull out one of the legs of the stool and expect the whole system to stand up. It needs all three. And the idea that we can start to assess these non-medical interventions for their value is really exciting to me and, frankly, my friends in recovery, because we could get another pill that can manage some symptoms, or we could get a stable place to live where we can develop new neural pathways of thinking and behaving because we had the support to really dive into our recovery, which includes a community support, a spiritual support, and, of course, mental health and addiction support. But none of this can be done in isolation, and that's why this idea of a national coordinator, all of your help in putting together pilots around the country for data exchange where we can test what works for whom. And the really exciting part about this endeavor is bringing personalized medicine to people with mental health and addiction issues. Every other area of medicine has standards of care except for mental health. You have cancer, you have cardiovascular disease, you have diabetes. No matter where you go in this country, you can expect to get standards of care, except for us. So wherever you show up, you're subject to the vagaries of where they are in delivering evidence-based treatment. And frankly, I'm here to tell you, over half the clinicians in this country, no fault of their own, but do not deliver simple cognitive behavioral therapy, which is the evidence form of treatment, because they had never gotten that kind of specified type of training that's appropriate for the clinical diagnoses that they're treating. And it's not a one-size-fits-all illness, even though to this day we treat all of these diagnoses as if they're the same. Now, in general, they all benefit from some of the same elements. But like every other disease, like specific types of other illnesses, we do not have anything close to personalized medicine, let alone implementation of standards of care. So we need that. When Senator Marshall, when I was in Congress, we worked to try to get the electronic health record to include mental health and subsidize behavioral health providers so that they could afford to put the infrastructure in place to be able to do this data sharing. We never were successful to doing that. I had the chance to talk to Theo Merkel from the Domestic Policy Council. He said, I don't think the administration is going to dive in and subsidize these big technology companies anymore. So we have to come up with an alternative. And frankly, the president's transparency law and transparency rule also gives us another tool to assess what's working and what's not. And I'm proud to say the Kennedy Forum just released the Parity Index, which uses President Trump's publicly available data, thanks to that law, and assesses where all insurance companies are in terms of their claims data and what they have in-network versus what they have out-of-network. Now we got to dig into that same accountability when it comes to providers. We have a lot of stranded costs in the medical system. Those costs are not getting people better, as the Secretary has said. We have a goal of getting chronic illness addressed in this country, and at the end of the day, what I hope can come from this is that there's no MAHA without mental health. You cannot treat any of the chronic illnesses that are the goal of this administration if mental health is not integral in terms of the treatment of those illnesses. And I'll conclude with this. I am a person in long-term recovery as well. I've been at 8 different rehabs. I racked up every kind of bill in the emergency room you could rack up. And I will tell you, in the last 15 plus years I've been in long-term recovery, I've not had to visit the ER once. And I tell my Horizon Blue Cross plan in New Jersey they ought to scratch a big check to my 12-step recovery group because that's been the key to me not ending back up in the ER. Save the system millions of dollars in the last 15 years. And I believe that while we're coming up with the data help us make better decisions, let's also not wait to do what we already know works. Let's do specialty coordinated care as a mandate. Office of National Policy Personnel, we ought to put that in the RFP. Let's do collaborative care codes. We already know that is essential to integrating primary care and mental health. And frankly, 80% of the antipsychotropics, antidepressants, all written by primary care docs, often with no input from specialty psychiatrists and the like. So let's do those things we know work while we're building the infrastructure to understand new ways of making the system work even better. Thanks for letting me share.
And thank you for sharing. Those are very powerful words. And what I can say is it is our goal that where we have had fits and starts before during this administration, we're going to actually cross the finish line. The only thing I would quibble with that you said is at the beginning you said that data is not sexy. As the guy who oversees health data, I would say it's very sexy. Senator Marshall, you've been a tireless advocate for patients with mental health and substance use disorder specifically and for patients in general. Love to hear from you.
Sure. Thanks, Dr. King. Thanks for hosting us. We lose more farmers every year to suicide than farm accidents. Let me say that again. We lose more farmers every year to suicide than farming accidents. On the other end of the spectrum, we have an epidemic of mental health issues in children, and of course that's going to lead to more abuse as well. We have to get at the root of the problem rather than just throwing new medication at it. I want to just stop and praise the things that are working. On the farmer side of this, Kansas State Extension, Kansas Farm Bureau, Kansas Corn, the ag lenders, especially the farm credit institutions, they know the at-risk people. They know who the at-risk people are, so we're trying to identify them and then remove the stigma of getting mental health. Now, how do you do that? Look, if I pull up in my Dodge Ram truck, everyone in my hometown knows it's me. So, if I pull up in front of the mental health center, there'll be that stigma. But if it's embedded within the other primary care clinics, then people are there, maybe I'm getting my blood pressure checked, So what's working in Kansas are our CCBHCs, Certified Community Behavioral Health Clinics. We have 28 of them. And they've embedded primary care within those clinics. And it's bringing MAHA to people where they are. Bring in the nutritionist, bring in the food bank, bring in WIC, bring in nurse coaches. So those are working along with our community health centers, FQHCs. We have 32 of those, and I bet there's probably more than that in the number of clinics. And then we have rural health clinics that are subsidized by the federal government as well. And I have a saying, if you can't measure it, you can't manage it. So right now we have 25 different EMRs and 25 different paths, and it's how do we bring those all into one entity? It's my belief that we need one EMR and we need one dashboard that works for all of them. I mean, it's got to be so simple. Look, I led our hospital through Meaningful Use 1 and 2, as well as our doctor's clinic, the worst chore I've ever had in my life. And the only thing sure about whichever record you picked as a doctor when the federal government threw money at it is that the doctor switched in 3 months because they didn't like that one. So throwing money at it is not the solution. Whether you're a veteran or you're a soldier or you're an employee of the government or you're getting health care through a rural health clinic or through CBOCs or CCBHCs, we need one EMR. They never are going to communicate with each other. The makers of these do not want them to communicate to each other. The federal government has to say, this is the one, and if you don't communicate with it, you're done, and we're gonna, and you owe us money. That would be my attitude towards this. We can't be a slave to the data either. We took nurses off the floor to turn them into data entry people with Meaningful Use 1 and Meaningful Use 2. So it has to be really simple. And you know, I've been asking my community health centers for 7, 8 years to give me one dashboard. You know, to me, mental illness is one of the 9 chronic diseases that drives 85% of the spend on healthcare. So mental health needs its dashboard, just like hypertension needs a dashboard. And guess what? People with mental health may also have diabetes and hypertension and poor nutrition. So I think that let's not reinvent the wheel. Let's not start another program. Let's accentuate what's working and bring them all together and rely on these beautiful numbers to help guide us. I say if you've seen one community health center, you've seen one. And some are great and some aren't busy, but we should be standard metrics that is so simple that the 7-second attention span of a senator, which is even less than an orthopedic surgeon, could look at this dashboard in just a matter of seconds and say, this clinic is doing a good job. Thanks.
Thanks for those powerful words, and I think that your experience as a physician and as a senator and policymaker really allow you to understand how the rubber hits the road with the policies that you make. And maybe later we can discuss what the attention span of an OB-GYN is compared to those of the orthopedic surgeons. Dr. Klein, you are the head of ARC. Please tell us about yourself.
Yeah, hi, I'm Roger Klein. I'm a physician and an attorney, and I direct the Agency for Healthcare Research and Quality. So listening to Patrick's comments really were inspiring because what he's talking about is exactly what our agency does. I'm a native Ohioan, and so I've seen what the opioid crisis has done in our state. It's devastated, especially our rural communities. But our agency looks at finding out what works and what doesn't. That's our mission. And then we make sure that the knowledge is safely implemented, that it's effectively implemented, and that access is provided for all. And that's what. So what you're speaking about, you know, in terms of behavioral health, we have primary care. You mentioned we have what's called our Integration Academy. And that's dedicated toward bringing behavioral health into primary care settings. And so we have an entire program centered around that. And then we do a lot, both in hospital and outside the hospital in terms of quality. And then we're getting into we've done some level of effectiveness work in this area, and with your inspiration, we're going to be doing more. So that we can really find out and understand what are the best ways to manage people, the best ways to treat people, and then make sure that that's actually done. I mean, we work at the bedside. We're right there implementing care. We're not doing high-level research. We're not looking at receptors and all kinds of things. We're not doing basic science. What we're doing is we're implementing. We're doing research on the best ways to implement medical care and improve outcomes for everybody.
Thank you, Dr. Klein. Mr. Carroll.
I'll see if I can bring the room down a little bit after all those dynamic speakers, and that's definitely a possibility. Thank you, Senator Marshall, Tom, Ken, Carissa, all my colleagues around here, especially Patrick. I was thinking about this over the weekend and my remarks, and I thought back to one of the first things I did in my professional career at SAMHSA is I wrote an article, I published an article in the International Journal of Mental Health called Information Technology and Performance Measures as Transformational Strategies. And I went back and I read it. I was right. They are. But the problem is I wrote it in 2005. So we've been talking about this for a long time. And I'm excited because we now have the opportunity to actually do something. So, and the time is now, actually. So, the reality is people just are not getting better. We've not made the progress that we need to make. 1 in 6 people have a substance use disorder. A quarter of adults experienced a mental illness last year. A quarter. Among those, nearly half had a substance use disorder as well. And too many people that need treatment do not get it. And all of this is costing us billions of dollars a year. So there's an economic issue at play here too. This is important work to me. I think everybody in this room, I know everybody in this room, either knows someone, loves someone, or are someone with one of these conditions. That is 100% true. So, through our partnership with ONC, which I'm thankful for, we're working to change this trajectory. We're focusing on solutions that get at the root of the problems. It's not rocket science. It's transactional. It's in some ways easy. I don't understand why we haven't done it yet. But more than that, I'm grateful for the administration's focus on recovery, for Catherine's work. I'm grateful to the Secretary. He has both a professional and personal commitment to recovery. And I look forward to this conversation today. We can take what we learn and use it. So thank you, Tom.
Thank you, Mr. Carroll. And for what it's worth, I think your words are just as inspiring as everybody else's on the panel. And our collaboration both with ARC and SAMHSA has been fantastic. It's really making real changes. So thank you for that. Sam.
Thanks, Tom, and I'll keep it brief. Sam Cardall, I'm one of Dr. Keene's deputies at ONC, and I just want to echo something that Tom said in his remarks, that the Office of National Coordinator, it's not simply about technology for the sake of technology. It's about how technology can improve access and outcomes for folks, especially today's topic, mental health and substance use care. So I appreciate everyone being here and their engagement, because national coordinating is hard when it's just doing it by yourself. You need to coordinate a bunch of people to get real positive outcomes. So thank you.
And we want to thank everybody here for collaborating with us. To Sam's point, Carissa.
Hi, good morning. Thank you very much for having me here. I have, I think, the unique opportunity to be here at the table today. My experience is a little bit different than everyone else's. I've had the opportunity to see this literally from all sides. I grew up in a town of 1,000 people where I had a clinic next to a pharmacy, next to a hospital, next to a therapist. All they had to do was pick up the phone or walk 2 doors down, and all of that information was shared. When I went to college and then I went to my pharmacy to complete my pharmacy degree, I was surprised that not everybody had that experience. And as I went through my career, my heart just got a little bit sadder and sadder every step, where I got to see the system just fall apart. So I'm a counselor here at HHS, and I get to support HRSA, SAMHSA, ACF, and ACL. Unique opportunity. I think that they work in partnership. That means it's holistic care. It's caring for the person from start to finish. I have a father-in-law who is a farmer, and he has lost quite a few of friends to mental health. And so finding a way to not just talk about integrating through EMRs, but also finding ways to make it easier to use telehealth for smart phrases, for dot phrases, whatever it is that we can do within those EMR systems to make it simple to document what they have learned from that person. I have family members that live in assisted livings for mental health. Every time they hit the ER, they start over because the information, the medications that they've been on are absolutely just not shared. I was a director of pharmacy at an academic medical institution when we did a rip and replace of our EMR system, and it was a really big conversation at that time. Do we put the mental health information in the same EMR as everything else? And at that time, we literally thought there were some rules that didn't allow us to do that we would get in trouble if we did that. So some of that really is just education, and I appreciate the conversation today because I do think we can do it better. I started back in the day when you would discharge somebody from the hospital on Coumadin. The physician didn't know, the family practice physician, maybe what the INR was when they were discharged. And so understanding how they should adjust those medications, we figured out how to solve it. We did. And that was before we had electronic medical records that spoke across all of the different disciplines. I do believe we can do this now. And I think it's individuals in this room and on this panel that are dedicated to it. We will see it happen. We will.
Thank you. And I appreciate the comments of folks who live and represent rural communities. I had practiced in a rural community for 6 years, and I know the specific challenges that they face, even above and beyond the challenges that all of American healthcare faces. Mr. Callahan.
Thanks, Dr. Keenan. Yeah, just will echo what everyone has said, the gratitude, and thank you everyone for being here. My name is Ken Callahan, head of policy for Secretary Kennedy, and this has been a top priority for him. He's asked every agency at the department to see what can be done, and he's already, as you've seen, he's already announced a number of different policy announcements on increasing sober housing services to working more with faith-based providers, but all of those initiatives are going to take better data and better coordination, and it's very imperative that all the providers and all the patients have the best data that they have. So this will fit very well into the Make America Healthy Again initiative, and as Patrick mentioned before, they go hand in hand, and it's going to continue to be a top priority for the Secretary moving forward. Growing up in Ohio, I had too many friends that suffered from this, either getting access to opioids that they weren't prescribed or being, getting addicted one way or another. So seeing the progress that's been made is good, but to Chris's point earlier, there still needs to be a lot more progress. So this is going to continue to be a top priority, and just happy to be part of the conversation today.
Thanks, Ken. Mr. Krugen.
Thanks. It's a privilege to be here. So I'm an internal medicine doctor. I trained in the primary care track and firmly believe that PCPs need to be a part of this solution. I still see patients with addiction medicine. Can you guys hear me? Okay, good. 1 day a week, I see patients with addiction in a rural safety net clinic. And then I'm the deputy secretary at the Louisiana Department of Health. We don't need to look far to see the implications when we can't meet the need of our patients. I was up late last night sorting through this horrific shooting in Shreveport. I think at the same time, for every one of those instances, there's incredible examples of durable, long-term, dramatic recovery, and it's all about helping folks move into that second category. So looking forward to learning from folks on this panel and sharing a little bit more about what Louisiana is doing later.
Great, thank you. Tracy.
Good morning. Thank you so much for having me here. Tracy Gruber, the Executive Director at the Utah Department of Health and Human Services. This is a data conference, or roundtable, so why this is so important to our state starts with the data. We have been looking at our all payers claims database. In the state, we know that we have 20% of our adults having behavioral health challenges with the diagnosis. 24% of our youth have a high need for mental health treatment, and 30% are living with a mental illness. We know that this is incredibly important. Also, unfortunately, high rates of suicide and how you address those issues. And we also know that the relationship between behavioral health, physical health, and outcomes is interlinked. And I'm honored to be representing a state and a department that has the ability to bring together an individual holistically from their behavioral health needs and their physical health needs, have the resources to bear to address those and improve outcomes. And I'm so grateful for this convening today, because when us at the state level have to balance the various divisions and entities within HHS and the funding sources and all the different requirements, to have so many of the HHS entities here today for this conversation gives me hope as an administrator at the state level that we're going to solve this, because the only way we're going to be able to do it is by working together. I also have a personal challenge with mental health that started when I was in college, and every time I go to the doctor, I have to have the same conversation. I'm blessed to have good health care, and my profession and my life is the result of having that good health care, and I think everyone should have it, and having a conversation about the non-sexy part. Dr. Keene, I'm with you. I think this is a critically important element that needs to be resolved, and really hopeful for the start of that happening today. So thank you.
Thank you. And we know that Utah and Louisiana are very forward-looking states on these issues and on the issues of technology generally. Ms. Moretti, you want to tell us about Ohio?
Well, it sounds like there's lots of Ohio love in here today, so that's unusual, but amazing. I'll take it. I am the Tia Marcel Moretti, the director of the Department of Behavioral Health in Ohio, which is a standalone cabinet agency representing 6 state psychiatric hospitals. So that's over 1,000 patients in our hospitals at any given point, in addition to all of behavioral health in terms of addiction, mental health, and SMI. And as many know, Governor DeWine made behavioral health his priority within the reflecting of his first 3 executive orders. One was to create Recovery Ohio, which is an agency that coordinates all the agencies to take efforts toward recovery in Ohio. And then the next was Children's Initiatives, doing the same thing, having us all rowing in the same direction and collaborating as sister agencies around children's issues. As we know, so many were victims of and continue to be victims, as is reflected in youth mental health, of the opioid epidemic. And then the last was to create an appointed position for the Deputy of Prevention Services. So just marking that these were those priorities for him. And as we round out in less than 200 days left in the administration, I'm honored to have served multiple times. I'm a licensed social worker, so a clinician and a certified prevention consultant. My background, in addition to counseling, has been in Medicaid as a senior advisor in private equity in their healthcare portfolios, as well as an executive at an MCO. So when I was asked to come back and lead this agency, I'm deeply passionate about increasing the business acumen of behavioral health, because healthcare and behavioral health is healthcare, but healthcare is a business. And we've been able to justify outcomes and metrics in many other areas, just as you had said, sir. And why can't we expect that in behavioral health? And often I see that we are paying for activities and not outcomes, where if we could elevate our data to a platform that was interoperable, we could operate in a grant environment, much like claims adjudication, so that we can see the whole picture and not have the blind spots of transition of care and be able to calculate total cost of care in grant-making environments. So needless to say, a little bit passionate about making this a business enterprise, and largely driven by having been born in withdrawal and told that I would be developmentally disabled, 3 stints in foster care, and then ultimately being homeless and alone my senior year in high school. So I'm here because these stories matter, and my mom didn't get what she needed, and largely that's because there were no accountabilities in this system. So thank you so much for having Ohio. Thank you so much for having Ohioans around the table, and I'm so looking forward to being a contributing partner. Thank you, Dr. Keene.
Thank you. And I just found out that Ms. Moretti's family owns the Moretti's restaurant, 2 restaurants in Columbus, Ohio, at least one of which I've eaten at before. And I suggest that we all convene after this at Moretti's and have a discussion about how sexy health data is. So thank you, everybody, for those wonderful introductions and for telling us what your investment in these activities are. Now I'd like to go around and ask some folks specific questions, and I'm going to start with you, Catherine. You were the former First Lady of North Dakota, and you are the Senior Advisor at the White House for Addiction and Recovery. Would you tell us your story?
Okay, sure. You know, so great to hear everyone around this table and to see everyone here so invested in this topic of mental health or addiction, which is really just health, I believe. And so anyway, again, just I'm starting to call it Mega Maha because Maha is really everywhere, right? And it's in the data, it's everywhere. So Secretary Kennedy says that addiction begins in isolation and ends in reconnection. And, you know, I did live that. I started to share my story, but I almost didn't make it to the second half because at the end of my drinking, I was suicidal, and the shame and stigma made me think that I didn't deserve to get help. And so, you know, I talked a little bit about my story starting in high school. And, you know, and that I'm in recovery now long term. But what happened for me was I was out walking. At the end of my drinking, I didn't know what else to do. I was trying to stay sober. I couldn't do it. I'd been to treatment. And I just didn't have a lot of faith. I wasn't part of organized religion, but I knew there was a God. And I just said, hey, if anyone is there, I need help. And I have been sober since I uttered those words. And so I love that this administration has faith as a part of what we do and what everybody's doing, because it was a big part of the reason why I'm here today. And, you know, when I became First Lady of North Dakota, I'd been in recovery for 15 years, but I didn't talk about it. So all those years of struggle and being in recovery, nobody knew, you know, and I didn't talk about it, but it was the height of the opioid crisis. It was the first Trump administration. And I decided that, you know, it was going to take some courage, but if I could help one person by sharing my story, it would be worth it. So I opened that door, a bunch of weight got lifted off my shoulders, and then it opened 1,000 more doors and led me to here, seated at this table with all of you, working on these really important topics. So when I became First Lady, I decided to focus on eliminating the stigma of addiction. So we started something called Recovery Reinvented, which was a one-day event solely focused on stigma and eliminating stigma. And it was all about storytelling. And we had scientists and a bunch of other people coming to that event. And that turned into a movement in our state. My husband and I emceed it every year for 8 years. And I wasn't sure if it was working until the first maybe 2 years into doing it, the second or third year. Someone on my team said these people wanted to meet with me, so I did, and they had come to Recovery Reinvented, and they were sharing the story with me of how they revived their son at their home with the Narcan that we trained them with and gave them for free. And so I thought, wow, that's the one person, you know, that got help. But then at the end of my being First Lady, this wonderful mother and her 3 kids, and then her mom, the grandma, all came up to us. It was Halloween. We were giving out candy at the governor's residence. And she said, you know, I really wanted to be here and meet you, this mother of these 3 kids. And she said, because my mother brought me to Recovery Reinvented, and I couldn't get sober, and I lost my kids and everything. And at that point, she was now in recovery for 4 years and has her kids. And it was just, you know, I was like, wow, you know, to see these people bringing their lives back together because of this event that we started to do. So that was, you know, fantastic. People are talking about statistics. And many of you have heard this one that from a 2024 survey that says 40.7 million Americans with substance use disorder, 95% didn't perceive they needed the treatment, and 50 to 70% of that is driven directly or indirectly by stigma. And stigma isn't a side effect of this disease. It's the disease's most powerful ally, which is why I'm so grateful that President Trump created the executive order establishing the Great American Recovery Initiative to fight this. It directs us to focus on a culture that celebrates recovery, because you can't coordinate care for people who don't believe they deserve it. So in North Dakota, related to stigma, we created 3 pillars. Storytelling, which I've talked about, but we measured stigma in our state because people were saying, I feel like, things are changing. More people are talking about addiction. And so I was like, well, feelings are one thing, but data moves the needle, gets funding, and creates awareness. So over a 3-year span, just through storytelling, without any taxpayer dollars, we reduced stigma by 20%. So and then I met with the head of the CDC during the first Trump administration. I'm like, you guys are the surveillance team. You should be measuring stigma in every single state across the nation. He didn't do that, but he said he would think about it. But anyway, then the other thing we've done in North Dakota, what we did was, because we're a 50% rural state, we're never going to have services for all the people that needed it across North Dakota. So we doubled down on the peer support program. And today we have over 2,000 peer supports trained in our state. We have 5 tribes we share geography with, and a significant majority of the peers in our state are from the tribes because their services are so significantly lacking. So I love this. I love to say, which we should have a T-shirt made with this saying, that lived experience is a credential, not a disqualification. Then we created another program called Free Through Recovery, which was funded by the state to reduce recidivism, and it paired peer supports with people coming out of the criminal justice system. That was a super successful program in our state. Because we legally discriminate against people with felonies in our country, and they can't get a job, and this peer support opportunity is so important. And from the technology front, in states like North Dakota, with Recovery Reinvented, we were able to broadcast that behind prison walls. People in Portugal and South Africa saw that program. So technology is hugely important. Telehealth is so important for rural states. So from that perspective, technology is a big tool that we used in North Dakota. But let's move to the Great American Recovery, which I'm so excited about. And I'd love to thank President Trump again for signing the executive order. He used that authority of the presidency to declare what every person in recovery has needed to hear from the highest level of government, that addiction is a chronic, relapsing, lifelong disease. It's a chronic disease. And it's in the executive order. So from the highest office in the land. And, if we don't treat it, it's a fatal disease. So it's like diabetes and all the other chronic diseases. So, so for those 95.6% of the people who didn't perceive they need help, when the President of the United States declares addiction a chronic disease, the word disease itself helps to eliminate stigma. The disease framing for addiction can reduce stigma-related barriers by 20 to 30% as compared to disorder. So anyway, when we're going to focus on the full continuum of care with Great American Recovery. We talk about integrating prevention, early intervention, treatment, and recovery supports and reentry. We try to solve addiction at the crisis moment. And then that's when we get involved, and then we focus on all the consequences, and we layer and layer and layer and layer programs on top of the consequences. And that has to change. This is a chronic disease, so we need a full continuum of care focused on a chronic disease model. And also we need cross-agency coordination, which is exactly what we'll be focusing on across cabinets. And then the other part of the executive order talks about celebrating recovery. So the more we do that, the more we lift up the people in recovery, the more people will see that people do recover from this, and they lead lives, very successful lives, and they all can look just like you and me. So, one of the things I've learned is that 113 million people in America are affected by someone else's disease and someone else's addiction. 113 million people. And then there's 48 million people with the disease of addiction. So add up the numbers, it's half our nation is struggling because they're impacted in some way by the disease of addiction. And so we are going to focus very heavily on chronic disease because that is, in my opinion, what needs to change. I mean, it's a big lift. Obviously, everybody's talking about codes and this and that and how do we do it, but it's a chronic disease. Let's just call a spade and start focusing on that and change our healthcare so these people are fully wrapped in a continuum of care and there's no gaps in the system for people to fall through. And so anyway, I'm grateful that I have the opportunity to co-chair this initiative with Bobby, two people with lived experience. Anyway, I just sometimes I wake up every morning saying, I can't believe I have this opportunity. So we're going to do our best to save lives across America.
Well, I think I speak for everybody when I say thank you for turning your lived experience into something that can be leveraged by other folks facing the same issues. It seems like you did extraordinary work when you were in North Dakota and are now scaling that up nationwide, and we can't thank you enough for it. I mean, even that one life saved by the interdiction of Narcan is an entire family and life changed. And maybe it's not 119 million, it's 118,999,000 that are impacted by this disease, and we can't thank you enough for your contribution. Patrick, you also have lived at the intersection of lived experience and policy. When it comes to the exchange of health data, in what ways do you think that behavioral health is still falling short, and what are the ways that federal and state leaders can change this?
Well, first of all, let me thank Catherine for your remarks, especially as it relates to this is not just a healthcare issue. When you brought up the criminal justice system, we all know that unfortunately the largest psychiatric hospital systems in this country are county jails and prisons. And that is because we have not done an adequate job at understanding the intersection of a public health model that leaves out the total cost of care, as Secretary Moretti said. If the total cost of care is not just the medical cost, it's the criminal justice cost. It's the foster care costs. It's the housing, human services costs. Lots of these costs are spread throughout the government, federal level, state level, county, and local. If we were ever able to truly track those downstream costs of not adequately moving upstream and preventing these illnesses, there would be a no-brainer in terms of moving the dollars away from this acute episodic treatment system. As I said, Catherine, 8 separate rehabs, huge costs. After each one, no coordination of care for me. My docs never understood. This was before the prescription drug monitoring program, too. So I could, to the pharmacy issue, Carissa, get my opioids filled, Oxycontin everywhere. But when I first went to the doctor to get my checkup, they'd ask me, is there a family history of cardiovascular disease? Yup. I got Lipitor in like my 30s. Okay, because they wanted to save my life when I'm in my 60s and 70s. That's a healthcare system that wants to go upstream. When I go to my doctor, he takes one look at my Irish face and he says, ooh, I bet you could use a dermatologist. And he's right. I've got a lot of risk factors there. But the doctor never asked, do you come from a family of addiction? Imagine if you were able to truly track these, as you said, Senator Marshall, in a totally unjudgmental, unbiased, purely normative way, and say, okay, you're high risk. You come from a family of addiction, trauma, major contributor. and Peter. Our hearts go out to Louisiana, all the people, all those parents and siblings and children who are suffering today because of that horrendous trauma. I guarantee if we don't treat them early and wrap our arms around them, the ripple effect of that trauma will be felt not only throughout their lives and their families' lives, but their whole community's lives. And Secretary Kennedy and I both understand that. The trauma of his father's assassination, my uncles, and so forth, have made their way through generations of my cousins. And so we had better in this nation address this as a family issue, not just an individual issue. And all of this is possible now that we have data at a level that we've never been able to do before, so we can track population data in addition to individual data. And that, Dr. Keene, would be one of my recommendations to that point of surveillance, Catherine, about CDC. We know who is at risk. Why aren't we moving upstream and risk stratifying those populations? So we're not doing a one-size-fits-all and putting a whole bunch of money. Focus the money where we know it'll do the most good. And so if we're not tracking those highest utilizers of our jails and our Medicaid system, the taxpayer's paying for this. They're just paying for it through different pockets, so no one gets the complete picture. So, Catherine, one of the things that I hope with your leadership, to your point on the criminal justice side, we can begin with pilots that aren't hard to start with. We don't need Dr. Keene, you to jump in just yet. There's enough data right now to tell us what we should be doing while we're working to enhance our ability to collect the proper data more writ large. But anyway, I felt so grateful, as you said, Catherine, to be part of this initiative. And I can tell you from personal experience, there's so many areas that we need to start to connect the dots, and I know everyone's echoed that. So I'll shut up now and let others. There's a famous phrase that everything's been said, but not everyone's said it yet. But as Senator Marshall, you said, you can't manage what you can't measure. And how are we going to measure things if we don't have the data? So it comes back to that. If we want to save money, we need to spend money on getting the infrastructure in place. We don't have to spend a lot of money, but we have to understand that if we put an infrastructure in place to track this data through Dr. Keene, your leadership, and Dr. Oz, frankly, because we need where the money comes from to be pushing these solutions. So I'm excited to be part of this and thrilled to join all of you in trying to push it forward.
Thank you, and I think what you've just said hasn't been said before, so I appreciate you saying it. Thank you. Senator Marshall, as a physician representing a largely rural state, what are some of the specific challenges regarding access to mental health and substance use care in rural America, and how do you see technology playing a role in addressing some of these gaps?
Yeah, thanks, Dr. Keene. I mentioned farmers' health and farmer suicide earlier. I want to talk about children just a little bit more. Whether you're in rural America, urban America, suburban America, we're seeing an epidemic of mental health challenges in our children. Encourage everyone to read The Anxious Generation if they haven't, and I think social media is a big part of that. I'm on this mission to salute people that are doing a good job, and I want to stop and salute Facebook and Meta and what they're doing with Instagram. That they have, and I'm going to use my notes here, teen accounts with built-in restrictions, stricter content controls of PG-13 style, limits on risky interactions, AI enforcements against predators. And I'm just calling on all social media, especially the TikToks of the world, to do the same. But I don't have confidence, and that means Congress needs to act. And how do we set those guardrails without, hurting people's privacy? But it's that bad, again, regardless of where you are. So I think that would be one issue. Then speak to OB, my specialty. I delivered a baby most every day for 25 years. When I was practicing, the largest cause of maternal deaths were the typical things like hypertension and stroke and embolic phenomena, hemorrhaging, infection, But today, now remember, maternal mortality is measured for a year after delivery. The number one killer is suicide and drug overdose / poisoning. Fentanyl is typically poisoning. Those are accidental deaths. They're not trying to overdose, right? So that's the big picture again, whether you're in rural America or in urban America. I think we have to continue to accentuate the positive, what's working, work with those organizations that I described. But remember this, people solve the problems. A loving nurse, a caring doctor, nutrition coaches, they're the ones that solve the problems. Data, we don't want to be the slave to data, is what I'm trying to say. That's why I go back to my dashboards, a very simple dashboard as opposed to we have too much data, and that's when we're going to bring in AI as well. And I wanted to emphasize that I've yet to meet a doctor yet that likes their EMR. And the doctors now spend their lunch breaks, they take records home and spend hours a day because of the EMR. They become a slave to that data, but it really has not improved healthcare. You know, it starts with a very simple problem list. My old paper records, I kept a problem list on the front page. You know, tobacco, osteoporosis, hypertension, whatever it was. And just in a snapshot, I could walk in the room and have all that, and then look at the patient and sit down and look him in the eye and say, tell me what's going on. And instead, young doctors and nurses, this is what they're doing when the patient's talking. So it's so sad. It's so sad. So don't let us become a slave to this data. Keep it simple. Use AI. Use AI to bring the data, to collate the data, to make it meaningful, and then to make suggestions to the practitioners. Give it to those nurse coaches. My best person I ever had at diabetics, and we had a very large OB diabetic clinic, unfortunately, was an LPN. And it wasn't because she knew more about nutrition than anybody else. It's because she loved on those mamas, more like a grandma or a favorite auntie, and coached them up. You know, you're expecting me to talk about telemedicine, which is important. And telemedicine works after you have the relationship. But it starts with that relationship. And we have to, again, embed all of this together. That's why it works in rural America, in urban America, and suburban America, is embedding it all together. Rural America, we have the internet connections now. So don't let them tell you otherwise. There's a few places where the phones don't work, but there's places that almost anywhere across the state of Kansas that you have access to the internet. But I think it's more that, the challenge is engaging that farmer, is removing the stigma. How do you start the process? That's the challenge. How do we empower them? And then how do we bring in the rest of the MAHA, the nutrition coaching? I don't care what mental illness you have or addiction you have. If you have poor nutrition, it exacerbates it. So treating patients, this whole patient, embedding them all together. And again, those pieces are out there. How do we collate them? It's got to be one EMR. This has to be the dashboard. And if you don't want to comply with that, then we're not going to give you federal dollars. Thanks.
Senator Marshall, thank you for calling out an area of mental health that is often forgotten, childhood mental health. And thank you for doing so much in the Senate to see that this issue is addressed. And I can tell you that at our agency, we take very seriously the burden that EMRs impose on patients. I still practice, and so I get to go from being the person who regulates the EMR to the person who suffers under the EMR on a pretty routine basis. Mm-hmm. So we're taking it very seriously, and we appreciate your attention to it.
Suffering's the right word.
Dr. Klein, how can we use technology to better integrate mental health and substance use treatment into primary care settings, and why is it important for improving quality and outcomes for patients?
Yeah, thanks, Tom. That's a great question, and I would point back to what Senator Marshall just said about relationships. And I think the importance stems from that relationship. And so as Congressman Kennedy said, 80% of antidepressant or psychotropic prescriptions are given in primary care settings. Most patients with depression are treated in primary care settings, but most patients actually are not treated with either drugs or medicines. It's a gap. Many patients don't refill their prescriptions, and slightly over half return for a second therapy visit. So there are clearly holes here. The numbers for anxiety disorders are even less encouraging. Most patients who are treated are seen in primary care settings, but diagnoses are often missed. It's actually quite infrequent to diagnose an anxiety disorder, even though that's where the patients are seen. And so most are untreated. Substance abuse treatment actually is not common in primary care, and perhaps Dr. Krugen can discuss some of the reasons for that. But I think the principles in terms of technology implementation remain the same for as with other behavioral disorders. And so what can technology do? It can help primary care doctors identify mental health needs early. Key, identify mental health needs early, connect patients to care teams, monitor progress, and then potentially extend access. So looking at the EMR is problematic, but it's also a tool for good. And so we can implement, we can take standardized screening tools, and we can add them, embed them into EHRs to encourage routine screening, just as we do with other illnesses. And then we can use the clinical decision tools that can prompt providers with diagnoses. Hey, this patient looks like they're having an issue, and suggest potential interventions or referrals. Technology can help us bring through registries and dashboards and clinical decision support tools. It can enable measurement-based care if you have to measure it. So that means tracking symptoms, treatment response, follow-up, and risk over time, adjusting care quickly when a patient isn't improving. So all of this technology can help us do all of these things, and this is critical in a busy primary care setting. The primary care doctors nowadays they're called upon to do many things, and it's extremely challenging. And I think technologies are a great friend here. Technology can also support team-based coordinated care. We can have shared health plans, shared care plans, electronic referrals, and secure communication, so that primary care physicians and managers and behavioral health specialists have access to the same information. So it helps integrate the function of behavior. Even if it's not in the same setting, it helps integrate the function of behavioral health with primary care. And telehealth was mentioned, e-consults and digital tools. They can expand access to mental health and substance use services, especially in rural communities or other places where you don't have specialty care. And then, so Senator Marshall mentioned AI, and I think this is really one of the exciting new areas. At least I find it very fascinating. So you can use predictive analytics to potentially identify patients who are, for example, at risk for suicide, or overdose, or relapse. So using AI to analyze the data, we can see patterns that maybe we wouldn't recognize as doctors, and it will enable us to provide better care. As I think was generally recognized, mental health care and substance use conditions are intertwined with physical health. When they're unrecognized or untreated, patients are less likely, for example, to manage chronic diseases. They're less likely to adhere to medications. They're more likely to experience crisis care, hospitalizations, overdoses, or worse. Primary care is where most patients already are, and integrating these services helps improve early identification, continuity, access, and follow-through. All the while, Secretary Burgum, while reducing stigma and fragmentation. So stigma. I think integrating these services into primary care, as you pointed out, and I think others have mentioned, does help reduce the stigma. So at AHRQ, our role in this journey has been to define and test these approaches in real-world settings through research, through our Integration Academy, and through implementation tools that we develop that we give to doctors and health systems and other providers in order to take the knowledge that we've gained and distribute it outward to patients.
Thank you, Dr. Klein. And your point about measurement is extremely well taken. It's something that I look forward to collaborating with ARC on. Your agency has done extraordinary things in physical health, more or less eliminating central line infections over the last 20 years. And under your leadership, I think we'll be able to do the same thing for mental health. Christopher, could you tell us about some of the work that SAMHSA is doing in support of the Great American Recovery? And what role does data interoperability play in improving mental health and substance use care outcomes?
Thank you, Tom. First, I'd like to thank Catherine for all of her leadership. It's been a pleasure getting to know you, and your drive is amazing. So thank you for your work. So this, it's interesting that, you know, recovery's always been a very clear marker for SAMHSA. We've believed in recovery for years and years and years. In fact, we have an Office of Recovery. It's the only office in the federal government that's fully staffed by people in recovery. So this is, you know, we kind of feel like the church kind of turned around to us and said, oh, there you are, right? And that provides us an amazing platform, I think, for SAMHSA. And I think the secretary started that when he came in. He really inspired us. And then the president solidified that through his executive orders on the Great American Recovery Initiative. Just to be clear, through these executive orders and what I've hoped SAMHSA would do is to execute our portfolio to support those initiatives and do that with compassion. And I think we are doing that. This provides us another opportunity to do that, so I'm looking forward to that. We have been, what I have found to be a nice endeavor is working with my colleagues in HRSA and ARC and CMS and HRSA and seeing their commitment and passion as it relates to recovery and the Great American Recovery. That's providing us a lot of opportunity to work across HHS. And that's exciting to me. But I'll mention just briefly a few initiatives. We recently announced $69 million in funding that will directly address the root causes of addiction, including homelessness and serious mental illness, and strengthen community safety by expanding treatment that prioritizes recovery and self-sufficiency. We also dedicated another $45 million to focus on building and strengthening recovery housing for young adults, ages 18 to 24. It's a vulnerable group and one of the largest populations struggling with addiction right now. Part of the Secretary's behavioral health agenda there is a major initiative called the Streets Initiative. That initiative will, and we're still working on getting that out. One of these days, I'm gonna say it's out, but we're this close. It's a $100 million initiative. 8 communities will address addiction and homelessness. We think it will really start to solve some of the long-term issues that these communities have been struggling with for ages. And we really hope that it's a model that we can implement in other spaces as well. part of what we're also doing is engaging the faith-based communities, organizations, and the communities that they serve. Coming from the South, I understand the importance of these communities and the role that they play in helping people, number one, but also addressing addiction and mental illness in very effective ways. So we're looking to expand that collaboration with the faith-based organizations. We have stood up an Office of Faith in SAMHSA as well, which will be good partners with the HHS Office of Faith. Generally, I would say that it's a great opportunity for SAMHSA to highlight the work that we've been doing for a long time in recovery, using the platform that has been created, supporting the Secretary, supporting the President, with Ms. Spurgeon's leadership. We just look forward to what we can do next with, and we have some things planned, so what we can do next. Thank you.
Dr. King, can I say something? And I just hope that we're measuring how we're going to measure success with these as well. You know, how do we know that what's working and what's not working is important? And then how do we communicate that to the community health centers, to the CCBHCs as well? So I hope that these grants lead us somewhere. Thanks.
I'll just add to that. Functional outcomes, Senator, is something we've never evaluated in mental health. We track symptoms, not results, as was said a number of times here. So I love what you're going after here, which is not getting all mired in too much process and focusing more on outcomes. And so, you know, that's our goal here, and I appreciate your bringing that up.
Your guys' points are very well taken, and the beauty of health information technology, as burdensome as it is, it does track everything that happens. And so our BHIT initiative that SAMHSA was kind enough to conceive of and deploy with us allows us to see what has actually worked and what has actually not worked, and we will report that out not just to the community but also to the Senate. Ken, you run policy for the Secretary. From a policy standpoint, what are the most significant levers available to HHS to improve care coordination and outcomes across mental health and substance use care?
So, Dr. Keene, I know we had worked together on interoperability regs in the first Trump administration, and something I know you're implementing now on the standards and how the data is going to flow between providers and electronic health record vendors. But the Cures Act was passed in 2016. One of the key components of that was the enforcement of information blocking, or when healthcare entities are not sharing a patient's healthcare data with other healthcare entities for one reason or another. And so when the Secretary came in and realized that it had almost been 10 years since the Cures Act was passed in 2016 and information blocking was still not being enforced, he had asked, you know, what could we do? What could we do to make sure that patients had their data when they needed it? It's very important, not only in an emergency situation, but also just for management of chronic care. So he had used his secretarial transfer authority to transfer the Office of the Inspector General $10 million to hire new attorneys and other specialists to start digging into potential cases when healthcare entities were illegally withholding information or performing information blocking. And so over the last few months, we have hired a number of new people to do that and making sure that patients have their data when they need it. It's essential for chronic care management. It's essential for behavioral health care, and it's been a main focus of the Secretary, and just really, it was one of his main goals too, and he understands how important it is of making sure patients have their data, not only for chronic care, but also for behavioral health care. So that was one of the first things he's done, and we're getting updates, and we're just making sure that patients hopefully will always have their data when they need it. And I know we're working closely with your office on that as well.
Ken, if I could just say that 42 CFR, I've been a little controversial with my fellows in recovery, but I absolutely believe if we're sharing HIV AIDS data, we're sharing STD data, why in the world can't we share SUD data? And if I'm going into the emergency room unconscious and I have medications given to me by my psychiatrist that they have no knowledge of, and they give me something in the ER that could kill me because of that lack of information, that is a harm that we need to fix. And so to your point, Ken, thank you for really having this effort with the Secretary to really enforce modernization of that 42 CFR, because it's going to be crucial if we're truly to integrate records like we're trying to do here.
And as part of our initiative with SAMHSA, we are looking at computable consent in one of our BHIT pilots, so that the consent to move 42 CFR Part 2 data moves with the patient after they give a single, provable, verifiable consent. So Carissa, what role can EHRs play in improving care coordination between behavioral health providers, hospitals, and community service providers?
Okay, this part I get very excited about. From living it from all sides, as a pharmacist, I truly believe we're in a unique position to see where the failures are and where information slips through the cracks. Academic medicine, private healthcare. I was a deputy in Medicaid for a little while, saw it from the payer side, now get to be on the policy side, and everybody is trying to fix it. There is a tool. It's technology, not always the best. I got politely yelled at by many physicians that did not like the EMRs. Totally get it. The opportunity is in sharing that information. So as the senator pointed out, there are a lot of high risk, high need populations that we are kind of treating as add-ons. It's the youth. And in CCBHCs, FQHCs, there's an opportunity to support them. As the congressman talked about, there is another specialty population that we're treating as add-ons, those that are going through re-entry. You put all of those together, and then you look at that we are treating mental health data, clinical information as an add-on, not being integrated, just an add-on. That absolutely is just perpetuating this issue and this problem. So under the leadership of the secretary, digging in, trying to fix, and I would say revolutionize and be innovative with the CFRs, which are very old, and how do we leverage them to help support that care coordination across. It truly is putting words into action. Somebody might put down that an individual is depressed. They put somewhere else a diagnosis code that might reflect that in a different EMR. They have then a medication that might not live in either of those, but it is in the PDMP. All of those different types of databases for medical information have been supported by grants from the federal government over the last decades. Some of them have been required by statute in different states. What hasn't been required is sharing of that information across all of those technology platforms. Thou shalts, I'm from Nebraska, and so we don't always like governmental thou shalts. What we do like is government saying, let's support you to do the right thing. Care coordination across all of the different technology platforms, across all of the different data elements of somebody's medical record, not treating these things as an add-on is how care coordination can actually occur for all of these patients. They shouldn't be an add-on anymore. It shouldn't be we're going to treat you holistically, and maybe we'll talk about your mental health. Holistic means everything.
And we're doing everything we can to move towards that. So I was told by my timekeeper that we have 30 minutes left in this roundtable. For the remaining 30 minutes, I'm going to turn it over to my colleague, Sam Cardle, who is neither from Ohio nor Utah, nor, but he is from Minnesota. So
then we can just mute his mic.
Yeah, this is sweltering heat for him right now.
I'll suppress my accent for your sake. So thank you, Dr. Keene. And one thing I'm going to turn to for a second here is we've gotten a great job getting the national perspective, but as Congressman Kennedy was saying earlier, mental health and substance use care is highly personal, and I think that getting a perspective, not just from the federal level, but from the states is incredibly important here. So I want to start with you, Tracy. Can you tell us, when it comes in regards to mental health and substance use care, what's working in Utah that we should know about, and particularly when it comes to behavioral health IT?
Yeah, thank you so much. I think when you talk about what's working and the opportunities, you also have to talk about the challenges, which have been well established here, the data sharing, getting clarity, the room of federal leaders here. So I think knowing where the impacts are at the state level is incredibly important. And we've talked about the small providers being disconnected, not having the EHRs, not having the funds to connect to EHRs, really providing that care independently. And then also the fragmentation of the system. And we always have to remind ourselves that the state and the government solution or providers on the mental health side is just a very, very small part. And sometimes we have challenge pulling that lever on the private sector. The opportunities really are, and what's working well in Utah is that when our department became the Department of Health and Human Services in 2021, when I was appointed, we established the Division of Integrated Healthcare. Used to have a Medicaid division. In my mind, Medicaid is a lever, it's a solution. You have to be able to bring the behavioral health and physical health together and know what that primary payment lever is. We also have approval from CMS on reentry. So people leaving corrections and jails to make sure that 90 days pre-release, we're connecting them with healthcare. That's huge with people who have substance use diseases as well as behavioral health, mental health conditions. I have to talk about the opportunity that the Rural Health Transformation Program is providing to states, particularly in states like ours that have big rural frontier communities, and what that's going to mean on technology for these small providers who don't have EHRs. We're going to have an opportunity to bring them into the systems with FQHCs and using that technology. In Utah, we also have an Office of Artificial Intelligence. It's not in our department, it's in our Department of Commerce. And what's really interesting about it, well, the first regulations that they've established, guidelines they established was on behavioral health. But it's providing a forum to address regulatory issues that could stand in the way of AI and put them in the regulatory sandbox and see if we can test some AI solutions. So that's really exciting on the behavioral health side. The other thing that I'll just mention is the One Utah Health Collaboratives. We're talking about bringing together the private sector with the public sector. This is something unique in Utah. It's a nonprofit that Governor Cox established right at the start of his administration. And that's allowing both the private and public sector payers, providers to come together to deal with things of interoperability, get buy-in, not have the heavy arm of government say, you must do this, but seeing the value of bringing everybody together and establishing things like EHR systems across both sectors is really important. I also just have to bring to light the opportunity that all of us have here, particularly on the federal side, which I always mention, and it's the outcomes. The federal government has a really strong role to help us define the outcomes, as has been mentioned. Paying for strategies doesn't work. We need to know what the outcomes are, and we need the opportunity, because people don't live their lives based on federal funding streams. We need the opportunity to bring those federal funding streams together, be outcome focused, and address the needs of the population. So that's some of what's working and some of the opportunities that we can all leverage here.
Thank you, Tracy. I appreciate that. Dr. Krogan, could you tell us about Louisiana's approach to behavioral health, and how are you leveraging technology to improve outcomes in Louisiana?
Sure thing. Well, we actually have some good news to share at this panel about our reentry 1115. So there was a press conference last week with our governor and the head of Medicaid announcing that we're on track for approval later this year. So that'll be the first of this administration. And I'll come back to how we kind of work through some of those issues. But America's health rankings ranked us 50th again last year. It's no secret that Louisiana has its fair share of health challenges, so we usually don't get invited to panels with Utah and Ohio. But our mental health America ranked us 27th overall in terms of mental health and 32nd in terms of access to care. And I bring that up not to claim victory. In fact, quite the opposite in terms of success. I think the system very much feels broken for clinicians, certainly, and patients in Louisiana. And we spent a lot of time unpacking those two contradictions. How is our behavioral health ranking so discrepant from our overall ranking, and how does it feel so broken despite these numbers? And the short version is we think it comes down to transitions, that for folks that are in care, able to access care, they actually do overall relatively well for Louisiana, but it's the transitions between levels and sites of care that are the most disruptive. I'll just give you one quick clinical example. 3 weeks ago, I saw a woman who had just gotten out of jail, and she was on Suboxone. She told that to the provider. They didn't feel like they had enough information to continue her on her medicine, so she went through withdrawal. And then at the same time, she told me, they started me on this antipsychotic, and it worked really well for me. And I was just asking her, like, so what, do you remember the name of it? Does it start with a D? Does it start with a Z? And I was like, this is so absurd that in 2026, I'm asking her to remember the letter. Maybe the nurse mentioned it, and she heard about it. And so it's those transitions, community to jail to community, rehab to community, jail to hospital, that I think the handoff breaks. And so there's 4 things in Louisiana I'll touch on quickly that we're doing. Our Reentry 1115, our Bridge program, Project Mom, and our rural health transformation. So basically the breakthrough on reentry was able to align with the upcoming federal requirements on budget neutrality. So we're going to use APD funding, rural health transformation funding, hopefully non-deployment broadband funding at some point, and state general fund to build the IT infrastructure essentially outside of the 1115 waiver, so that can be focused on providing services. And we should be the first approval in this administration, and looking at Q3 this year for that to be formalized. Second big initiative is our Bridge program, which is all about getting folks linked to care and initiating care when they visit an emergency department. We would never treat someone with a heart attack, just show up, give them a brochure to a cardiology clinic and say, not start them on a medicine and hope for any different outcome, but that's unfortunately how we treat a lot of overdose visits in the ED. So we're using our managed care incentive program to set up incentives, different tiers, bronze through platinum for hospitals, and we'll reimburse them accordingly based on how much infrastructure they're able to do, but start folks on treatment and get them linked to outpatient care in the health system. Third big initiative is called Project Mom, which stands for Maternal Overdose Mortality. In Louisiana, since 2018, overdose has been the #1 cause of pregnancy-associated death. So to get a different outcome, we need a different intervention. Essentially, this is a large collaboration between our regional public health offices, our birthing hospitals, and our outpatient behavioral health providers to try to make sure no pregnant woman or postpartum woman falls through the cracks. And there's a big IT component to make that sustainable. And the last piece is how we're thinking about our rural health transformation dollars, which are incredible. One of the pillars of our program is a statewide EMR license that the state will own, that we're planning to make accessible to rural health clinics, our parish health units, hopefully even jails and prisons. And so that, I think that just changes the whole game. It changes how information flows at the clinical level, changes how the state evaluates programs in terms of being able to go to true clinical outcomes. So pretty excited for the implications of that program. So I'd say takeaway is that it's the transitions, that we think folks are falling through the cracks. And if we can improve those handoffs, we'll improve the system writ large.
Thank you. And Tia, now moving on to Ohio. I know this is an Ohio heavy panel, so I want to make sure to give you your time.
I love it.
What strategies is Ohio taking to coordinate the medical, behavioral health, and other social services?
Yeah, I think just as a reminder, how we're set up is the Department of Behavioral Health is a standalone cabinet that has a $3 billion budget. a quarter of which goes to operating our state hospitals. So largely we rely on our relationship with SAMHSA as well as the generosity of our General Assembly. And so really bringing an Epic on those 6 hospitals was a game changer for us as a business operation, right? To become a little more lean in government business and centralize those hospitals so at least we can see our patients moving through our own systems. You want me to be louder? Better? So bringing in Epic on our 6 state hospitals has allowed us to kind of practice what we preach in terms of centralizing, watching patient movement, and even identifying opportunities, though slim, for revenue making. That also opened us up to understand that, like you had shared, most of our providers, of course, have EHRs, but many of them are retrofitted or were made only so that they could be affordable to that community behavioral health provider. And so when we went into our budget efforts, we tried to look at an HIE, and it was just a lot to bring the General Assembly along, so we'll have to try again. But I think by modeling that through our hospitals, it's been pretty critical, both in learning the patient journey. The next I want to talk about is very simple in some ways, but it's about beginning with the end in mind, and that was how we built up MRSS. MRSS is Mobile Response and Stabilization Services. This is a 60-minute response for any young person, 20 and under in Ohio, is available all through Ohio now by order of Governor DeWine. And of course, our agency couldn't afford the cost on its own, so we braided our funding with Medicaid. But what made this work was that from the day that we began MRSS in some of our rural counties with the Engage grant through SAMHSA, we had an evaluator, and we had built a simple data management system. This is literally just holding providers accountable for response time and family engagement, and then on the back end, evaluating the family experience. And we were able to calculate to the penny the cost saved to child welfare systems, emergency rooms, other healthcare providers, psychiatric inpatients, and child relinquishment. So it's one program model that, when done thoughtfully with small number of metrics, we were able to demonstrate to our General Assembly the cost savings in a business case for why they should invest to bring this statewide. And we were incredibly successful doing so. And I believe, beyond a reasonable doubt, that it was because we were so thoughtful in making sure that we were establishing ROI and outcomes from the beginning to the end. And then the last, a little not as necessarily as tech savvy, but as we try to bring on our more rural areas to telehealth platforms and broadband, as we look at rural health transformation, and as we look at the stigma associated in Appalachia, rural Ohio, and in our farming communities, we advanced forward with mobile opiate treatment programs. So these are 2 nondescript mobile buses that provide full healthcare checks, but so that folks can receive their opiate treatment, their dose for MAT, and they can do that without having to take Medicaid transportation across the state. They can pop in and pop out. We are simply now awaiting our DEA approval to be able to start operating those buses. So, I mean, if anyone around here knows anyone, it'd be really cool if we could get that approval and start that work so that folks can live, work, play, and heal in their own communities.
Thanks. That's very helpful, and thank you guys for all letting us know what the states are doing. So I think we have about 8 minutes left. So first of all, I just want to thank everybody on the panel. This is really an all-star panel. I know you all have day jobs in which you have real responsibilities and lots of things to get done, and I can't thank you enough for your generosity with your time. So what I would like to do, having heard what the other panelists have said, I would like to call on you all one by one. And in 30 seconds, if you could tell me one ask of the federal government, one ask of HHS that you would have, based on what you've heard, that would make a difference in the next 6 months to a year in the treatment of substance use disorder and mental health problems. And I'll start with you, Tracy. And my colleagues, I should say, my colleagues from ONC are writing these down. So they will be preserved for posterity.
I'm going to stick with the theme of the conference, which is really dealing with the issue of interoperability and the ability to have clear measures within the EHR systems that could be standardized throughout the country, and everyone knows what data they're pulling in and what outcomes are being measured.
Yeah. Oh, go ahead, Dr. Krugen.
Oh, sorry. I'll add the appreciate the continued flexibility in terms of grant funding. I'm sure at some point it's a trade-off between rolling out evidence-based models at the state level versus allowing experimentation, but I feel like states have been able to do some really innovative work, so would appreciate the opportunity to innovate at the state level.
I've thought a lot about this ask because I knew you were going to ask. I'm trying to be very well behaved. I think that it's time to move some of our HHS systems to a VBR environment, value-based reimbursement, even a fiscal intermediary, so that the grant making that we're doing is not so blind. And maybe I'm only speaking for Ohio. I don't think so. But I know that we're sometimes paying for the treatment of the same people, whether or not we want to or not. And I think there are ways that both through the health information technology exchanges and a fiscal intermediary, or even some sort of just these shall be the outcomes that you are grant making for. It would be great to see us get closer to a payer or reimbursement environment in grant making. So any technical assistance.
Fantastic. Patrick.
I'd like us to keep the big picture in mind, to make it clear to people that this is not some esoteric, non-sexy issue, but rather it's fundamental to our public getting better writ large. You can't deal with chronic illness, heart disease, cancer, diabetes, if mental health isn't brought up to speed with its clinical care pathways to ensure that we bring the same rigor of expectation of outcomes to mental health like we do with other illnesses. That has to be our overarching goal so that we can make it clear this isn't just us managing something over here on the side with BH, which is what we've always done, that this is fundamental to our nation's health. And so with that, we just want to support your efforts, Dr. Kane and Catherine's and this administration's, because this is the moment where we finally bring BH up to speed with all other chronic illnesses. And that's what this data is going to allow us to do.
Thank you. Senator Marshall.
I think I've been pretty clear. One dashboard, one EMR, one dashboard for each chronic illness, in this case, mental health, and requiring everyone connected to the government to comply with that one dashboard that measures outcomes. And then we're going to have to pick a most favored nation, EMR, and everybody that touches the federal government has to use that one. I'm tired of Ford's not talking to Chevy and Dodge. It just doesn't work in the real world. And they promised for 20 years, 2008, and there's still no interoperability that's meaningful. Thanks.
And Catherine.
I have two, but I'll make it fast. Adopt the chronic disease model that also includes mental health. Adopt it completely across government, CMS, everywhere, because if we don't change what we're doing now, that's not working, we will continue the generational decimation of families across America because it's not working now. So we need to do something. And we have this administration, which is a unicorn point in time where we have senior people in the administration who care deeply about this because they've been individually impacted by the disease of addiction. And then the other one is the IMD 16-bed exclusion, which don't yell at me because I bring it up a lot, but it's a temporary waiver. It prevents upstream investment. It's not scalable. So although there is a waiver, that it's not a solution to really providing more opportunities for treatment.
So I think I speak for the whole room in saying that this panel was absolutely outstanding. I can see the passion of everybody on the panel, the depth of knowledge, and I appreciate the frank and open discussion. Can we give a round of applause for our panelists? A little housekeeping. We're going to have a 10-minute break from 10:55 to 11:05. There's a bathroom out there, and there's a cafeteria with bad food as well, and coffee. and we'll be reconvening at 11:05 for an Innovation in the Field Progress Report on Behavioral Health Transformation.
All right, good morning, everybody. We are going to go ahead and start our next panel. All right, a couple housekeeping points quickly. So, as you know, the secretary will be here this afternoon. So we will be breaking for lunch. I'm going to do my best to keep us on time so everybody can enjoy their lunch. That third roundtable is going to begin after the secretary's remarks, and his remarks should end around 2 p.m. Okay. If you do leave the building for lunch and plan on returning, please make sure you give yourself enough time to get back through security. That may take you a little bit more time than you think. There is a cafeteria around the corner if you prefer to stay in the building. And if you plan on being here for the secretary's remarks, we just ask that you're in your seats before 2 p.m. when his remarks should start. All right. We lost a few people, but thanks for everyone else for staying. My name is Jason Funderburk. I'm a Deputy National Coordinator, and I'm actually a practicing physician as well. We're going to continue with the theme this morning. I will tell you that if you have young children, and I do, in sports now, they do walk-up themes for a lot of things, and in baseball, they have a walk-up theme. I think after this morning's talk, the ONC walk-up theme is going to be bringing sexy back. So we'll stick with that one. I really want to appreciate all the comments that were made this morning, in particular the very powerful stories that we heard from Mr. Kennedy and Ms. Burgum, as well as some of our providers, Senator Marshall and Dr. P. Crowan from Louisiana, as well as the public health officials. I think those stories were all very compelling, and they illustrate how health information technology can improve and is improving behavioral health care delivery. But I think it also begs a couple additional questions. What else can be done, and how do we scale that for all communities? So for my esteemed panel today, we're going to allow everyone to do some introductions to give you their background and better explain how we're going to focus on a few things like current examples of EHR-enabled care coordination, the role of AI in improving both clinical and patient outcomes, as well as program and policy conditions that are needed to expand access to all these effective tools. So with that, we'll start with Mr. Steve Herron from Oracle.
Hi, Steve Herron from Oracle. I've been with Oracle Health for 31 years. In that time, it's been my job to basically adapt and implement the technology that everyone knows from the acute and ambulatory spaces into venues outside of those spaces, so specifically in post-acute, behavioral health, and all of the areas that basically haven't received the meaningful use funding or anything to implement the technology. So in most cases, when providers in these spaces have implemented, they're doing it for other reasons. Either they're doing it for something that helps to drive the benefits of the local program that they're operating in, or state local environment that they're in, or for better reasons of actually doing a better job of tracking the patient's condition. And so that's kind of what my role is. And I guess I'll mention too, in the previous session, I really appreciated Senator Marshall's comments in the idea that, providers haven't loved their EMR. And so that's one of the things about meaningful use. It did a great job of digitizing the record. But on the flip side of that, we did take a lot of doctors and nurses and in some cases turn them into data entry specialists. And it's kind of now that we're on the precipice of all of those next layer benefits of all of that coming back around. And I'm going to get into a little bit more what we're doing with AI to specifically address what he was saying earlier about, hey, I need to be able to prepare as I'm getting ready to see the patient. Well, AI can do that for you. AI can take all of the data from years of that patient's record and summarize it and put it in context for what you need to know as you're going in to see that patient right now. While you're caring for that patient, you don't want them staring like this, like you mentioned earlier. And in fact, today, they can take their phone, set it between them and the patient, have the full session, and let that be the thing that takes the notes, summarizes the information, stores it into the record, and then we need to take the next step of actually, simplifying the process and the follow-up. And so I'm sorry, I'm taking a little bit more time with my introduction, but that's the things that we want to make sure we're addressing going forward with getting out of this just being a digital record and actually creating access out of that.
Thank you very much. And as a provider, I certainly do appreciate the thought that providers should be part of this conversation. So, Ms. Baronio?
Thank you. And thank you for having me here today. I'm here today representing the National Association of State Mental Health Program Directors. So that association represents state leaders in every state and some of our members are on the prior panel, who lead the state public programs to address the needs of some of our most severely disabled and impacted people who are most impacted by behavioral health conditions. And so we think about these issues more from the system level and, kind of how the different programs interact or don't interact. So my role at NASHBID is I'm a senior advisor, and I'm primarily focused on funding streams, Medicaid, SAMHSA, Medicare, et cetera, and thinking about, advising state officials on what the opportunities there are, what the limitations are. But in terms of the importance of this issue for our members, it's incredibly important. As the prior panel highlighted, there's a lag in terms of the use of IT, and your data brief also really illustrated this well, that particularly for state-funded programs, there's a lag in terms of using IT for care coordination, which, as we know, is really critical. People don't just come with one single diagnosis. They generally and often have comorbid conditions, and the interaction between those conditions, we know from research, really affects outcomes and cost of care. So for the most severely impacted individuals, those with serious mental illness who often have very serious physical health conditions as well, the impact of those behavioral health conditions on physical health outcomes is very costly. And we know this from research, but nobody tracks it, as others on the prior panel also highlighted. This is very important, and improving the coordination of care for those comorbid conditions is very, very important, as well as those transitions between levels of care, as the doctor from Louisiana highlighted, very, very important for our members. And I'll just leave it at that for now, but thank you for having me.
Thank you very much, and we will certainly be digging more into the care coordination piece today. Ms. Brown.
Hello, and thank you all for having me. My name is Stephanie Brown. I am the President and Executive Director of CRISP DC. We are the District Designated Health Information Exchange, a 501c3 nonprofit right here in DC. I am, by my education, a public health professional and focused on policy, and I always joke that I don't know how I ended up in health IT, but how I did was because of everything we've been talking about today, that the movement of data is essential for whole person care, and that means it needs to be all of the data, and that's something that the HIE here in DC is focusing on. So today I will be diving into what we're doing in the behavioral health and mental health space, but we are also focusing on other creative ways to move data in the district, such as the DC-led registry and school absenteeism data for the coordination of whole person care.
Thank you very much. Ms. Newton?
Hey! Very loud. It's great to join you all today. I am Ashley Newton. I am the CEO for Centerstone's Institute for Clinical Excellence and Innovation. I represent a provider organization. Centerstone is the nation's largest behavioral health community organization. And we have brick and mortar facilities in 9 different states. We also offer a 2,000 licensed clinician network of services for military service members and their families across the entire United States and in 26 other countries. The Institute is the part of the organization that gets to really dig into research, clinical practice, setting those practice standards, helping our staff to be comfortably competent, utilizing evidence-based practices,
We also run what's called Centerstone Patient Safety Organization. And so this theme of data is not only connected to how do we deliver the very best care, but it's also connected to how we can utilize our lived experiences and decades of practice and patient experiences to also shape what care looks like, and to understand what kinds of interventions work and for whom. So this is very near and dear to the work that we do. I've spent the first 10 years of my organization really working in clinical practices in communities. I'll talk a little bit more about that with the next question, I believe. And then the last 10 years, I've spent really working in this research and innovation space, and also trying to help shepherd clinical technologies and decision support tools into the EHR. So we have a lot of experience with both the kind of the data mapping and the technical requirements there, introducing that to new providers who are learning to utilize new tools, and then also thinking about things like how do we overlay, safety science, for example, with the way that we think about designing records and tools for clinicians. So I have a heavy interest in that space too, and find that to be really, there are a lot of lessons learned, but I think it's been really fun to be able to dig into that. There are also quite a few constraints and barriers that we run into, and so I know those will come up today on this panel.
All right, thank you very much. I've seen some themes develop already, one of which we blow the microphones out when we talk, so I apologize about that. The other is that most folks on the panel, it seems like we have a lot of similar thoughts and a lot of lines of thought. Very friendly panel, so with that, I think I will just switch to first names if that's okay with everybody. Quinn, would you like to go next?
Hey, good morning, everybody. It's great to be here. My name is Quinn Bastian. I'm a psychologist with the VA. I came to VA originally as a operational leader for a small hospital in Washington State, and then eventually came over to VA Central Office, where now I serve as the National Mental Health Director for Informatics. We had some conversation between Dr. Jonathan Nebeker, I don't know how many of you know Jonathan, but between he and I about whether it ought to be the informatics side of the house or the clinical side of the house that came to represent this panel today. And we ended up falling on the clinical side of the house. So I work within the Office of Mental Health. The Office of Mental Health, which is part of Veterans Health Administration, but my team and I oversee a portfolio of informatics tools that range everything from testing products to mobile apps to everything in the electronic health record in the mental health space. Thanks.
Thank you very much. Interesting debate. Dr. Nebeker still practices, so he's kind of clinical too.
Right. We both have our feet in both sides of the camp. That's right.
All right, Dr. Postal, Susie.
Am I on? Okay. Hi, everybody. Thank you for the opportunity to present today. I'm Dr. Susie Postal. I'm the Chief Health Informatics Officer at the Indian Health Service. And I also would like to recognize Dr. Glorinda Segay, who's with me today, and she's the Director of Behavioral Health. Within the Indian Health Service, we are recognizing the American Indian and Alaska Natives. There's over 2.6 million that we provide services to, and we represent, we listen to the 575 tribes. We are a healthcare system. We have a strong behavioral health care program. We recognize from this morning's discussion a lot of the same kind of concepts and concerns that come up, but to just recognize the need for technology to improve care and utilizing these tools, how can we make it more efficient for the provider? How can we use interoperability, health information exchange, and more for our patients, recognizing traditional health and also recognizing the special, unique cultural sensitivities of our population. Thank you.
Thank you. Nathaniel?
Hi, Nathaniel Counts, Chief Policy Officer of the Kennedy Forum. The Kennedy Forum was founded by former Congressman Patrick Kennedy, who heard from last panel, and his wife, Amy Kennedy. And it was founded to really carry on their legacy and their work to stop the mental health and suicide crisis in this country. And so in the Kennedy Forum, we have this vision. It's called 90-90-90, and the goal is for, by 2033, 90% of people screened, 90% of people receiving the evidence-based coverage, the care they need, and 90% of people in recovery. And to that end, throughout this panel, I'm going to relentlessly hit on the importance of interoperability to value-based payment, which is really sort of like the workforce for accomplishing this. So no matter what I'm asked, that's what I'm going to talk about.
All right, good to know. Holly.
Thanks so much for having here. It's a great focus. Holly Carmen, Senior Compliance Manager for Qualifex Systems. I have a long-standing career with Qualifex. We are an EHR vendor of the CareLogic, Credible, and InSync platforms, and our specialization is supporting behavioral health, substance use disorder, and human service organizations. Thanks for having me today.
Thank you. Tim?
Excuse me. Tim Clement from Mental Health America. We're the country's oldest mental health advocacy organization, founded in 1909 by Clifford Beers, who had been suffered greatly in inpatient psychiatric facilities in the early part of the 20th century, endured some barbaric treatments, and I think we all look back now at some of the mental health treatments that were done, particularly in the inpatient realm, facility-based realm in the 20th century, and look at them as, rightfully so, as horrific, barbarous, torturous. But I think one thing to remember is the people, the practitioners at the time, didn't think that. They didn't think that they were hurting people by submerging them in ice baths or extreme heat or performing lobotomies on them. I mean, I don't know if Patrick is still here, but they didn't perform a lobotomy on Rosemary Kennedy because they were trying to harm her, but obviously it did. So I think that's the perspective we bring to the conversation, is that we know everyone has the best interest of those with mental health conditions and substance use disorders in mind. We want to make sure that actually happens. And there's something I will bring up during our conversation just to emphasize that. But that's our perspective at Mental Health America.
Thank you. Megan?
Hi, I'm Megan Gilmore. I'm the Vice President of Government Affairs with the Association for Behavioral Health and Wellness. Our members are health plans that manage mental health and substance use disorder benefits, covering 200 million lives, both in the public and private sector. And so in this context of our discussion, looking at interoperability, data information exchange, moving beyond kind of administrative to the measurement informed and outcome, kind of how do we get to value?
All right, thank you very much. Okay, we will move into some discussion points quickly here. So, Quinn, I'm just curious, what strategies does the VA take to leverage internal and external EHR data to improve mental health and substance use care coordination for veterans?
Yeah, thank you for the question. The VA is doing a lot. We historically, as an agency, we've done pretty well internally, meaning within the VA. We may have a legacy EHR that has 155 different instances of the EHR, but at the end of the day, all of those instances send their data at the end of the day to a corporate data warehouse. And we've been able to leverage that corporate data warehouse to pull data for a lot of very useful things, for clinical decision support, such as the ReachVet initiative, which uses predictive analytics to identify veterans who, based on what's in their EHR, are at very high risk, statistically, of suicide. So that we can then outreach those veterans and make sure that they're engaged in care. We've used this data for quality measurement, for measurement-based care, for all kinds of things. So internally, it's gone pretty well. The challenge is externally. With any of you who've worked with the VA know that it's been kind of a challenge to actually collaborate and communicate and share records, exchange data and other information with external partners. We've been pretty good about billing data, but beyond that, hasn't really gone so far. I believe we are at a real inflection point right now. I believe we are poised right now with almost a perfect storm of opportunity to make some significant changes in this, not just within the VA, but nationally. And here's some reasons for that. One is the speed at which technology is moving. It's moving so quickly. We've got a lot of opportunity to make some significant improvements with data. Number two, the administration. The current administration is very passionate about this, and that does include the VA administration. Our secretary has made it a top priority to really work better with the community and collaborate more with the community rather than just sending vets to be seen in the community, and then there's no communication between the agencies. And there are other reasons why I think we're so well poised to do this. One of them is VA's migration to the federal EHR. That there was a decision made years ago that VA needed to move to a single instance of an EHR that was a commercial EHR that would then become the federal electronic health record, and that is the Oracle EHR. Just last week, I spent time in Michigan helping 4 more VA sites migrate to the new federal EHR. So they're now in their first week of learning this new system and transitioning from the old system to the new one. That brings us to a total of 9 so far. We will have all VAs converted to the federal EHR within a couple of years. That inherently brings with it some new connections with the community that we never had before. Engagement with the new Joint Health Information Exchange that has more than 10,000 hospitals, labs, and other organizations already interfaced through the Oracle system with VA so that we can really start to share records in much more meaningful ways. So I think we're in a really good place for doing this, but it begs the question, and this is kind of my key stomping point today that I'd like to make. So what? Let's say that we do a great job of creating all this interoperability between our data. Let's say that we can share all of our data. What is the value? How does that actually lead to different mental health and substance use disorder outcomes? I think is a key issue. And so we've got some thoughts about that. And I think one lens to look at it through is to say, well, what kind of data are we actually sharing? So from the VA's perspective, at the most surface level is just a question of, is this patient sitting in front of me a veteran? There's a study from Duke that showed that if a community provider knows a veteran is sitting in front of them and that this person is eligible for VA benefits and VA care, that can transform their healthcare significantly and lead to better mental health outcomes. That clinician, that system knows that this person is eligible for suicide-related care, for example, through the Compact Act and other legislation. So just knowing that somebody's a vet is a starting place, but that's not really enough. If we dig a little bit deeper, we get just past knowing somebody's a veteran to actually sharing records, diagnostic assessments, treatment plans, other records of care. This can help us actually collaborate as a community in developing a shared joint treatment plan. So we're actually all working from a single community treatment plan as opposed to a different treatment plan at each agency or each stop along the way that a veteran may go through. So that's another step. I think we need to go further than that, and it's been talked a lot about today, to go a little bit deeper into if we do commit as a community to collaborate in how we provide care for substance abuse and addiction, how do we know if we're doing it? How do we actually know that we're doing these actions, taking these steps that are showing that we're collaborating and working together? And that brings us back to the measures, to having a standard set of digital measures that are built into the EHR that help show if we're actually doing that. And our agency is working collaboratively with a lot of folks here, including ONC, to develop a collection of digital quality measures that can assess things like, are we actually providing warm handoffs between agencies? Are we making sure that veterans have continuous opportunities for care? And maybe above all, are we actually, as a collective group, carrying out the work needed to follow the clinical practice guidelines? Are we actually working on the same treatment plan, and is it consistent with the evidence? Things like titrating medications across agencies, imagine that. Things like being consistent with psychotherapy and the delivery of evidence-based psychotherapies across agencies, things like that. So it's very important to us. We think this is really key that we get to this point of digital quality measures. And then one more level below that is when we actually start talking about clinical outcomes. When we're really working together as partners, including with the veteran or the patient, to identify whether we're actually making a difference in their life, whether, and as was mentioned this morning, not just symptom reduction, that's important, but it's not everything. Whether quality of life activities are getting better, whether from the perspective of the patient, there's improvement and recovery actually happening, and life improving. So tremendous opportunity right now. We're at a great inflection point for making a lot of difference. There's also a tremendous amount of work to be done.
Thank you. And I think you highlighted an excellent point, which is interoperability in of itself. It's just the means, right? It's not the ends. It's like, what value do we bring? How do we improve outcomes? How do we improve people's lives? And so from your perspective at IHS, can you explain why the exchange and use of health data is so important for mental health and substance use, case care, and outcomes in tribal communities?
Sure. Thank you, Jason. First, I want to go backwards just to recognize that we, as well as the VA, are going through an HIT modernization. So we currently have, within the federal side, a resource patient management system, which is a spinoff of the VA, but versus we're cradle to grave with our EHR. And our new system, which will be Oracle Health, I look at Steve over there, that we have a strong group of users, not just within the headquarters side, but all over the whole Indian country, providing input to design this to meet the cultural sensitivity needs and more. And we also have a very strong telebehavioral health center of excellence for telehealth. So I just want to say, so what do we feel could the data exchange? The exchange and use of health data is vital for advancing mental health and substance use in our tribal communities, and it's systemic. It will systemically collect the data, and then you can get a comprehensive view of what you need to do to address these issues and address outcomes. You could look at the demographic changes in age. We have patients who have depression, as you heard, substance use disorder. You can look at other critical factors to design treatment and manage it. And I always say you take the data, you use it with your own information, knowledge, and then you provide the treatment or the wisdom. So instruments or tools that can help the provider to make these decisions, make quality care decisions to help the patients, so important. And as you mentioned, it's not just the technology, it's the person at the bedside, it's the person at the clinic. And so then I'm going to go into my technology side, where we also mentioned telehealth, a patient portal, where you can empower the patient to be part of their care, to message the provider if the medication's having adverse effects. I think of the prescription drug monitoring plan when you have substance use disorder, that you can help to guide them versus have a fatal overdose. And then again, it's the quality decisions, but we also have to recognize with our patient population the cultural sensitivity, and that's making sure that we can meet them at their native language sometimes and more. So thank you.
Thank you very much. And you know what I heard you saying that was really appealing to me is, you know, when you're dealing with true longitudinal care from a very early age to the end of life, and you're treating that patient comprehensively, right? I mean, that's an approach that we really need to be thinking about, and I'm happy this forum is here to talk about that, you know, stigma was a huge topic in the first lecture, which didn't really come up so far yet today, but it's a huge barrier that we have to deal with. And looking at mental health as just part of health, right? It's just another pillar of primary care, I think is an excellent step forward. And it sounds like that's what you're working toward. So I'm really interested, you know, Steve, I know that you have some thoughts about this, but how do you feel that treating mental health and substance use care as a whole person, what does that actually look like in practice?
So in order to treat the whole person, you have to know the whole story. We've heard several clinicians today talk about, you know, needing to have that information and about data that they're putting into the system and struggling with doing. But the reason they're capturing all that information is so that they have that whole story. And unfortunately, we rely sometimes, well, and I should point out too, AI, we talk about all the benefits that we're going to achieve from AI. The AI is only as good as that data that we've input into it. So it needs that whole story as well to really tell the true story of what's going on. And unfortunately, we're relying on memory sometimes. When we go out and care for a patient in their home, maybe that patient has memory problems. Maybe they can't speak for themselves. Maybe the family member isn't even aware of the time that they went to the ED 6 months ago and were prescribed a certain medication. So we need all that data in, but we also need it to be liquid and interoperable so it flows to the caregiver and the provider so they know that whole story so they can actually care for that patient. And so that's ultimately what's going to allow the AI to show the full context to the caregiver in the situation that they're in. We're also relying on memory of the actual provider who, as we mentioned earlier, is struggling to pay attention to the person that they're caring for and take those notes so that they don't forget it later. And then taking that note, maybe they already cared for 9 patients that day, and they haven't gotten back to that note that they did at the beginning of the day from their first session. And then they have to go to their kid's soccer game, and now they spend the evening in their pajamas trying to remember what it was that patient told them at 8 a.m. in the morning. And so that's where, again, AI can take that out of the equation by capturing the data during the session, recording the information, putting it back into a note, presenting it to the provider and saying, hey, here's what I heard. Is that what you heard? And allowing them to just acknowledge what they've seen. So now, again, they've had the entire story of what they've experienced there. And I should say this is not, we talk about some of this is coming. The AI is here today to do what I've just described. We've got behavioral health providers across the country that are using it. We've got behavioral health providers in Southeast Texas that are using this, and they've told us that they're seeing an extra 2 patients a day because of the time that they've saved. So we've opened up access to more patients receiving care because of the fact that now they have more time to do this. And they said simultaneously that they don't have pajama time, that they're leaving at a regular time. The office is empty at 5 p.m. because everybody has actually had their notes already recorded and in the system. So another note about that is that they said that it captures the data. You know, the sessions in Southeast Texas are very often done in Spanish. The provider may be English as a second language, the patient is English as a second language. But they can capture the data, the session that's happening in Spanish, and the note is created by the AI in English. And so, and in some cases, the providers themselves have said that the note transcribed it into better English than they would have if they had to do that themselves. So there's another benefit then that note is being captured accurately and then shared with the other providers that are going to care for that patient later. So it is amazing the change. And I should say, too, statistically, we got another provider in New York, and they've said that it takes them 57% less time to document the notes from their session and 25% less time that they spend in their EHR overall because they've implemented this artificial intelligence. Now, when we start translating that into the next phase of saying, hey, let's create a treatment plan from AI. We already know the standards of care. We know the patient's history. Instead of making the provider build that treatment plan from scratch, start it for them. Show them, here's what you would normally prescribe for a patient with these conditions in this situation, and let them modify that as opposed to starting from scratch and taking all the time that it takes to build that treatment plan. So these are real-world benefits that are coming, but again, it relies on that whole story, capturing all of the data.
No, I appreciate that, and I appreciate focusing on mental health data, the capture of that data as being a unique experience that we have to really focus on. And I also, again, as a provider, can't say thank you enough for making sure that we have to remember that providers are part of this equation too, and their satisfaction translates to better care and better longevity and more physicians in the system, more providers in the system. So I appreciate that very much. Holly, look to you and ask, what are some successes and what are some challenges for EHR adoption in the mental health space and substance use space, those care settings? What have you seen?
So I don't think it's necessarily about the adoption of an EHR. I think it's some of the challenges that we see are posed by states themselves, or a lack of barrier to education for providers around interoperability. What does it look like? What does it look like in practice? How do we tap into things or state HIEs or otherwise? How do we look at data liquidity? How do we look at clinical quality reporting beyond just having to do it for MIPS or APMs or otherwise? Using it for that value-based reporting. Behavioral health care and substance use-related care are not standardized like health care, which is what we see. Every state has different requirements and even payment structures, and even sometimes within the state, there's different structures that we have to adhere to as well. So when we have organizations like CARF and JCAHO, which are wonderful and fabulous standards of care, they are still voluntary across the board. So we also look at, and this was raised in the first roundtable as well, there has been a recent update to 42 CFR Part 2, and it's been welcomed, and it's been quite a success, looking at kind of that one single TPO to share substance use-related data, intermingling and commingling within the healthcare record. But it's also its alignment with HIPAA really kind of creates that substantial connections to consumer coordination of care, national goals for data interoperability, and a culture of information sharing and only blocking when absolutely necessary. So I think I like to flip it when people say, oh, it's the information blocking language, and I go, how about a culture of sharing until I've got to pull it back, and I've got to have good reason to pull it back. So that open notes movement as well. But this cultural shift, I think, that we've got to take in behavioral health care, specifically with substance use disorder, to move from data strangulation, because we want to protect it, to data safeguarding. It's a cultural shift that needs to take place nationally. We want to overprotect it, but now with some of those new changes, I think it's our opportunity to look at how can we really use this data towards the goals and aims that we want to. So I think it's an ongoing challenge, but not one that we can't really overcome. Thanks for the question.
Yeah, no, thank you. And I think what you highlighted there with that sort of balance between, privacy and utility, right? I mean, I think it's a conversation we have internally all the time, and it's a conversation that continues to evolve and will continue to be had. But, I agree. Well, we're going to have to figure out a way forward so we actually can have some, actionable outcomes from what we're doing. And with that, Stephanie, you and I were talking a little bit before the panel, and as Quinn and I had just said earlier, right? Interoperability, it's the journey, right? It's the means, it's not the ends. And so, working at CRISP DC, I mean, how do you see EHR systems? How can they be designed and leveraged to advance appropriate patient and provider access to secure, usable electronic health information, exchange of mental health, and substance use care contacts, and particularly, how do we improve outcomes with that data?
Absolutely. I think that I want to, before I dive into the technology and how we've designed that to address those barriers, I want to say the main thing that we're doing and why we're doing it is to take that burden off of the provider, like you spoke about, and off of the patient, to remember that history and constantly capture that history and put someone through potentially that emotional trauma, again, of speaking about their history when they've already done so, and that's something that came up on the first panel. And so that is why we're here. So at the District Health Information Exchange, we are very excited that we are currently sharing behavioral health data through the district for all of the Department of Behavioral Health certified providers. And we are doing so because we've worked with EHR vendors who have been open and willing to share that data with us in a way that works for their technology and also their organization. So what we've made sure that we do is we have technology that has been made with a no wrong door policy. We will take the data in any way you can give it to us. We will support those large EHR vendors that have sophisticated technology. We will also work with those smaller organizations that have legacy technology and need more support on their end, as well as their vendors need more creative ways to get that data into the HIE. And in order to do that, we have taken an agnostic approach of how that data gets in here. So some EHR vendors have the ability to work with their organizations and capture that 42 CFR Part 2 consent in their workflows. And so we work with those organizations to make sure that data is tagged and it flows directly into the HIE because that consent has already been captured. For those mixed-use facilities, for those that are not only substance use disorder treatment, but may also provide primary care, we offer another solution in which we say we will take on that burden, that technical burden of parsing that data for you. So we will take all of your data before it's visible in the HIE, move that substance use disorder data into the sensitive document repository, and the non-substance use disorder treatment data will flow directly to the HIE. That does not need to be covered by that 42 CFR Part 2 consent. And so again, we have this agnostic approach, no wrong door, that we're able to support the EHR vendor and their customer in the way that works the best for them. And when it comes to that 42 CFR Part 2 consent, not only do we have the technology on the back end to store that data, we also built a tool in order to capture consent in the way that the organization would like to capture it. So if an organization does have the tools on the front end to capture that additional 42 CFR Part 2 explicit patient consent, they can do so and attest for that in the HIE and then allow for that data to be shown to their treatment providers. For those smaller organizations that may not have the technology or the manpower to do so, we have a 42 CFR Part 2 compliant consent tool within the HIE. It's a provider and care team-led workflow where the care team can sit shoulder to shoulder with a patient, talk with them through what it means to sign a 42 CFR Part 2 consent and the importance of that whole person care, document that consent within the HIE, and therefore release that 42 CFR Part 2 data to their treating providers. And we've done all of this in partnership with the providers and what their EHRs have been able to support.
Thank you. Sort of revisiting the unique nature of what we're talking about today, right? Again, we want mental health to be part of the vernacular anytime you're talking about healthcare, but we do recognize that it is separate in many ways with regards to data capture and its approach to it. Different patient populations also have differences in the way they want it approached. And so I'm just curious, we have a minute here to revisit that. What are some unique considerations? We'll start with our federal partners first, but what are some unique considerations for serving our nation's heroes, the veterans, and our tribal communities with mental health and substance use in their treatment settings? And how can we use technology in those unique populations to improve care outcomes? Either or.
Okay, thank you. So I first think about the unique considerations to take with our distinct patient population. And some of our patients live on reservations. They may be 3 hours from the latest hospital to get care. And so when you think about a consideration and access to care telehealth, so as I mentioned earlier, we have a very strong telebehavioral health center of excellence. But you also have to have the patient want to have that technology. And some may not want that type of care. They want to be seen in person. So cultural sensitivity. The other thing to look at is population health. And there may be teens who decide that they have a suicide pact and they want to, at 3 p.m. Perform something that could be very fatal. That you have the technology to alert the community, to alert the healthcare system that something's going to take place. And what was mentioned in the first panel about historical trauma. So we, within our patient population, have a history of historical trauma, and you want to treat, again, the wellness of the patient. So what type of apps are out there to provide support for that, even if it's meditation, with water running, things like that. So I wanted to bring that up, but integrated care is so important with our patient population. So when you think of substance use disorder and you think of just a routine care, that they can talk, and they spoke earlier about that if you couldn't see something and you took a medication and then they showed up in the ER and it was hepatic toxic, you have no clue. So we have to have that ability to give technology integration available. And then the last thing I'll mention is about consenting. So, you hear about opt-in or opt-out, and what type of consent will help support a broader care for our population.
Thank you. How about the veterans?
Yeah, thank you. So veterans have some things in common. Every veteran was once an active duty service member. And active duty service members are taught to focus on the mission at hand. And the way you get the mission done when you're uncomfortable or when you're hurting is you push it down, suck it up, push through the pain, soldier up, and focus on the mission. And you get the mission done. That can be an effective way to get operational missions done. It's not a very effective way to deal with addiction. It's not an effective way to deal with mental health issues. 20 years later, after you're done with your military service and you've transitioned to civilian life and you're staring at a dark wall in the middle of the night wondering why you can't sleep. So the stigma that is endemic in our culture with mental health and addiction issues tends to be amplified a little bit in our veterans. There's even a little bit less inclination to seek help in the first place. While they're on active duty, they're very aware that any medical or mental health issue could keep them from being able to do their job. It could lead to them losing their operational assignments. It could lead to separation from the military. And so they're very disinclined sometimes to share that information. So that stigma is particularly strong, I think, in veterans. Another issue is because they've made that transition from active duty service to civilian life, for many of them that holds a deeper connotation of transitioning away from being part of the federal government and working for the federal government and becoming a free civilian where they're not feeling the touch of that federal establishment in every aspect of their life. Ever since Vietnam, we've seen that a lot of veterans, once they leave service, are really anxious to have to be fully divorced from the federal government, which makes them less inclined sometimes to seek out help through the agencies that are there, through the public agencies, through the VA and others. So what about technology? What does this have to do with anything? Well, technology can smooth those transitions somewhat. For example, the advent of all the different things that are available for getting help in mental health space that aren't necessarily going to a clinician and getting medication or getting treatment, getting psychotherapy. Things like courses, online courses for mental health, things like virtual reality, eventually AI. None of those are treatments per se. Chatbots are not treatment, but they can sometimes soften that entry into mental health services in a way that makes it a little bit more comfortable for people to engage in the system and start being open to the services that are available to them. I mentioned before about knowing that somebody's a veteran. We can say all day long we want the community to know that somebody's a veteran, but if we don't provide the technology to support that, it's kind of an empty request. And that's why a number of years ago, the VA started really encouraging the Veterans Interoperability Pledge for the VIP program. We have now 20 different healthcare systems and 2 vendors, Oracle and Epic, who've agreed to help support this veteran interoperability pledge. All it is a pledge that an agency will check to see if somebody's a veteran by submitting a call to the Veteran Confirmation API to just ask the question, is this person a veteran? And so by putting the API behind that, it makes it much easier for systems to build it into their regular, even automated workflows to be asking that question. One last example, when it gets to the point of measuring all the things we'd like to measure, the processes of collaborating care, the outcomes that are there, we need to make that as user-friendly as we can too. One thing that we've learned from migrating over to Oracle is if you make something the easy path, people are a lot more inclined to do it than if it's more cumbersome and more difficult and harder to do. So we've got to make this kind of measurement the easy path. We need a digital health platform that allows our clinicians inside the VA, outside the VA, with all of our agencies and our patients as well, to be able to engage in this platform to collaboratively pull together this information that shows, are we doing a good job of collaborating care and are we getting the outcomes that we need?
All right, thank you. And again, the stigma aspect surfaced again, and I'm glad it did because I think it's worth discussing. And it sounds like the VA has some forward-looking approaches on how you address that. I'd be curious from everybody on the panel, what your thoughts are about, scaling it out beyond our veteran population and, beyond our Native American population to the general public. What thoughts have you had on it? What conversations have you had? And what are your thoughts going forward? It's a hard one, I know.
Some thoughts we have at NASHBIT about this have to do with really incorporating behavioral health into more integrated settings, at least for conditions that are not to that level where you need a very specialized treatment setting. And technology is key to that. HIT is key to that. So as the senator, I think, told a story about in small towns, everyone knows if you're going to the mental health clinic, I think providing better access in more integrated mainstream settings really does help to improve stigma and really teach people that behavioral health is really a part of your overall health. But in terms of HIT and technology and how it can support better integration, there have been a number of articles written over the years. There was guidance that CMS put out back in 2024 around how Medicaid can support better integration of behavioral health, and also some guidance that was put out specifically around how CMS or how Medicaid can support the administrative costs of making some of these connections. So I just wanted to highlight that for you. And that guidance does go into some of the details around how technology can support telehealth, can support e-consults, and that communication between a primary care provider and a behavioral health provider, even outside the presence of that client. So just a lot of really good recommendations, I think, in a couple. And the other guidance document I talked about has to do with Medicaid coverage of interprofessional consultation. That's the term used. So I'd recommend those to you.
All right, thank you. Any other thoughts? Yeah, of course.
I had my chance to talk, but I feel strongly about, stigma. And some patients may not be comfortable with having mental health providers who are not indigenous. And so when we think of telehealth, and others may have concerns that they live in the same community as their provider, they run into them at the grocery store, it might be their psychiatrist. One of our providers had shared that by providing telehealth and remote access, they can meet with the provider at another facility, per se, and get the care they need and not feel that they're weak seeking this care. So that's just one of the things I think of. Thank you.
To piggyback off of that, I just wanted to highlight, interestingly, from the health information exchange side of things, we saw through our technical assistance efforts with substance use disorder, behavioral health, mental health providers, a deep concern on behalf of their patients because they know what they have endured at the hands of the stigma that does exist. And so their comfort in engaging with us as the Health Information Exchange was something that was being tempered by their concerns of the stigma that their patients that they are so dedicated to face. And so it's very important for us to have robust technical assistance programs where we can sit shoulder to shoulder with those providers, help them understand that we are a nonprofit and we are here to serve them as our users and the patients that they're dedicated to serving. And we do understand the stigma and explain to them the technology that we have and how we take every step to protect all of the information within the HIE, but specifically in line with 42 CFR Part 2, and make sure everyone on the care team is comfortable so that they're not only engaging with me and sharing the baseline data, but they're continuing to engage with the HIE and use our data in their workflows and the coordination of care on behalf of their patients.
Thank you. And I'm again, the theme that I'm getting out of that is the coordination and the outcomes. And I really like to hear that. And I kind of want to, I'm sorry, Nathaniel, I know what you're going to talk about.
No, well, I think you're getting to us anyway, so I'll just go ahead.
Thanks, Tim. Appreciate it. So back to my thing on value-based payment. You just can't really have value-based payment in any way that allows for integration that serves the whole person without interoperable data systems. So this is sort of like a fundamental challenge we face. We put out a paper, I think it was in 2019, looking at MSSP used to collect depression remission at 12 months as one of its quality measures. And so I did a review of all of them. The average performance was about 15% depression remission at 12 months. The average rate of random remission is about 50%. 3 ACOs achieved 100% remission. I like to go see where those are and attend them myself. And now with the new ACO reach, access, there's about 5 main quality measures, and there's a lot of ways to hit them, right? And if mental health isn't meaningfully integrated, there just won't be a possibility to try to build it as part of overall value-based payment and allow for integrated stigma-free care. And that's not because they don't want to, right? There's like a general problem with integrating specialty care as a whole, which like CMS and CMMI are relentlessly focusing on. But without access to interoperable data systems, you just like it's so much harder than integrating like oncology or any other aspect of specialty care. So to policy recommendations, and then I'll let Tim talk. I think the critical thing is to integrate financing for interoperable data systems into value-based payment models. So when you're thinking about designing, let's say, a Medicare model out of CMMI, and I think it's important that it have a chance at national scale-up. There's been a lot of small models that are tests but aren't set up for national scale-up. And I think there's a chance to make this case that by investing in high-quality interoperable data systems, it has an ROI that allows for national scale-up that fits inside of existing value-based payment models so it can scale nationwide, and it's not sort of a one-off opportunity. Then as Kirsten started to hit on, within Medicaid, I think you could have the same system where you demonstrate that kind of ROI, and that makes it that much easier for states in their 1115 waivers to propose investments in interoperable data systems. And then finally, with all of this in place, I think health insurance, like health plan alignment, gets that much easier. And I think especially on that point, there's this always antitrust problem, right? Like they can't all work together on investing interoperable data systems, or it becomes a federal violation. And so I think there's an opportunity for the federal government and states to work together to create this liability shield that enables cross-payer alignment and coordinated investment. Like I think we've seen in a few states, like I actually think Louisiana and Rhode Island both did that for primary care. So this is maybe to summarize for the note takers in particular. 3 recommendations, all related to value-based payment and interoperable data systems, scalable Medicare models that work across ACOs, help for Medicaid 1115 waivers to states, and then help for multi-payer alignment, especially through antitrust yields, so that there can be coordinated investment. I yield my time to Tim.
Thank you, Nathaniel. Fun fact, Nathaniel and I basically traded jobs over the last 9 years. I used to be Nathaniel at the Kennedy Forum, and he was me at Mental Health America. But so just talking about stigma, we all recognize stigma. Everyone here in this room, I think, recognize stigma as a huge barrier to mental health care. But I think one thing we often talk about stigma like as a miasmatic vapor that sort of floats in the air and harms people with mental health conditions. But If you look at the research literature, it's defined as stereotypes, prejudice, and discrimination. So I think we have to remember that, for instance, in the small town where everyone knows that you're going to the mental health clinic and you don't want to go, why? Why don't you? Well, there's that stereotype that your neighbors might endorse that you're dangerous or you're incompetent, you're not going to get better, they can't have their kids around you, that kind of thing, so you're not going to go. You're worried about prejudice or potentially losing your job, that kind of thing. And so that's one thing we have to remember about the stigma when we want to address that. There's lots of ways to do that, but until you address the actual underlying components, it's hard to get around that. And there are some evidence-based strategies to reduce them. I know the VA has actually been really good in doing what are called contact strategies, videos with veterans talking about their experiences with certain conditions. That helps people destigmatize and understand that individuals with mental health conditions are not necessarily the stereotypes they had in mind. But one way it plays out in the health records world, electronic health records, is that there's a phenomenon known as diagnostic overshadowing. So if you have a mental health condition on your medical record, you're less likely to receive appropriate medical care than if you don't. And so this has been confirmed by many research studies, including a very, very large one in 2006 by Druss and colleagues, hundreds of thousands of participants in the study. And they found that with a mental health condition on your health record, this was not EHR necessarily specific, but just your health record, you were less likely to receive a revascularization procedure after a myocardial infarction than if you didn't have that diagnosis. And they controlled for every potential confounding variable they could find, and it still held through. So that means if you have a heart attack, you're less likely to get needed care with the mental health conditions than if you don't. So that's literally life and death, and that's discrimination. That's the stigma. So that's why people don't want that diagnosis on their health record, because you have a heart attack, you're more likely to die than if you don't have the diagnosis on your record. So that's something, I'm not saying that there's a solution to that in this room today, but it is something we have to keep in mind. And just the last thing I'll say about that, it's one way this manifested itself in electronic health records. It was about 10 years ago, a little over 10 years ago. There's a JAMA article about this in 2016. There's a health system that on their electronic health record, certain patients would have an airplane symbol on them. And so what did the airplane symbol signify? It signified that they were a frequent utilizer of either inpatient psychiatric services or emergency admissions, ED admissions for a psychiatric condition. So that's the stigma actually being actualized in an electronic health record. So that's the electronic health record basically saying to the provider, you should treat this patient with poorer care because they're a frequent flyer. They're less likely to, they're probably faking it, or it's just a symptom of their mental health condition and not a real thing. So anyway, that's just something we all have to keep in mind when we think about, integrating the health records, interoperability, and mental health conditions. Thanks.
To Tim's point, sometimes the stigma is actually keeping them from physically coming into the clinic because of what they may, what their neighbors may see or what their neighbors may think. And in some cases, we have providers who are actually going out into the community to care for patients. And the VA is one. VA has a home-based primary care where they do that not just for the stigma or for behavioral health, but to go out there for primary care purposes for those veterans who just cannot make it into the clinic for some reason. But we also have clients like the NHS that have community care trusts where they send people out into the homes. And they're actually in the process of combining acute mental and community care trusts into one trust where they can share the data across. But the point is, when you do that, you need that EHR to travel with the person out into the community and for them to have access to their EHR, even in places where they may not have internet access. And so that's where, something we've seen successful is the implementation of that technology on smaller form factors with full access to the historical EHR, again, in the community, regardless of whether you have internet access or not.
Can I just add quickly too, sorry. I think one thing that I haven't heard, and I didn't think about it really until I was listening to colleagues here, is we haven't really talked about crisis either today. And I think we haven't talked about how do we integrate that information. We've really moved away from law enforcement responding to mental health or substance use by, trying to advance and improve our crisis response system. But I think in the context of our conversation today about integration, as well as technology. I think that's a missing piece of this too, and it's a difficult one to kind of solve for. I mean, we're looking at how do you integrate with primary and other specialty care, and I agree with what everybody said, but that's another area that I think has a lot of exploration that needs to be done too.
Thank you. Please, Holly.
Yeah, I think the piece that I want to hone back on too, that we in the behavioral health care and substance use disorder world, what we live and breathe on a daily basis is what we're all talking about as a person behind all of this, right? And there's that adage that we've all kind of, if you're in the behavioral health world, nothing about us without us, right? And I think that we need to look also at, while we're looking at interoperable systems for providers or healthcare systems or crisis services or whatever, what does the consumer interaction look like? How are they able to kind of make that portability? How can they use an app ecosystem to be able to maintain that hub of their own healthcare ecosystem where they are the kind of central hub? So that interoperable data not just goes to a provider sense or outcome sense, but really looking at how can I enter a PHQ-9 in my client portal before I go see somebody, or those types of different things to be able to do those outcomes, or to be able to use, whether it's my colleague Stephanie's local health information exchange, or looking at TEFCA's QHIN network of networks of exchange networks. So how do we also empower and engage the provider, but then also empower and engage that consumer as well? I think that's an important topic that we tend to forget about here when we get it deep in data. We talk a lot about what we're all doing, and then I think we forget about the person receiving the care as the hub of the healthcare ecosystem, which is a vital piece here.
Thank you. Yes, very much so. And I appreciate you highlighting that, because in the time that we have left, I was about to pivot to over here, Nathaniel, I promise. I really wanted to dig into, this care coordination piece, like why it's so important, how we design that into our EHRs and our systems, and then importantly, how from a policy perspective, we make that happen. We make that an advantageous thing to try to do and to design into systems and to support. So I think with that, if I could maybe pull something out from either Tim, Nathaniel, or Megan on that, like from the care coordination piece, the HR design piece, what can we do to really get down to that consumer, that patient?
I'm happy to start, kick it off, and maybe probably hear what others have to say as well, and bounce off some ideas. But I think, this is a theme that was in the first panel, and I know has brought up here as well, as having that core set of data as well. So not just process, but what are the functional outcomes, and how do we move toward that? Advancing, that those common core set of data that include behavioral health specific elements, enabling the data exchange as well across the fragmented systems. Technology is not going to solve the fragmentation in itself, but it's one of the solutions or the puzzle pieces. And I know 42 CFR Part 2 has been a core of this panel, and that's good for me to hear that from others as well. While the culture, I like the way that you had mentioned the culture shift there, and then there's good examples about how that has been integrated. It's not consistent across the country, and so I think there's still a lot of education, a lot of efforts that need to be made for all the stakeholders that are involved in the system around privacy, HIPAA compliant, as well as 42 CFR, and what's appropriate, what to share, what is not. What are the real changes? What are the laws and regulations around that? So while I think we've heard some positives with that, there's still, I think, some lack of knowledge, education, and resources specifically in that area. And then again, making those measurable, those metrics measurable and meaningful as well. So,
thank you.
I guess I could add in terms of why the care coordination piece is so important. I think with individuals with mental health conditions and substance use disorders, there's a very high comorbidity rate with other medical and physical health conditions, and that works two ways. One, individuals with mental health conditions, substance use disorder, just one variable, for example, they have a much higher rate of smoking than individuals with that, particularly individuals with serious mental illness, which of course leads to all kinds of comorbid health outcomes. But then also individuals with serious chronic medical conditions are also much more likely to have depression or anxiety. So you do see this very high disease burden with individuals with mental health conditions and substance use disorders, particularly those with serious mental illnesses like schizophrenia and bipolar disorder, where there's a lot of comorbidity that is, which actually, from a payment perspective, individuals with mental health conditions, particularly serious mental illnesses, are much, much more expensive to cover from a health insurance perspective. But that's mostly because of the comorbid physical health maladies they have. In fact, it accounts for about 80% of that spend. So I think it's something that's the reason why you really need to have the care coordination piece, because you have to, not only do you have to address all of these things, you have to know about all of them too. And then also that comes with prescribing the various medications. And of course, with the 42 CFR Part 2 issues, there's that part as well in terms of individuals with pain who've gotten injured, who might be prescribed an opioid, but they have a substance use disorder treatment. That almost happened to Patrick Kennedy about 11, 12 years ago. So I think it's something that's why care coordination, that's just one reason, but that's a huge reason why the care coordination piece is so important.
And I'll just build. So I think since like 2011, but probably even before that, there's been this dream in healthcare for the learning healthcare system. This idea that networks of people are able to not just see how the person in front of them is doing, but be able to like integrate the latest evidence from the literature into the practice to get the right treatment to the right person at the right time, which is always like a great thing to say at meetings. And then at the same time, it's called practice-based evidence. Like as you learn something in treating people, it goes back up and becomes part of the overall evidence that you test elsewhere. So that's the idea of a learning healthcare system. And it's led to two like profound breakthroughs in the mental health area. So in first episode psychosis and prodromal, there was this program out of, started with the NIMH and that was scaled called EpiNet. There's a PedsNet for pediatrics. There's one for bipolar. And there's these incredible networks of providers that like are coming up with breakthroughs like in real time and then figuring out how to apply them to different populations, which, has sort of like changed the trajectory of people's lives. It's quite profound. They are totally cabined off from every other system. Like it works well within their network, but without, interoperable data systems across the mental health field, it just like cannot even make it to everybody else. And none of these people are participating in value-based payment. Like they're not in an ACO as far as like, maybe they are, but I don't think they know that. And so it's so critical to bring this kind of like powerful approach to patient care that really provides people the best possible care as part of the overall architecture of healthcare so it doesn't get left out.
I think I want to add just quickly too. We talk about workforce shortages, and I think that care coordination and I think the technology and the interoperability can help with that. We know care navigators can help identify where there are providers and maybe that speak the same language, look and have similar backgrounds to the individual and what they're looking for, but also again leveraging telehealth and some of the other digital tools as well.
Can I just add something I forgot to mention earlier, a model for your consideration for improving care coordination, sort of a hub and spoke model, if you've heard of that. It's initially, I think, was in the opioid treatment space that term was used, but there's also a HRSA program that's sort of similar. It's called the Pediatric Mental Health Access Program, and it's really designed to create hubs of specialists that can support better access to care in other settings. And technology is a key piece of that and really supporting that kind of model, which can also address some of the workforce issues that Megan mentioned.
Thank you. Ashley, I'd love to get your take on it. I know you have a very data-driven approach and you have a lot of research you can share. And so what are your thoughts?
Thanks. I love this question, too, about care coordination. So I would say in addition to thinking about the data and research and support behind it, this was actually my first job when I entered the field. I worked in communities with children and their families and young adults and provided care coordination services to them. And so I can talk about the research, but I also have a very personal experience and have seen the impact that work can have for people in our communities. When I think about care coordination, I think about lots of benefits. I mean, for the patient, I think the linkage to services, learning how to navigate a complicated healthcare system or the rules for your insurance, knowing what your patient rights are. I did a lot of advocacy in schools also with children. And so, your rights as a student, as a learner, as a a recipient of care services. I think those are all ways that we can really start to address some of the social drivers of health, social determinants of health, like health literacy. And so that is something that I think care coordinators can also uniquely do, because they can visit folks in lots of different care settings. And, Centerstone, we provide services in CCBHC settings, FQHCs, in communities. We have a hospital, we have outpatient services. So there are all of these ways in different spaces that people can engage in care. And I think in all of those, we have ways that we can impact their total health outcome, like especially focusing on those social determinants of health. That's about half of your total health outcome. And so I think this service is also one that when we look at the research around, the benefits of being able to have multiple care providers from different systems focusing on the same care plan. We've already heard that today. Having data systems that actually support care coordination and make that data more as real-time as possible available to both the patients and the providers. There's definitely an impact in terms of the workforce shortage and prevention of worker burnout. And so that's something that we look at, frequently. And when we talk about, metrics, we've heard several times that there's a real need for consistent metrics across behavioral health. And I fully agree. There's a lot of measure sets we can look at for guidance, but there's not really one single measure set that we've all prioritized together. But when we do that, not only do we benefit because we can learn and we can make sure that folks get the right care, we can also understand from a patient perspective what their outcomes are like and whether they're getting their needs met through that system. And when we actually look at the assessments and the kinds of outcomes that we're looking at, like symptom reduction with patients during their service, research also shows that they're more likely to come in and actually complete that episode of care, and they're likely to get better faster. And so I think, to me, all of these things are kind of interwoven in terms of what does the best care look like, and then what are the tools and the resources that we need to navigate that well. And I think that's really where the data and interoperability and stigma, so I thought the point that you made about sometimes it's not the fear of walking into the building, it's the fear of when all of these things are connected, how does that impact other parts of that person's life, right? Or the care that they receive in other systems. I hear people, I know that from a data perspective, but I also hear people in a very personal way talking about that experience and how it's shaped how they think about their children's health, for example. I think autism is another, like in the IDD space, where you hear frequently that while it's helpful to have services, sometimes it feels like you're penalized for having that label attached to you or a child in the system. And so there are a lot of considerations when we think about interoperability and what's really helpful there. I personally am really looking forward to any opportunities that we have to learn from our experiences and from patient experiences, and to kind of factor that back in. Somebody mentioned practice-based evidence, which is kind of equally as important, I think, as an evidence-based practice, and really bringing those things together is going to give us the best shot at providing care that really works.
Thank you. As we sort of come to the end of our discussion here a bit, I kind of want to, Kirsten, you have deep policy experience, a lot of experience in CMS. I think the federal government in many ways is like a patient, right? We have different organ systems, and sometimes they don't always communicate well together or work well together. And so from a policy perspective, from an overarching policy perspective, not just ONC, what are some key levers that you would recommend to improve the utility and adoption of health IT? But really more importantly for me is, how do we improve outcomes with policy in this space?
Yeah, I think I mentioned, because I was afraid it wouldn't come up, and I think it's really critically important, this guidance that CMS put out in June of 2024, really kind of outlining the availability of enhanced match for state agency operated IT systems. So really building the platforms at the state level that can connect all of these dots and really improve care at the practice level, improve coordination between the different, programs and systems. It's important to recognize that Medicaid can't pay for all of it, but it can be a really good investment, a good way to organize a lot of that interconnectedness of care that's so important. I think that it's also just really important not to just excuse behavioral health from participation in quality improvement, value-based payment, because the IT isn't there. We really need to get beyond that. It's been used as an excuse for a long time. And I think that there are really challenges there, but it really does take more of a leadership, a federal, state effort to really make all those connections between different systems. A couple of examples. So the 1115 reentry, I was very excited to hear about that Louisiana is kind of on a track to get an approval there. That's a CMS Medicaid initiative to provide Medicaid coverage as someone's transitioning out of jail or prison. We know a lot of the people that NASHBID pays a lot of attention to and our members serve are the very seriously mentally ill, the people with serious addiction who often, unfortunately, get involved in the criminal justice system, cycle in and out of criminal justice system. But improving those connections is critical. And this Medicaid program, the 1115, to help states do that is a really important policy lever. But what I have heard that has proven very, very challenging, the most difficult sticking point has to do with the IT systems. So having criminal justice IT talk to healthcare IT, that's really difficult to make that happen. But even within the healthcare system, state and private, public, psychiatric hospitals, specialized treatment facilities that qualify as IMDs. Someone, I think the former First Lady from North Dakota mentioned on the first panel, that being a challenging issue in Medicaid, the lack of coverage in those settings. When someone's leaving those settings, it can also be, even if they're a Medicaid beneficiary, even though it's the healthcare system, there's big disconnection there and people get dropped off of coverage. So, these kinds of cross-system issues, there needs to be a lot more support. And Medicaid can be a part of that, but it's streamlining access to that, I think, is really critical, working with CMS to help support state efforts to access some of that support, finding other ways to provide support for those kinds of systems that make those connections, but at the federal and state level is, I think, critical for improving outcomes.
Thank you. Thank you for pulling that together. Ashley, I know we haven't heard from you as much. Do you have any thoughts on the policy piece?
Yeah, I think when you look at kind of the state of electronic records and other tools in behavioral health and compare that to physical health, and we see pretty dramatic differences. And I think there's, when we think about parity and the lack of parity, I think there are a lot of ways as that shows up, but there are also some opportunities that we have in front of us. If I think about like high tech in 2009, there was an investment of between $25 and $30 billion into the physical health space. And that system is clearly years and years ahead of behavioral health at this point. And so I would think about opportunities to align some of the investments with the incentives that shape behavior. And there are lots of levers of change that we can consider when we do that. But, if you think about, for my organization, we were working on accomplishing the meaningful use measures at the same time that we were doing things like MIPS or PQRS, right? And one of the core themes that I heard and across other organizations too is that sometimes the penalty for not participating is still less than the incentive you might have earned for doing it and getting it all right. And I think that when we look at incentives that are based in like the Medicare market, for example, community mental health doesn't have enough, they don't have enough people that are Medicare recipients. And so those incentives don't speak loudly enough to those organizations. So I might look at if there were, changes in requirements, certainly around common metrics, the more we can move toward that. I love this no wrong door approach. It's real hard to pull off, even in just our single health system. And so often what we end up with, and keep in mind, like Centerstone is now the largest nonprofit behavioral health organization in the U.S., which it's relatively new for us, but we have a lot of resources that smaller organizations don't. A lot of my colleagues, we came from smaller organizations. Centerstone was much, much smaller 20 years ago when I started. And I was part of the first team that piloted laptops in the field, if that says anything. But I think our systems tend to be kind of Frankensteined together. We have an EHR, you put data in, it sometimes can prompt you to do things from a clinical perspective that are helpful, but generally you're having to go and retrieve all of that information. And the tools that help our systems to better communicate with one another, we're kind of bolting them on and having to choose them. And so I think anything we can do that moves toward a common framework for measures that aligns the incentives in ways that actually speak to and shape the behavior of the groupings or the organizations who need to make the change, I think that will help. And I think holding all parties kind of responsible to the same goals. So, you know, we have the legislators, we have the behavioral health organizations or provider organizations. We also have vendors and technology partners. And so I think really focusing on what is the goal and can we all interpret that in a reasonable, reasonably like the same way. So even if an EHR today can achieve interoperability, it looks really different from system to system, and we need them to be more of the same. And I think that the burden and the cost of that typically does, a large portion of that falls into provider organizations to figure out. And so maybe there are also opportunities to offer technical assistance or things of that nature to organizations who really are trying to make that shift, but doing so in, like I sometimes say, it's like the road is riddled with potholes. Like it is really difficult to make all of these things connect. And the more that we can offer and support and be really intentional about how we align the incentives, I think will go a long way.
Please, Nathaniel.
So I had a sort of a pitch that HHS could do tomorrow, which is easy for me to say because I don't work at HHS. But so there's like 3 giant VBP models running right now. Access, MSSP, which is always running, and then AHEAD, which I think is quite large, at least in a few states. And so like one of the biggest problems since CMMI existed is the selection effects. People who apply for the models are not representative of all providers. And so that makes it like very difficult to scale over and over and over again and defeats the nationwide scale up. And so I think the opportunity within these major models is to have every sort of like major healthcare system find a partner that's like a mental health and substance use provider that doesn't have an interoperable data system, and then apply. And so you have like quite a lot of applicants. Like it could even be like within Access, like different sorts of healthcare systems within it. Within AHEAD, you sort of apportion it up. And once you have enough applications, like really encouraging people to apply, you could then randomize it at that level. So it's not a mandatory model, it's still an optional model, but within randomization of the applicants. I think if that's carefully controlled enough, you could set up a logic where because you're tracking total cost of care, and not just siloed costs because we know mental health affects multiple areas, you would be able to find if it paid off within the window, and then you'd have enough information for national scale up. And then like, since as more VBP models roll up, it would just be just baked into it because it's assumed to be cost neutral. And I think that would create like one sort of massive scale up mechanism that's not, a huge new Medicare incentive system, which would be, first best solution. Second best solution is in VBP, specific recommendation for whoever the note takers are. Thanks.
All right, thank you. My last job, I should have hired you for our research department. That's a pretty clever approach to that. I like that. In the time we have left here, I want to have the opportunity to sort of revisit anything we need to revisit. So if you heard something from another one of your colleagues today that really stuck with you or challenged an assumption you had, I'd love to hear that. Or if there's anything we just missed that's worth getting out here right now and talking about, I would love to hear it.
I think one of the things that we've talked a lot about, and I'm going to kind of not pick on Ashley on this one, but what you had said was it's a challenge, right? And I'm speaking more in that vendor sense. We want an interoperable EHR system, but we also want that flexibility, right? Because my behavioral healthcare agency looks like this and we do this, and so I want this workflow to get the outcomes that Nathaniel talks about quite a bit. And so in that flexibility of saying, when I go to this brick and mortar location, it looks like this, or I go over here, it looks like this, then how do we create kind of like systems? I don't think that we're ever going to get to that place. We all can't agree on one vanilla sugar cookie, right? I want chocolate chip, or you want snickerdoodle, or whatever it is. But I think that we're already creating that under ONC right now. You've got USCDI Plus for behavioral health care. So you're creating those data element and those vocabulary standards that we can all talk to when we do interoperable pieces, right? But now we need to define them. It's great to say, I want to see this in a behavioral health data set, but how do we define that data element? And I think that's a piece that I think we're struggling with as a kind of an ecosystem as a whole. But I also think that we need to look a little bit more holistically too, right? We have patient-facing apps that are sprouting up all over the place, whether it's through FHIR-based APIs or whether it's through other places, but HIPAA doesn't cover those. So how do we then get adoption to those? Can HIPAA then kind of go in and cover to kind of create that secondary layer of security as well, as long as we're doing different things? And I think that we also need to focus on cybersecurity. We've got the new revision hopefully coming out this year in regard to HIPAA cybersecurity and what that looks like, because all of us in the grand scheme of things, the more that we keep diving back into the IT ecosystem, I think it's important to kind of look at the safety of our data. So we want it to be interoperable. We want the kind of network of networks of being able to access things. We want those kind of prescriptions, those diagnoses, that ecosystem space, but we also want it to be safe and secure as well. So I think that there's a lot of things that are working so well in regard to health IT right now, but a lot of them feel still a little in their infancy, right? USCDI is still kind of chugging along, but we're not really pushing it in regard to certification. So does ONC have a space for that? When we look at the BHIT program, I'm looking at my colleague Stephanie because I'm working with her very closely on that in DC. How do we then kind of look at what does that pilot program bring to us in the behavioral healthcare space? When do we reflect on it a little bit and say, what can we learn from it, right? What did we grow from? What didn't work? We thought it would work really well, but it didn't. And then where's our areas of growth and opportunity? I think there's a lot of good places and spaces that we're already doing that I think we need to champion each other around. And there's a lot of ouchy points too, right? And I think that's kind of a good way to look at behavioral healthcare sometimes, right? But then I do think that there's some good successes out there that are already foundationally creating a floor for interoperability, AI use cases, and kind of all those different places and spaces that we've got out there. So not to be a Pollyanna about this, but I do think there's some good change going on in behavioral healthcare right now as well. Yeah, thank you.
Thank you. No, I don't think there's anything wrong with being positive. That's not making Steve.
Yeah, something Holly mentioned earlier that stuck with me was the disparate nature of local agencies and the fact that the data that they capture, the standards for assessment, for what they need to capture in order to get paid under their local program is so different from area to area. So, I mean, and because I deal with the post-acute space, I can see it the other way too, where in the post-acute space, if I leave the hospital in LA County or upstate New York, I'm going to go for rehabilitative services for my fractured hip. They're going to capture the same information on me in both places because they're going to be paid the same by the same place. And so it's created an ability from a vendor perspective, to be able to support that standard of care easily everywhere and have our medical record be applicable everywhere. Because there are so many variations of the data that need to be captured in all of these local programs, it means that we can't support all of them, or we have to really dig deep to determine whether we're going to be able to support some of them before a client can come on board. And what ends up happening is that a lot of local providers that they become niche suppliers who are really good at helping the people in that area meet the requirements and make sure that they get paid, but they're not necessarily certified technology through ONC, and they're not necessarily as interoperable. They don't have the experience or the technology to be as interoperable as some of the larger enterprise vendors. And so somehow, we need to get to a place where we do establish, like Patrick Kennedy was saying earlier, standards of care and standards of assessment and reporting that are consistent across all of these disparate programs.
Thank you.
Sure, and I would like to piggyback off of that with minimum data quality standards. So as Holly has mentioned, We were awarded the Behavioral Health IT Transformation Grant. We're working with her organization on that, as well as some pilot organizations in the district. So while organizations are connected to the HIE, these behavioral health organizations, and they're sharing data, we are continually working with them and evaluating the timeliness and completeness of that data that we receive. And that is not just for our behavioral health providers, that is for everyone who participates in the health information exchange. But because of all of the limitations in the past that that the behavioral health providers have experienced, there is obviously a larger gap in some of the data that we are receiving from some of these organizations. So I do think it's essential to think about those minimum data quality standards and the data that the providers can see, because I can move the data, and however I move the data on the back end with whatever interoperability standards doesn't exactly matter to that primary care provider that needs to see the data that they need to see in order to provide that whole person care. And so from my end, I really would like to focus more on the data that we have and the data that we don't have. And through our public-private partnership with Medicaid, which has been mentioned here, they are who designates us in the district and have a significant investment in everything that we do within the HIE from our inception to now, through also these technical assistance programs that I've spoken about. We have made great progress in that. But if there was something that was standard and enforceable, it would allow that investment to go a little bit further, rather than the district specifically working on the data elements that our technical expert panels have decided is important. It could be something that could be broad and far-reaching.
I'll keep going, Ashley.
Thanks. I kind of want to piggyback off of both what you and Holly and Stephanie said, and just say, I think the extent to which we can land on a common measure set or the minimum standards for that will really go a long way. And CCBHC is one of the areas that stands out, and so in terms of areas of consideration, I think that might be one that we could look at and do more with. The other thing I wanted to highlight is, I was saying before that there are opportunities to align our investments with other incentives. And so there was a comment, I think, Holly, while you were speaking about, I kind of connected that to, digital therapeutics and other kinds of technologies that help us to provide better care and all of the new interventions that are supported in that way. And, I'll say, so I do a lot of work also around the reimbursement and regulatory environment for digital therapeutics and AI and other things. And a lot of my work over the last decade especially has been trying to help the organization actually start utilizing some of these tools in real world care. And the hardest thing, it's actually not getting it connected to the EHR. There's a technical solution for those. That has taken a while, but we are able to do that. It's the reimbursement landscape too. And so if we think about in 2019, for example, this was a project I worked on, CMS updated the codes for these for digital therapeutics, for remote monitoring and assessment, and it added clarity in hopes that that would incent or help providers to be able to utilize those tools. And as a provider organization, we're looking at providing services in 9 states and in other parts of the country. And at the level of the state, you have to wait for the state to actually adopt the code updates, and then you have to go through and renegotiate every single health plan to add those to your contract. And so when you have a handful of contracts, that becomes increasingly time, it's expensive, the time to do that and the complexity of the plans and the wait period. And so, and even then, early days in trying to build those, a very low number of the ones that actually should have been eligible for reimbursement were still not reimbursed. And so you kind of end in at this point where you're like, is it worth it financially to add these codes, right, to be able to utilize these because of the burden that it takes to actually make those changes. And so when I think about that, I think about all of the different players involved and all of the different ways that we could shape our behaviors to get to that outcome. And so I think if there were more intentionality around how some of those rolled out, there probably are ways that you can also incent provider organizations to want to do more in those spaces because it's pretty hard to convince people to add all of these codes to our health plans when the chances are it's not going to be reimbursed, and then the reimbursement rate is so low that it doesn't always make up for the time it takes to document. I mean, we've multiple times kind of been in that scenario, I think, as behavioral health providers, and there's, I think, probably a lot we could do to advance that if we thought together about the different ways that we could shape behaviors.
Thank you. Susie?
So I'm listening and everything. I was thinking, okay, we're bringing up FIRE, we're bringing up USCDI, and I'm like, oh, that's what I was going to say. And then you're bringing up the policies, and I'm thinking that's perfect because I think of a couple things. We're going to be saturated in data. And then how can you consume the data and use it to look at trends, to make good judgment? And that was one of the things that came into my mind. We have business intelligence tools, as Patrick Kennedy had mentioned, a dashboard for each one of the different mental health kind of issues. We have the opioid surveillance dashboard within IHS. We have a telehealth dashboard within IHS. And how can you look at it real time to make decisions? The other thing that I was also going to talk about is with the EHR. And right now, our instance is where it sits at that site. But to have that integrated model, and then where ONC defines, I read all the rules, that's part of my role, the different types of, it's not called 2015 edition anymore, but the rules and criteria that you're putting into the EHR, so it is certified, so other people are measuring the same things within the whole country. Over. Thank you.
Thank you. Thank you. And Nathaniel, we'll end with you.
Oh, wow. So imagine, if you will, an RCT inside of a bunch of ACOs. I think the question becomes, like, what does it mean in literal terms to scale up, right? Like, you can't scale up some sort of like abstract thing within inside of a larger ACO. And I think the critical thing is not just to set it up as like this sort of like purchasing decision, but it needs to be a specific code, like a Medicare fee-for-service code, that let's say you can bill a single time to do this purchase. And then it becomes a test of that, basically. And if the test goes well, it's cost neutral, improving outcomes. Then across all of Medicare, you'd be able to build, like you don't for a mental health provider not able to achieve meaningful use, you can bill this one time to get the money you need to do your EHR purchase, and then like come in from the cold and begin to do standard sort of mental health practice as part of these systems. But I think the critical thing is making something that can scale up nationally to make the rest of what everybody suggests works.
Thank you. And we've heard so much in the last 90 minutes from standardization of the elements associated with mental health, standardization of payer system, standardization of requirements. I appreciate the focus on providers, having EHRs that are appropriate for mental health and capture of that data. And I especially, appreciate the prospective look of like, hey, let's make sure the money we're spending and the way we're doing this, we're getting the outcomes we want. Because I think we often fail in that. We're well-intentioned. We want the best for people, but the outcomes just don't meet that. And I think accepting that and trying to do it better is an amazing thing. And I appreciate the positivity that goes along with it. Because I do think with Secretary Kinney's leadership, it's a focus, and I think we're going to continue to push it through ONC. And I do think it is bright days for behavioral health, mental health, and substance use disorder. So with that, I'm going to remind you one more time, because I've been told it's really important. I got to let you know we're breaking for lunch, which you probably know because you're like, be quiet, I want to get out of here. The third roundtable will begin after the Secretary's remarks. His remarks start at 2 p.m. There's a cafeteria around the corner. In all fairness, I haven't eaten there, so I don't know if it's good or bad, but it is here. And but if you leave the building for lunch and you plan on returning, please make sure you give yourself enough time to get through security. The escorts will be available in the lobby starting around 1:30. And if you plan on being here for the Secretary's remarks, please make sure you're in your seats before 2 p.m. or you may not get to them. So thank you very much. Thanks for all the participants in the panel. It was wonderful. I appreciate all your remarks and your insight, and we'll see you soon.
I'm pleased to welcome Secretary Kennedy, co-chair of the Great American Recovery Initiative, to our discussion on how technology can unlock better outcomes and access to care for Americans struggling with mental health or the disease of addiction. Under Secretary Kennedy's leadership, HHS has a clear mission to follow gold standard science to end chronic diseases like addiction, to lower the cost of health care, and to help the American people live healthier and happier lives. The Secretary's work on dietary guidelines alone is a historic reset of federal nutrition policy with a clear, common sense message: eat real food. At 72 years old, Secretary Kennedy is a picture of health and clearly practices what he preaches. I feel like I don't look so good sitting next to the man, but however, for today's discussion, the Secretary's openness about his personal experience with addiction is a testament to the power of recovery. I have no doubt that the millions of Americans struggling with addiction could not have a better champion leading HHS than Secretary Kennedy. With that, please join me in welcoming Secretary Kennedy to the podium.
Thank you all very much. And thank you for being here. I want to thank the Office of National Coordinator for Health IT, Tom Keene, for convening this meeting. I also want to, I'm grateful to my co-chair, Catherine Burgum, who's been amazing, and to Patrick Kennedy, my cousin I know was here earlier, and who spent his life thinking about addiction and how to address it. And he's been an invaluable source of wisdom to all of us here since I came into office. And to all of you, providers, developers, advocates, and public servants who are doing this work on the ground. We're here to focus on behavioral health, mental illness, and substance use, where failure has immediate and sometimes fatal consequences. Nearly 50 million Americans struggle with addiction. Across the country, families are dealing with depression, anxiety, substance use disorders that often disrupt their lives and too often end them. We now are in a malaise, a spiritual malaise, where the highest cause of death to our teenagers is suicide. And too often our system is not helping. It's making those battles harder. Care is fragmented, data is siloed, providers lack critical information, patients fall through gaps that should not exist, and we're not going to accept that anymore. We're acting to fix it by improving coordination, enforcing accountability, and aligning the system around the patient. That starts with making health data work the way it should, secure, lawful, and available in real time to the patients and to the providers who he wants to provide it to. When a patient walks into a clinic, the provider should focus on care, not on chasing records across a disconnected system. I go to recovery meetings every day, and I hear stories often of addicts who've been to 20, 30, 40, 50 different rehabs. And at each one, and that's just a feature of this disease, is that people tend to relapse and they tend to move around. And when that happens, the new treatment facility is starting afresh in many cases, and doesn't have the benefit of the medical records across time for that individual. And as a result of that, they're not able to align treatment with things that other people have learned about the individual. And earlier this year, I signed a new regulation, 40 CFR Part 2, which will include law enforcement records in that health data. And those are private, they remain private, but when the addict, the recovering addict, the treated addict choose to share them, they're important things for the treatment personnel to understand and provide him the highest level of treatment. And that kind of coordination is critical to treatment. It's critical for all of us. Today, too many clinicians are forced to make decisions without a complete picture. This is inefficient and it's dangerous. The technology to solve that issue already exists. What's been missing is execution, and that's what we are driving now. Providers should have seamless access to all the information they need. Patients should control their own data, who sees it, how it's used, and when. And that's informed consent. And without that, there is no trust. And without the trust, the system doesn't work. And as all of you know, the first step toward recovery is honesty, rigorous honesty. And in order to measure whether the patient, whether the addict is being honest, it's very helpful to have somebody see his entire track record. We're also pushing innovation directly into behavioral health, where it has lagged for too long. Through $20 million initiative with SAMHSA, the Office of National Coordinator has launched pilot programs across the country to test new data sharing standards and strengthen integration between behavioral and physical health care. These pilots will produce the evidence we need to set stronger standards and to refine our policies and scale whatever we find works to scale it nationwide. And we're already seeing that in progress. In Florida, programs are connecting housing and job support services with mental health and substance use providers, recognizing that recovery depends on stability and not just treatment. In Massachusetts, public health officials are improving how we track substance use trends so that we can respond faster and more effectively. And in Connecticut, new electronic consent tools are giving patients greater control over how sensitive information is shared, while still enabling providers to deliver coordinated care. These are practical solutions, and they point the way forward. And better data will lead to better decisions and better outcomes. At the same time, we're expanding access to care. Telehealth has already transformed how services are delivered, especially in rural and underserved community. It removes that barrier of distance and time. What once required hours of travel and time can now happen in a single session over the cell phone or computer. And for many Americans, that difference will determine whether they get care at all. As all of you know, people who are addicted go through cycles of readiness to get help and then resistance to it. And it's critical that we can reach them in those little points of time where they've hit a bottom and they're ready to surrender and they're ready to do whatever they need to do to get sober. And if you miss that time, oh, Patrick, I didn't see you. I thought you were. I said some nice things about you that I hope you heard. We're also advancing the careful use of artificial intelligence. AI can reduce administrative burden, eliminate redundancy, and support clinical decision-making so providers can spend less time on paperwork and more time on patients. And this agency has done more, I think, than anybody, maybe with the exception of the CIA or Pentagon, to drive AI into all of our functions at this agency, into diagnostics, to patients' care, to record keeping, to fraud detection, all of those different things. And we've recruited an extraordinary group of, I would say, I wouldn't call them nerds, but I'd say people from Silicon Valley who are very, very smart about AI and are really transforming this agency in the way that we deliver healthcare. And all of those things that we're doing in physical health are also applicable to mental health and addiction. AI can reduce administrative burdens, eliminate redundancy, and support clinical decision-making so that providers spend less time on paperwork and more time with their patients. Used correctly, these tools will not replace physicians, but they are going to support them, and they're going to enable them to be more effective. This afternoon's discussion is about building those bridges forward. The people who can build it are in this room right now. You're not working in theory, you're building systems that connect, and platforms that function, and tools that are going to give us results for the future. And our role here at HHS is clear, which is to set the standards, enforce the law, remove barriers, and support innovation, and support all of you who are trying to improve the quality of care for addicts and for people who suffer from mental illness. We have the tools now and we have the data. This is an inflection point, a generational inflection point in history where people are frightened of AI with good reasons, but there's huge hope that we can use AI to actually reach people. There's so much fragmentation and alienation in our society today and isolation, and that ultimately is the cause of addiction. Addiction is a disconnection, and we need to figure out ways to restore a sense of community and restore interpersonal relationships. And as unlikely as it seems, you can use AI to do that. It can drive us apart or it can bring us together. And we're trying to make sure that to optimize its use in bringing human beings together and as a healing tool rather than a tool of control or domination. We have the expertise at this agency. We've recruited extraordinary people to do this. We're open to every kind of notion. There's nothing partisan about this issue. There's no such thing as Republican children or Democratic children. And the people that we brought into this agency are every stripe. We want to solve this problem. We want to make a difference. We want to change the way that addiction is treated. And we want to find new paths to healing our country and ending this spiritual malaise and bringing us all together again. So I want to thank all of you for the thought and energy and the personal devotion that you've put into this mission, and to tell you that we are here to help you. We want to listen to every good idea and figure out if there's a way we can implement it. Thank you all very much for coming here today, and thank you for your commitment.
Secretary Kennedy, I want to thank you for your remarks. And I think that the Americans who suffer from substance use disorder and mental illness could have no better an advocate in the Office of the Secretary than yourself. And thank you for everything you're doing.
Thank you. Thank all of you for being here. Thank you.
Thanks, everyone. It's tough to follow the secretary, so we'll do our best. Good evening, good afternoon, everyone. I'm Mark Atala, part of ONC, and I'm grateful for everyone being here today. Just to start off, grateful for Sam Carl to put this together. Thanks for all the work that went into this, and the ONC team. Mitch Cheney's here. I know she put a ton of work into this, so grateful for that. Just starting off, the session's titled Building the Bridge from Today's Barriers to Tomorrow's Systems. I think what the Secretary just outlined, and more broadly, I think we all hopefully share the same thought. The care that's delivered by you, either through your systems or through what you've enabled, is really the most human of care. So between mental health or substance use disorder, someone's struggling. And I think that the systems that are built are designed to bring down those barriers that people are faced with, really either they've created them through their choices and what they've done, and then the addiction that they've suffered. And so I think this question is, how can we help build bridges for them to not suffer? And so with that, we know that we have a broad set of people here between payers, providers, EHR developers, technologists, to really help talk about how can we build systems that really do work for people as they struggle. And so with that, if we can start with introductions, and Colin, maybe you can share what you do, and then also how health IT relates to your work as a starting point.
So thank you again. Manage my distance here. I'm Colin LeClaire, CEO of Connections Health Solutions. We operate urgent and emergent psychiatric facilities as an alternative to an ED visit, psych inpatient admission, or a trip to jail. And so the idea is the level of care that we provide is a step above an inpatient level of care. It's more acute, it's more emergent, but the modalities are similar. And so what makes us special and what makes our results so unique is that we're providing multidisciplinary psychiatric care immediately. So if you think about the day in the life of John Doe, who's having a psychotic episode, typically that patient waits 10 to 12 weeks for outpatient care, decompensating the entire time. Finally, they can't wait, they go to the ED. The ED is really not generally very well equipped to handle a high acuity psych patient. And so that patient will be put in boarding. They'll get some treatment in boarding, but typically it's just a holding pattern for an inpatient stay. They'll finally make it to inpatient care. The reason that our readmission rates are 30 to 40% better than inpatient care is not because the care that we deliver is that much better than inpatient care. It's probably pretty comparable. The difference is they didn't wait 70 days to get there. And so it's all about immediacy of access to a multidisciplinary care team. And then the second element is that we operate exclusively in value-based contracts. So we take accountability for the outcome, which I do think sets us apart in some important ways. So we're on the hook for making sure the patient doesn't readmit, that they get back to longitudinal care, and that we're coordinating all of their social supports, their medical supports, and really swinging through the ball, seeing that patient back to ambulatory care, making sure that they stay there is a critical part of our model. One of the things that I am an evangelist for, excuse me, is value-based care. This is a kind of a lifelong pursuit of mine, first on the medical group and multi-specialty side, now in behavioral health. And moving to value-based care requires some data fluency that just doesn't exist in fee-for-service medicine. In order to take longitudinal accountability for a patient, you need to be able to track their movements throughout the system, from everything that happened before they arrived at your front door, and then everything that happens afterwards, and concatenating all that data from all those disparate sources, from lab and from the ERX and the outpatient services that they accessed, and all the hospitals. It's an impossible task unless, one, you have an integrated system, an HIE and some other supportive services that brings it all together for you, or you're like us and you're just forced to. We had to go out and do this ourselves because we were on the hook. We had responsibility. So what we're here to talk, or what I'm here to talk about today, is not every organization and provider in behavioral health is equipped or capitalized to do what we've done, but we're working with them every day. When we send patients to them, we have to trust that they're going to do the right thing. We don't have great data to determine whether they're really high quality or if they're low quality. Are they really efficient or are they not? We don't know. We have to learn through experience. And we'd like to move toward a model, a world where all of those providers have an EHR. We have interoperability set up so we can trade information on these patients in real time. They have a longitudinal view, the same longitudinal view of the patient that we have. The coordination is tighter, the communication is tighter. And then you now have an environment where all of those other providers can take the same level of accountability and responsibility for the patient that we do. They can actually take responsibility for an outcome because he can measure the outcome and they can see the whole patient experience. So that's what we're really excited about talking about today. And I'll see.
Thanks, Colin. Kevin, please.
Good afternoon. There's a distance that you got to get exactly right.
Perfect.
Turn yours off, otherwise there we go. My name's Kevin Malott. I'm with NetSmart Technologies. We are an EHR provider. We focused for over 5 decades in human services. We started in the substance use disorder space and focused on mental health, and then over the last decade in the post-acute space. I first want to thank everybody on behalf of all the technology providers here for the feedback session today. There's been a lot of input, and we think it sets the stage for a lot of what's possible. Part of what we get excited about, I love hearing Colin's enthusiasm, since our organizations work together, familiar with it. There is so much more than just the EHR, and I know sometimes we use that broadly for what we're talking about when we say technology. But we at NetSmart are deeply focused on interoperability, not just for the sake of sharing, but actually putting data to meaningful applications and supporting the workflows that are going to take place whether we help them or not. So how do we use that in a meaningful way? And on care coordination, which was a good theme to see out of the last session, where that's different sometimes, certainly than maybe what the EHR does, and it's a broader set of services and people involved than the classic straightforward delivery of services with one person treating another person. And so I imagine we'll have a chance to talk about that. And then over the last several years around bringing AI into behavioral health in ways that are impactful, that are responsible, and that help us get past what some of the challenges have been for the last decade or two around making technology a positive impact in the delivery of services. So we're very excited to be here.
Yeah, thanks so much, Kevin.
Sitting back. Thank you very much for the invitation to speak. It's a real honor to be here and to represent Amazon Web Services. My name is Dr. Roland Illing. I'm the Chief Medical Officer of AWS, academic interventional radiologist by background. We've got a very privileged position because we sit across the whole data ecosystem. So we talk about, we talk to technology providers, we talk to end users, we work all the way from startups through large vendors, all the way through state and federal governments, providing that very secure, highly scalable data infrastructure that underpins a lot of the systems that we use today. Our aim is to improve the access and delivery of person-centered care, really accelerating the digitization and utilization of healthcare data at scale in a highly secure environment. I look forward to talking more about how we're doing that and how we're aiding interoperability by working with many of the players around the table today. So thank you very much.
Thank you. Please, Sarah.
Good afternoon, and yes, thank you for this invitation. I'm Sarah Steverman. I'm with the National Association for Behavioral Healthcare. We represent inpatient and outpatient providers in 49 states and Puerto Rico. We kind of run the gamut from inpatient, residential, to partial hospitalization, intensive outpatient programs, opioid treatment programs, as well as outpatient services and telehealth providers as well. We are excited to be here. I'm excited to be here because our members have really, been grappling with issues related to how they can demonstrate their value to, especially patients, I think first and foremost, but also to payers and other providers in their communities and their communities at large. So I'm excited to be part of this conversation and look forward to discussing how, as end users of EHRs and IT, they can be at the table.
Thanks so much. Dr. Snyder.
Thank you so much. So I'm John Snyder. I'm an internal medicine physician, first and foremost, but I also serve as the Chief Data Officer for the Health Resources and Services Administration, or HRSA, which is an agency within HHS. I'm also the Acting Director of HRSA's Office of Planning, Analysis, and Evaluation. I'm really grateful for the opportunity to join this really great session today to represent HRSA and to share our agency's viewpoints on this important topic. For those who are not familiar with our small but mighty agency, HRSA runs an array of programs that provide healthcare to people who are geographically isolated and economically or medically vulnerable. HRSA may not have the name recognition of CDC and CMS, but we run really important programs like the Health Center program. We support the nation's organ donation and transplantation network. We support poison control centers, home visiting, and Head Start. A slew of rural health programs, including telehealth support. So health IT is really the source of much of our agency's most valuable data assets that provide high quality data critical to our work, ensuring that our federal investments are accountable and meaningful and improving patient and population health outcomes. Thanks.
Thanks for being here. Nate, please.
Sure, good afternoon. Here we go, my turn now. Good afternoon, I'm Nate Tatro. I am with the Innovation Center at CMS. CMS, as Dr. Oz likes to call us, the payer. And the payer sounds like the next hero in a Marvel movie. And that may be appropriate because CMS, as you all probably know, is the largest payer for behavioral health and substance use disorder services in the country. Within the Innovation Center, I work on our Innovation in Behavioral Health model, now in model year 2. So we have 3 recipient states who are currently onboarding practices to participate in our model. In cohort 1, and just for the viewers at home, cohort 2 applications are open, and you can get that at our website. The work that brought me here over the past 15 plus years is I've had the privilege to work for several national provider and patient advocacy groups, including the American Psychological Association, American Psychiatric Association, and Mental Health America. And I worked with them all on health IT policy, going back, starting with meaningful use up through the current iterations of the quality payment program. So the perspective I bring comes from working with hundreds of psychologists and psychiatrists and those with lived experience of mental illness and their use of technology. And I'm really looking forward to this conversation today.
Michelle, please.
Hi, thanks for having me today. I'm Dr. Michelle Durham. I'm an adult child and addiction person, working clinically still and practicing virtually for a lot of my patients that I'm seeing. So I'm here first and foremost, I think, as a clinician, but my other role is at the Meadows Mental Health Policy Institute. At the Institute, I'm the Deputy Chief Medical Officer. Meadows really is a policy and programs in that intersection. So how do we bring what we see on the ground through different programs that we're doing both in the state of Texas but also nationally, and bring it to policy and make sure that it's rooted in evidence, but also that people, it's sustainable. A lot of what we've talked about earlier today, and a lot of people have said this, a lot of systems are doing a lot of EMR integration, the technology's out there, but what we're seeing on the ground is that people have a really hard time then putting that into practice in their day-to-day clinics. And that's a lot of the work we do at Meadows. And so I'm interested in the discussion today, but I'll elaborate too more on what we're seeing day in and day out.
Yeah, thanks so much for being here, Dr. Durham. Tim, please.
Hi, everyone. I think I got the distance just right. I'm Tim Platts. I'm a software developer at Epic, and specifically the R&D lead for our behavioral health module. So I work a lot with customers, clinicians, industry stakeholders to kind of understand how can we inform the development that we're doing in the future to best support patients that are receiving mental health care, substance use treatment, as well as the clinicians providing that care. It's a space that is evolving so rapidly, especially with generative AI recently. We're seeing so much movement, so much potential that we're unlocking here that is really exciting. There's a lot that we can do to improve access and outcomes for mental health, and I think Secretary Kennedy mentioned a number of things that we're thinking about too in terms of how we can apply the latest and greatest technology to this area. It's a area that's close to me particularly. I have a family member who has struggled with some depression and been in inpatient mental health services before. So it was actually at a facility that was using Epic. So it was very close to me and also like kind of comforting in a way that I knew that they were using the software that we had worked on, and kind of I knew the details of that software that was being used to treat someone who was close to me. So I'm really looking forward to this discussion today, talking about how we can continue to evolve how we're applying technology here to support these patients.
Thanks for being here, Tim. Ann, please.
Hi, everyone. I'm Ann Santifer. I work at the Arkansas Department of Health, and my primary role is to run the operations of our Health Information Exchange, which we call it SHARE. We think we have the best name. But with SHARE, our goal is to connect providers. So we connect to EMRs for hospitals, for clinics, behavioral health. We are also bringing in emergency medical services, or EMS. We are bringing in Division of Children and Family Services, foster care information, social determinants of health, prison clinics, the local health units, the free clinics that the health department offers, essentially just going around and connecting and aggregating data from wherever someone could be receiving care. And then we share that information back with the patient's care team. We share with the health plans, and then we share with public health. Right, the health department needs a lot of data from providers. So if we can offset some of that and direct them to use the Health Information Exchange, we're hoping to reduce that burden on our provider community. I'll just say that my title is HIT director. That's how HIT relates to me. But I'm not an IT person. My background's in quality and value-based care. But we knew, just like Colin said, that if we really were going to be successful in value-based care, data had to come along with it. So I was asked to serve in this role. So I'm glad to be here. Thank you.
Yeah, thanks, Ann. Cher is also a great name, so appreciate that. Please.
Good afternoon. I hope I'm in the right distance from the microphone here. I'm Matt Muma, representing another part of the payer community. I'm with the American Benefits Council. I am an attorney by trade. And we are a membership organization that represents over 200 of America's largest employers, as well as service providers in the provision of employee benefits, including health benefits. So I am excited to be here on the panel today, and I'm excited to hear the discussion.
Yeah, thanks so much. So we're obviously joined by an amazing group of people. So between federal partners, EHR developers, technologists, providers, payers. So really grateful, that you've all made the choice to come here, because we couldn't have this conversation without you. So I think with that, we'll probably follow a trajectory, starting first with the federal partners, talk through some initiatives of what we're thinking about on the HHS side, and then really move towards to value, I think, as a final conversations part of this, and to really hammer home how can the systems themselves deliver for people. And I think hopefully that makes logical sense to everybody here. If not, we can be agile and make changes based on where the conversation goes. So I'll first start with Nate in terms of where CMMI, thinking about how value that CMS can unlock and around EHR adoption, around really what excites you around health IT and the models that CMMI develops. Maybe a little bit of background on what how CMMI thinks about different incentives, and then how health IT really is used to unlock those incentives and enable those incentives.
Sure, yeah, and it's going to be hard if you were here this morning, we had two excellent roundtables that really delved into similar discussions. It's going to be hard not to repeat. The excellent points that have been made, I think it was Congressman Kennedy who said that you may have heard these points before, but you haven't heard them from me. So I will take a page from his book. But to your question, that question, it almost sounds like a two-parter to me, right? So we can think about the current state of EHR adoption and how we can use it to overcome existing barriers to care and promote innovation in healthcare delivery. And then at the Innovation Center, because we are forward-thinking, innovation is in our name, we can think more about the future of EHRs and what they want them to do in order to really incentivize innovation in behavioral health. And we've heard this recurrent theme of the history of this process over the course of this meeting, stretching back, like I mentioned earlier, to ARA and to high tech, and the beginning of the adoption of EHRs to the quality payment program and the promoting interoperability performance category. And we've seen, of course, payment and incentivizing being tied to the incentivization of the adoption of EHRs. Because ultimately, what the secretary, and tying to what the secretary just said a few moments ago, is we want the information to follow the patient from across the healthcare ecosphere, from care setting to care setting. And because if they don't, the providers are not getting a complete profile of the patient in front of them. So the biggest barrier that EHR holds the promise to addressing, which we've been saying now for many years, is to break down these care silos that we see in healthcare. And part of what we're doing at the Innovation Center is, we are mandated to test models to work toward that goal, and then, of course, centering that goal around different payment systems. So, for example, in the innovation behavioral health model, we are working toward the ever-present goal of moving from volume to value and adopting value-based payment and value-based care. And using EHRs as one piece of what we're doing within IBH. So, like I said, we're in model year 2, and part of my role is twofold. We're conducting a high-level health IT needs assessment across our 3 recipient states to determine their current state of interoperability, their adoption of, and the robustness of their health information exchanges. And then, as they bring on board these practices who will also participate in the model, both on the Medicaid and the Medicare side, offering these practices a small bit of infrastructure funding to address the fact that they were left behind in previous federal incentive programs to adopt certified electronic health record technology, number 1. Number 2, to begin to connect to their state health information exchanges. And something that folks may not know is not every state has a public health information exchange, right? So that's going to be a challenge both financially for the states, as we're seeing coming in, and also a challenge for the practice participants who are going to be participating in the model. And part of what we're doing to use that technology to move toward value-based care in the IBH model is more of a reverse integration model of care. So we heard earlier, of course, everyone is pretty familiar these days with in the primary care setting, collecting behavioral health information and inputting it into the EHR, and then hopefully having that information flow across the healthcare ecosystem. What we're doing in IBH, in a move toward value-based payment, using EHRs to address these barriers, is, and another panelist said earlier in the second roundtable, this no wrong doors approach, because many folks who enter our model, and we are targeting our model toward those with serious mental illness and substance use disorders, they may use their behavioral health provider, their substance use disorder provider, as their primary care. So within IBH, we are screening for those physical health conditions that we know are often comorbid with those with SUD and mental health conditions. So we're looking at hypertension, hemoglobin A1C for diabetes, and tobacco use. But we're collecting that in the behavioral health care setting. So as we're making that a model requirement, we're supporting them in adopting the technology that's going to make that possible. But that's almost old hat at this point, right? That's what we want EHRs to do, and that's what they've been doing in some form or another, to some degree or another, since the Meaningful Use program. The way that we are building on top of that in the Innovation Center with the IBH model is that we're looking to close that referral loop electronically. And as you all probably know, there really isn't a common architecture across the country for connecting community-based organizations. It was said, Congressman Kennedy said it on the first panel, looking at issues like employment services, housing, food insecurity, having that data digitized and flowing into the EHR on a data dashboard so that those bits of information are included in decision-making, in the electronic clinical decision-making that has to be done. And all that being tied, of course, to our Medicaid payment approach on the state side, and then direct from CMS in the Medicare payment approach. So that's the lay of the land, and those are some future prospects we have in IBH. And then really just to wrap up, my piece at least, is I'm sure you're all familiar now, there are other models looking at the use of technology in the Innovation Center. We have the Access model, of course, which I think just announced they have over 100 plus different partners who've been approved to participate in the Access model, which looks at the use of digital therapeutics and digital health in measuring and paying for outcomes. And then we have MAHA Elevate, which looks to integrate through an electronic health record system, which I think Tim may be familiar with, lifestyle medicine and functional medicine into the electronic health record, which again is a piece that Congressman Kennedy said on the first roundtable isn't necessarily measured as a piece of quality of care. We're really good at getting a PHQ-9 or a GAD-7 and measuring symptom reduction, but not so much looking at functional outcomes. So those are the sort of a few things that's happening at the Innovation Center with EHRs and reducing those barriers to care.
Yeah, no, thanks so much. And one quick follow-up on, so you mentioned the electronic referral loops. If you could maybe share a little bit more of what does that look like from the person that really seeks all their care from one provider, and thinking about how they're then referred out to other providers, and how important that is to the success of a patient or a person, especially in the context of the model.
Yeah, so what we've, how different these different community-based organizations work to connect to providers has historically been a phone call, a fax, something that's not integrated into the EHR. And we know that connecting, whether it's warm handoffs, whether it's helping someone get a cab, or when I worked inpatient in a previous life of mine in Pittsburgh, putting somebody on a bus to go to a social services unit, if they get there, that is a first piece of a closed-loop referral, and that frequently doesn't happen. And when that doesn't happen, we see, when I worked inpatient, we see higher readmissions rates to the inpatient. We see higher presentations to the emergency department. We see higher readmissions to inpatient. And that does many things. It drives up the cost of care, it reduces the quality of care, and it results in really poor outcomes. So hopefully within IBH, working with standards-based organizations like FIRE, the Sequoia Project has a number of folks who work on this issue as well. Really excited for the BHIT partnership with ONC and SAMHSA, so we can begin to tag these really important pieces of mental health and SUD data to better integrate the data from CBOs into EHRs.
Yeah, thanks so much. So moving to HRSA. So Dr. Snyder, the community health centers that you work with and support, they provide quite a bit of care across the country. I'd love some feedback and some thoughts on how to support the community health center, both between their workforce and the population and the underserved populations that they generally are caring for, and how EHR advancement plus technology just working for you. What does that mean?
Absolutely. I'd love to actually highlight sort of this flagship program of HRSA, the Health Center Program. As many of you may know, HRSA supports one of the nation's most important systems in the healthcare safety net. We actually serve 32 million people per year through to the system of health centers across the nation. Health center patients often face the greatest barriers to care, however, including poverty, high chronic disease burden, rural isolation, and limited access to specialty services. So digital health tools like EHRs and patient portals create opportunities for health centers to improve primary care delivery for patients and providers, as well as facilitate the seamless exchange of data securely, health information data. Now, EHRs, however, can be burdensome to gather data from and analyze. So HRSA has invested through grants and cooperative agreements the TA needs, the technical assistance needs of health centers as it relates to HIT. So in August of 2025, HRSA awarded over $53 million to 52 health center controlled networks, or HCCNs. These are networks that support over 1,300 health centers nationwide to leverage health IT and to deliver high-quality, comprehensive primary health care, leveraging data with a specific focus on increasing health center capacity to improve the quality of care, support community health, and engage in value-based healthcare delivery. HCCNs, or healthcare controlled networks, help health centers optimize workflows within EHRs for data capture, mapping, and reporting. And as a result of HRSA's investments, 99.56% of HRSA-funded health centers now utilizing the EHR system. Now, I know I'm talking a lot about community health centers, primarily focused on delivering primary care. As many people have emphasized today, primary care is pretty essential to behavioral health care. I mentioned in my intro, I'm not just HRSA's chief data officer, I'm also an internal medicine physician. I've been practicing part-time in addition to my federal role for many years. And I'll tell you, a significant chunk of my day, probably a third of my day delivering primary care to patients, is actually managing behavioral health and substance use issues, depression, anxiety, ADHD, and the like. I can vouch for this based on my own sort of clinical practice experience. But also, many people have long advocaate for better integration of primary care and behavioral health care, as well as sort of co-location of these services for patients. Primary care and behavioral care, health care are not separate items. Now, I'd like to talk a little bit about some bright spots and sort of challenges in this space. So let's start with some challenges. A lot of health centers are ready to exchange their health IT data, but not all of their partners are actually ready to receive it. So, for example, many health centers face challenges in connecting to their state and regional health information exchanges and registries, as well as to like third-party databases such as laboratories and non-clinical data sources. This is often because of incomplete IT architecture or perhaps barriers at the state, regional, and local level. Another major challenge and a pretty large data priority for HRSA is figuring out how to improve interoperability and data exchange across our grantees, as well as with the broader healthcare system. HRSA has actually been working in a great partnership with ONC for the last couple of years to try and address this and to facilitate more efficient reporting from grantees back to HRSA on their funded activities and outcomes. Our aim is to improve efficiency while also protecting the identity and confidentiality of patients who are represented in the EHR data. Also, in the sort of scope of challenges, I'd argue that a lot of patients are increasingly having to navigate a very complex healthcare landscape. They see many different types of providers at any point in time, and they need the ability to share their health data with hospitals, with specialists, with behavioral health providers. I'm not sure we've really figured out how to do this best on a large scale. In my own clinical practice, I'll actually refer patients to a specialist, and I often don't receive notes or lab results back from these specialists. In fact, I'm actually asking my patients, what did that specialist say? This is not the best way to deliver care. As the data brief that ONC just released yesterday shows, I would say too few behavioral health treatment facilities are using EHRs for the purpose of exchanging health information. They tend to use EHRs more for documentation. I think that's a space where we can do better. So I talked about challenges, but I want to highlight a few bright spots. I would say the healthcare system nationally is entering a period where advanced analytics, automation, and emerging tech like AI will play a larger role in supporting clinical decision-making, as well as operational efficiency, and the health center system is no exception. Looking ahead, one of the most important opportunities lying before us as the administrators of the health center program at HRSA is data modernization. Health centers generate a tremendous amount of clinical data. The real opportunity lies in, I think, translating that information into actionable insights. Currently, about 94% of HRSA-supported health centers are participating in these health center-controlled networks. It's actually the highest rate of participation we've ever had. And these networks are really at the cutting edge of helping health centers build shared analytics platforms, allowing care teams to, say, identify high-risk patients earlier, to close care gaps more efficiently, to monitor population health trends across communities, and to improve outcomes across those communities. So thanks for letting me speak just a little bit about HRSA's perspective.
No, thanks for being here. So I think that's 2 votes right now for better referral management, just in case you're keeping score at home. No, thanks, Dr. Snyder. So I think we've heard from 2 federal partners now between the CMS and the Innovation Center, and then HRSA in terms of how can we think about IT actually being an enabling factor. I think the concept of EHR is not just being record collection systems or ways to document care, but really to be enablers of care and enablers of outcome, I think brings us now to the technical side. So between Tim, Kevin, Dr. Illian, and Ann, I think bringing you into the conversation, I think we'd love to first start with how can we think about EHR's broader technology, use of artificial intelligence to both increase access to care, especially when it's access is critical for patients and people and their families. And then I think beyond that, how do we actually deliver some value and start thinking about outcomes and not just purely EHR serving as record collection systems. I'll start with Dr. Illian, maybe as a kick us off.
Great, thank you. It was a real privilege not only to work across the US, but also globally with a lot of health systems around the world. And everyone's suffering from the same problem, which is how do you provide highly secure and trustworthy systems on one hand, but highly scalable and extensible systems on the other. And that's why we're seeing this dramatic shift to cloud taking place at the moment. And we're working across organizations, and we're very proud to support the sort of state interoperability systems like MyHIN, so Michigan Health Information Network, and others to allow that data information exchange. Trust is really important, so how are we providing trustworthy systems at scale and bring in all of the trust controls that cloud computing can bring, because the checks and balances are there. It's obviously it's a shared responsibility with those that are building on top, but you've got to have really secure infrastructure underneath it. And then that will enable patients and care providers to access that right data at the right time. Part of what we're doing is also trying to get organizations upskilled in terms of the technology itself. So actually, how can they have AI-ready data infrastructure? And so how we're working across technology companies like NetSmart, for example, who are actually building out that technology layer. And we're releasing some of the latest technology into the healthcare and life sciences space with agentic solutions, so agentic services. So agents are software that are able to take actions on behalf of users. And so some of those back office functionalities that Secretary Kennedy mentioned around ambient voice capture and consolidating information in order to surface it at the right time, at the right place for providers, and also automated code extraction from care episodes. Some of that can now be agentic, and I know NetSmart is building that into their systems of record. And then when it comes into actually the delivery of care itself, it's that extensibility, and the scale is really important. So we're working with partners like Talkspace, and Talkspace can scale 6,000 providers, therapists across almost 4 million members across the US, providing AI-powered treatment personalization, and that can go across text and video and audio, and organizations like Ruler. And so Ruler can do matching, so they can do client matching with therapists, again, nuanced for language and cultural appropriateness and insurance coverage. And they can really address therapy deserts. So again, talking to low and underserved areas is really important. And we're also building out some technology to connect these things together. For instance, Amazon Leo, you may have come across, it's the low Earth orbit satellite network we're launching that will hopefully enable access to remote and rural areas with high-speed broadband internet that will enable some of this technology to actually get to the end users. So hopefully we're acting across all of the layers, both from infrastructure to scale to technology providers to providers themselves.
Yeah, that's great. So I think we've outlined really the cloud and infrastructure that can really enable technology to be implemented. I think now it would be great to talk through the actual technologies we're building and trying to implement for people and for patients. So Tim and Kevin, welcome your thoughts.
Yeah. Oh gosh. I think on the access front, I think technology has really shifted how we're thinking about getting care to patients. We did a really interesting analysis across Epic customers since COVID of the usage of telehealth across a bunch of different service lines. And of course, everything spiked up during COVID across all service lines. And then we saw somewhat of a decrease with most service lines post-COVID, but the one that had the smallest decrease and really stayed almost in line with where it was during COVID was mental health services. So I think it fits really well with delivering mental health care, and there's a real appetite for telehealth with patients seeking mental health care. I think it goes beyond just telehealth, though. There's a lot of other ways to get patients kind of access and that like initial connection with trying to get care. Things like just self-triage workflows, being able to use even conversational AI to kind of walk patients to a point where they can get to the right type of care that they're looking for. It's really important for mental health too, because seeking care could be something that a patient with a mental health issue decides they want to do in one moment, and it could go away really quickly. So if that moment is at midnight and they have to wait until the next morning to call a clinic or something, they might not actually have the will to do that the next morning. So I think it's really important that we have all those different entry points so patients can get access when they really want to seek access. And then I'll talk a little bit about sort of once patients are in the system, what technology can do to, enhance outcomes and have streamline things for providers as well. There's a lot of things that we're thinking about here, and I think it centers around having a really high fidelity patient story. So we want to make sure that, with all this data that we have so much data that we can capture. We have it all in one place, and it's something that can travel with the patient as they go to all these different points of care. So it's great to see things like the BHIT, USCDI Plus initiatives to really put BH at the forefront there and make sure that we're prioritizing having all of that data as something that can interoperate, can be available as patients see these different providers. And then once they're actually receiving treatment, and we want to make sure that the providers who have this wealth of data also can get to the data that they need the most in that moment to make informed decisions. And that's where I think AI plays a great role. We've seen AI be really great with things like summarizing large wealths of data, bringing data to the top of the chart. And that's really, I think, one of the best ways we can apply it is making sure that we're identifying certain risk factors about the patient, or making sure that elements of their history are being surfaced to the provider at the right point in time. It offers so much potential there. And then I think we talked earlier about ambient as well. I think that's an area where it's really growing as like the future of how we're delivering care. I've talked to a number of psychiatrists and therapists who have started to use ambient tools, and they just are in love with the fact that they can focus on the patient and trust that all the information that they need is going to be captured in their note, even captured discreetly after the visit. Sorry.
Are you turning up?
I had one word. Yeah, one more. Oh, you turned. Sorry. Where was I? I think that especially is extremely important for mental health treatment too, where it's a really vulnerable experience to go seek mental health care for patients. And if you're going into that visit and you're feeling like the provider is not giving you that face-to-face time, you're not feeling that engagement, it can be really demoralizing and not make you want to seek care. So having that avenue to still capture all the important information while you're providing care with ambient technology and AI charting really opens up so much more potential for the provider to just be focused on the patient. It also saves them time down the line when it comes to documentation. And then the final thing I'll mention is, as we kind of think forward with this, we've learned a lot recently about how we can apply AI to not only surfacing insights in the chart, but also doing more with predictive analytics. And I think as we have more and more of this data available, there's so much potential there for producing new predictive AI models for things like suicide risk, readmission, especially important when we're talking about capacity. How can we get to these patients earlier and get them the care they need earlier before they get to a point where they really need high acuity care?
No, thanks, Tim. Anne, please.
I was just going to piggyback on what Tim said about prioritization, because I don't think the technology is the barrier here. I think if a state like Arkansas, a flyover state, can create this interconnected system between providers, payers, and public health, I think other states can as well. I think prioritization is, what the focus needs to be. IBH is great. Maha Elevate, we have all these great programs rolling out, but if your state doesn't apply for it, then you don't qualify and you don't participate in it. So states are left in a position where they have to decide what do they want to focus on. So right now we're focused on moms and pregnancy, and we got the TEMA grant, but I think there's so many great opportunities too, but it takes someone prioritizing that and making it, the whole reason SHARE exists is because the legislature created an act and said, we will have one of these. It will be voluntary. And even those voluntary, we have all but 4 hospitals in Arkansas connected. We have 4,000 clinics. And it's really just about showing people and educating people and showing the use cases that matter to them, but also finding that fine line of, giving them enough data to where they're going to take action and they're going to prioritize it, but not giving them too much to where they're going to ignore it and just, this is just another report that I'm getting from someone.
Yeah, no, thanks, Anne. And I think the concept of prioritization is really, really important here. So, Kevin, would love to hear, what you've built out that you think prioritizes patients and their families in terms of care and that experience?
Yeah, sure, and I want to talk about outcomes in conjunction with that. I do want to go back to access just for a second because I'm a Kansan, and so Senator Marshall's comments this morning stuck with me. And he described what has been a difficult experience, suboptimal technology for way too many physicians. Dr. Snyder, I suspect you've seen that at times too. And so I thought both Tim and Dr. Illig described some of the uses of AI that are really impressive and making a difference. And one of the things that was shared earlier today was that we can increase the capacity, which is in some cases a great outcome. That equals better access. But one of the fundamental challenges is that we still have a shortage of clinicians. We have a high degree of turnover, and there's a tremendous amount of burnout. And so we need to deliver a better experience for the sake of people wanting to do the job. And part of what's happening with the AI solutions that we've been able to equip clients with is that it makes it easier to do their job. I was working with a client last month who they were dealing with some clinicians that they felt were very strong clinically and were not performing because they could not get over the technology hurdle. Everybody's probably seen this in one clinical setting or another. And we're giving them tools now which lowers the barrier of entry for somebody who may be sitting at a lower tech floor, and now they're performing at a higher level. They had an individual on a performance improvement plan and took off. And so there's a little bit of irony, but it's a good place to be where now the leading edge technology is taking us to a place where the barriers created by technology, which we all own, but we've created by trying to recreate a paper chart first, and then by saying it's great that we have all this data. Let's keep asking for more. And so we're solving those problems now by using AI to create a better front-end experience for organizations. With respect to outcomes, I think we have described throughout the day some of the things that I think we all want to see and that could apply. If we could all get there at a national level in unison, it would be amazing. And we've got quite a journey to get there. But one of the sub-themes today, I think, has also been that there are a number of programs that are having successes. And so much like Ann suggested around if we can do it in Arkansas, we need to look at what's working. And so I want to share one that's working, I think, very well, and technology has played a big role. The state of Missouri is, in the behavioral health world, some of you are likely familiar with what's gone on there. There was what started as a health home initiative, ultimately became really wrapped around CCBHC, and has created a tremendous impact on the consumers in the state. And I'll share a little bit about what we've done with technology to make that work very well. Two main things. Number one, equipping everybody in the state, all the community mental health centers, they are all CCBHCs, with a common care coordination solution. And so there's a recognition, number one, that that is different than what they do in the rest of the services that we provide. We heard Ashley from Centerstone talk about that as her first job. It's different, and the technology need is different. And so what that's ultimately made happen is in that function, we are all capturing the same data across everybody. So did we get to a true national standard? No. Were there lots of healthy debates? There are and continue to be. But we got there where we're capturing comparable information, and it's in a single system, so it's all stored in one place. And then secondly, it's around data analytics. So there is a data platform that we built. The Missouri Behavioral Health Council, a number of you are familiar with them, have sponsored this. And it is creating a centralized data platform where the data from the care coordination platform and from everybody's EHRs are aggregated. But it's also bringing in payer data. Medicaid data is flowing into that. The MCOs are flowing into that. This fits with some of the things that we're talking about. So we can now correlate data across a large population, the entire state of Missouri. We can look at claims data as well. And the kinds of things that are happening are, number one, we've got common data sets so we can have common measures. And you're looking at that both at a state level and individual providers. How am I doing relative to my peers? There is a baseline that has been established. But the other thing that we're doing too is saying we can go find gaps in care because we're not just talking about the EHR data, comparing it to claims. Who is or is not receiving services? Where a payer has an expectation, a provider has an expectation, and there's gaps in the data, let's compare those to see if there's actually a gap in care as well. And then finally, that is becoming the basis by which everybody is deciding where do we need to go invest next, and everybody is at the table, so that's done as a group. Are there still healthy debates? Yes. But those technologies have allowed us to get past some of those hurdles, which otherwise is a Herculean effort, and it's really many of the things that we've talked about today, but it's done on the scale of a state. And we're doing that now in other states like Kansas, Alabama, West Virginia, and there's even the initiative from SAMHSA, which we're very excited about, to pilot a data platform. That's equipping both these at the state level, whether that be policymakers or whether that be the association or individual organizations, to go determine what are the things we need to prioritize and that we need to go focus on. So we're excited about all of those efforts, but I think that there are a lot of examples that we can take microcosms of what we're talking about and apply those to populations that are meaningful, but not having to solve it across the entire country.
Yeah, no, Kevin, thanks so much. So I think moving to bring in really the rest of everyone that's here. So between payers, between providers, and associations, I think you have a magic wand now. So you have everyone here around the table. The questions on what should everyone prioritize that would give us the biggest impact, I think would be really helpful to hear. Happy to start, Colin. I think you probably have thoughts from the value-based perspective, but I want to bring everybody into the conversation.
So many thoughts. Yeah, I have an opportunity. I'm going to go through my shopping list. First, I think we do need a meaningful use program for behavioral health. We missed the boat a few years ago with not including behavioral health. I think I vaguely understand why, right? It's 42 CFR and all the privacy concerns, and sure, we need to get past that. I think when we look around our ecosystem of providers, the ones that are the glue that fill in the white space for the patients, not the inpatient providers, they all have an EHR. Not us, we have an EHR. The outpatient, for the most part, hit or miss, but most of them have an EHR. It's all of the social supports and services and coordinators, all the people that actually manage the patient, the glue in between all of us, no EHRs. So that's a big gap in our visibility into what the patient experience is. The work that they're doing is critical. Often it doesn't have a CPT code, it's a Z code or a J code or something else, but they don't bill for it because it's grant funded, so they have no reason to have an EHR. There's really no incentive for a lot of those providers to have an EHR. They don't have to bill. And as a result, they don't have one, and there's just these big gaps in the kind of the continuity of the data. So I think the only solution I can think of is meaningful use. Hopefully a little bit less administratively burdensome, but nonetheless. So that's one. Sorry, I'll try to move faster. Interoperability standards, I think, are exactly the right thing to do, right? The work that the US CDI Plus is doing is like spot on. Patient consent and commutable consent is a big issue, so I'm really thrilled to hear that that's being worked on. Ending information blocking generally, I think is pretty critical. We don't see a whole lot of this, but it comes up enough, and sometimes it's an interoperability problem. Sometimes it's, I think, EHRs are reluctant to try to accommodate every single API in the world, and so, understandably, there's some blocking. We need to resolve that. I think the result is, though, that, what we'll do is find that there's, better data liquidity for these patients. Everybody is reading from the same song sheet. We all have a more longitudinal view of the patient. We can all coordinate and communicate more effectively. I think what we'll see is better clinical decision making, and I think maybe most importantly, and back to my value-based soapbox, it will actually allow providers to take real accountability for the patient. They can see outside of their walls. There are not blind spots anymore. You can actually tell a provider, whether through carrot or stick, you are now responsible for the outcome. And they can't say anymore, how could I be? I can't see anything else that's happening outside of my walls. No longer true. I think it will create a system of accountability that just becomes part of culture, and this is at the core of it. So I think we're doing a lot of the right things. Love to see meaningful use.
Yeah, thanks, Colin. Sarah, please.
I think to pick up on what Colin was talking about, a lot of our members have a kind of a push-pull between quality, kind of trying to track quality at the individual level and then reporting at the aggregate. And this is something that you all know better than I do about, but when we have regulatory and payer requirements where we have to be, we being our inpatient and intensive outpatient providers, have to be reporting at the anonymized data, those data are needing to be reported on and held in a different way than what could be clinically meaningful. So I'll give you an example. The inpatient psychiatric facility quality of reporting program has new patient experience survey requirements. And those data need to be sent to CMS, and they need to be anonymous. And all of our providers have been collecting patient experience survey for years and years and years, and they really use it in a very meaningful way for them to know, which unit is doing a good job, which nurses are doing a good job, to be able to incentivize good performance, to identify gaps in performance and identify clinical units that need help or perhaps are not staffed properly. And the requirements from CMS are that these data need to be reported anonymously, and so they can't trace these data back. So our folks, our members, are at the point of trying to figure out, like, do we collect this twice? One way, segregated that we can use it, and one way that we can report to CMS. And it interrupts the clinical flow. It interrupts the patient-provider relationship, which is, as we all know, like the most important part of effective care. When our providers have to be asking more than once for the same data. So there's some real, I think, kind of concerns that our folks get when their regulatory requirements come down, when they're not involved in the decision-making, because it does interrupt the clinical, kind of the clinical care that happens on the ground.
Yeah, no, thanks so much, Dr. Durham. So I think, really bringing in, beyond just the EHRs, I think it would be great to hear your perspective as a clinician, and more broadly, how can we actually make this real for patients and their families?
Yeah, I think I'm going to shift the conversation just a little bit because of the fact that at Meadows, not only what I'm doing clinically outside of Meadows, but at Meadows, we work a lot with folks in small clinics to big health systems that have an EMR, actually, have vendors, so tech vendors that have come in. And it's a little bit to your point, Anne, of what are you prioritizing in your clinic or in your health system? And when there was money, from some of these, because we're working both in Texas but also nationally, so there's been money, essentially philanthropic dollars sometimes, or grant funding, and they're like, okay, now we want to do this because we actually have the space, time, and funding to do it. And so they have all the tech there. And what our team really is doing is a lot of training, technical assistance, and implementation work. Because we can get all of this done, and I think everybody today has said, we want to do this, we want to share, we want to stop siloing, we want to coordinate for patients and families. And even if we do that, on the ground, it's quite hard for people in good faith and that they want to do good work to really do it in a meaningful way that has good outcomes, and thinking about measures. And so we're really on the ground from day one with not just the clinical champions, to your point as well, of thinking about, are there providers in the room where we're making a lot of these decisions? So there's clinical champions from primary care doctors to behavioral health clinicians, because we do a lot in the primary care space of doing the collaborative care model, right? It has billing codes, so we have billing people at the table, and also IT. And really thinking about, as a team, how are we going to make this work in this, maybe a clinic with a pediatrician or an internal medicine or family physician seeing 2,000 to 4,000 patient panel, versus a health system, which is a very different thing to look at, but also need that on-the-ground technical assistance. And we're not going to get anywhere. We can have all of these things work, but I think we do see and firmly believe that you need funding, though, for that implementation support at the beginning. Even if you want to add a behavioral health clinician into a primary care clinic, you're going to have to pay. You're going to have to pay for them for those first 6 months to a year until they start becoming sustainable. We have a whole model of thinking about the pro forma, and if you're an FQHC versus a clinic that maybe has a lot of privately insured versus someone who sees a lot of Medicaid and Medicare, when will you see sustainability? When will you not need more grant funding to make this work? And so that's a lot of what we're thinking about, and what we see definitely with, because we have all the vendors and we've been working with a lot of the neuroflows of the world, and we see them, in various clinical settings, and they also have told us, we get there and we have this great product and they bought it, and now it's not doing what we know it can do, actually. And so that's our job. We have a full team doing that work. And then I think the other side of it, though, is I mentioned, clinically I'm a child psychiatrist and I'm seeing kids and I'm working for a startup. So Meadows is not clinical at all. It's a policy institute. But in my other job,
We also have an EMR, and I have the Mira. That's what they're using in this particular program I'm working with. And I don't know if I should say this in front of everybody and being recorded, but I always don't go look at the data because it's another system that I have to click 3 more boxes and I have a full caseload that day. And so sometimes I do, depending on my clinical judgment of like, this is an important case where I really need to go see all the data that's been tracked, for the last month. And I think that just gets to the reality. If the day is busy, things happen. And so that integration piece is so interoperability is so important of like, I don't want to go to 4 systems to figure out what's happening with the person in front of me. I think early on in this conversation, I think it was one of the senators said, 1 EMR nationwide, and I don't necessarily disagree with that point. As a resident working in a VA system, I thought it was lovely. I could see what happened in California to the vet, and I was in Massachusetts. And so it's just really difficult when we start having all these other tech, because we know it's there, everyone is saying it's there, and yet they don't talk to each other, even in right there, the patient's in front of me, and I'm telling you, I don't really want to click through 5 things to get to that, when I have to have a whole conversation with them at the same time. The last thing I want to say is about, there was a lot said about what measures and what are we doing? And so Meadows, we have had a couple of convenings already with national policymakers, payers, at many different, insurers, organizations, but also some other state and national organizations, really starting to ask that question, right? Of like, okay, because payers is a whole different ballgame too of what insurance is going to pay for what metric at what time interval, which measures. Some of them don't measure functioning, and we know quality of life and functioning is key in mental health and substance use, and key to life, right? That are you functioning? Are you doing the things you love to do again? And so, but nobody's really talking to each other at that level of, is it really the PHQ-9? Is it the GAT-7? Is it some other functional measure? And so we are trying to form a consensus statement at the national level with Meadows really leading this and thinking about at least what would that look like? Because there's not enough information out there on what is, or what are 1 or 2, what are the things that we are going to measure for good outcomes for people ultimately.
That's fantastic. So I think what you highlighted was really a lot of design questions. And so those could be system design questions, technology design questions, payment design questions, which is a great segue, I think, to Matt, and benefit design. So I would love to hear payer perspectives. How can we advance this and use technology that works?
Thanks, Mark. And thanks, everyone, because this is a great forum for thinking about all these different issues. And I'm going to take a step back as the lawyer to the payer community here and to talk about how for the employers, for America's employers, it's terrifically important that their employees and dependents get high-quality care. We hear more and more from employers wanting to facilitate their employees receiving value-based care and the best possible care. And to the extent there are barriers between providers and payers speaking to each other and capturing the right information, that makes it harder for employers to facilitate their employees and their dependents getting the best possible care. And we hear over and over again that behavioral health is one of the big drivers of cost and something that employers want to get their arms around to both get better outcomes to their employees and their dependents and drive down costs. And listening to all this conversation today, I could think of it coming kind of along 2 different tracks here, maybe more than that. There's like a legal track and then there's like a tech track. And on the legal side, one thing we're really focused on is breaking down barriers, getting people care when they need it, and getting data that's useful to the payer community. I've been heartened to hear a little about telehealth today. We were really supportive of recent legal changes that made it easier for patients to access telehealth and for payers to pay for that telehealth. That can be terrifically important when people are having a mental health crisis. But I'd also like to echo what Colin was saying about sometimes we have information that's not legible in the system. And if things aren't being coded properly and things aren't being communicated back to the payers properly, then payers won't pay for them or won't know the value of that care. And so what I'm hearing is sort of like a need for ongoing discussions like this and ongoing collaboration like this to communicate between the different stakeholders here, between employers and the plans, TPAs or issuers who provide the administrative benefits, and then providers in communicating what has value and providing that data in a way that's useful so that ultimately payers are paying for things that drive good patient outcomes, and interested parties like employers can facilitate their employees and their employees' dependents getting the best possible care, which ultimately will drive down costs and make this country healthier. So this has been, for me, a great learning experience with all the different tech side issues here in thinking about how to get that information back to payers so the best possible outcomes occur for their covered lives. So thank you.
Yeah, Matt. No, so just one follow-up. I mean, as you think about your members and then really bringing benefits more broadly across the country, I mean, how do you think about the role technology plays, the role systems design can play? Maybe unpacking a little bit of the benefit side or the care side would be really helpful.
So one thing that it makes me think of, it's been something I think has been a pending program, is the Advanced Explanation of Benefits, which was enacted into law as part of the No Surprises Act. And one thing that we are hearing on the payer side is that the technology platform or integration for payers to talk to providers and make that actual advance notice of what a cost will be to the patient work is just not there yet. And so that's the sort of thing that we would love to see prioritized, and that where tech, I think, and the ability to communicate useful information about these patients in real time would be incredibly important to alerting people in advance what their healthcare costs are going to be, because that's something on our side we hear a lot about and have a lot of trouble with, which is people are oftentimes afraid to get care, confused about what care they need when they can't see really good cost estimates in advance. And we've seen, when I was in government, we've worked on a number of programs to make that work better, but there's still, I think, a big technological hurdle there to get them a last mile to get that actual dollar sign out to patients to help them get the care they need. And so that's something that tech can really help with in facilitating these legal programs getting off the ground.
Yeah, no, thanks, Matt. And so we actually have that on the pharmacy front now. So ONC finalized a rule last year really to enable that around real-time prescription benefit pricing. And so we've seen adoption really increase, and that patients with their provider can know at the time of prescription really what the cost of the drug is. So they don't need to suffer when they show up at the pharmacy counter and can't actually afford the medication they were prescribed. They can actually change the medication to one that's covered for them under their plan and actually start care and therapy at the time there. So we really have two extra parts here. The first is going to be an open conversation that I hopefully bring everybody together to have a conversation on what to think through, and then the last will be as we wrap up, really what prioritizations you guys think through. So I'll start with Nate and Dr. Snyder in terms of kicking off really for an open conversation. What did you hear today that either challenged something that you came in with that you want to emphasize, that really to move us forward based on bringing everyone here, all the expertise and different perspectives. Would love your opinion and thoughts.
Sure, yeah, and it's really interesting being on this side of the conversation as a Fed for the first time, having worked on this issue in mental health. A couple of things that stuck out to me, but I do want to go back to what Michelle was saying, particularly around the need for robust technical assistance, education, and support for providers on the ground in the adoption and integration of the technology. As an example, I'm not sure how many of you out there have ever purchased and tried to assemble furniture from a certain Swedish company. It's very popular, high-quality furniture. I don't speak Swedish. I don't read schematics. I can't assemble that furniture. I need support, so I go to YouTube or I ask some very patient people in my life to help me with that. Not to emphasize what the importance is. What I've heard from psychologists and psychiatrists throughout the years is there's not just need for understanding the technology out of the box and how to use it. It's how to make sure it's integrated appropriately into some very unique mental health clinical workflows. Understanding the very complicated regulatory frameworks that we have at the federal level around sharing not just general mental health data including the provisions in HIPAA for protecting psychotherapy notes. And then we talked a lot today about 42 CFR Part 2 and its harmonization with HIPAA for treatment payment operations. What does that mean? A lot of these issues we see with providers make them very skittish about integrating technology because they don't necessarily know what they're getting into. And put into that, not just the federal regulatory and legal framework, but at the state level, different health information exchange policies around opt-in versus opt-out. And those are changing all the time from the perception of a lot of these providers. So I would say that technical assistance, that the ONC has a lot of good stuff out there. My colleagues at ONC, OCR has a lot of good stuff out there. SAMHSA has a lot of good stuff out there. We can go to some of the tech companies at the table. I'm sure you have a handbook on how best to help to implement the technology that you've spent so much time developing. But really, on the ground, TA is probably going to be the number one thing I would underscore. The second thing that really struck my attention was when Colin said we should have a meaningful use for behavioral health. I can unpack that in a variety of ways, but if I'm just waving my one magic wand, I do think there is some degree of optimism in that the ONC, as it's reassessing its certification program, thinking through being more API forward and API leaning. What does that look like for non-providers' use of technology and the use of FHIR APIs to begin to connect some technology collecting information from these community-based organizations or social workers, non-medical providers, and having that data flow into the EHR. I think that could be an opportunity as well.
Great, and of course, obviously, we want to help people struggling with mental health and behavioral health and substance use issues, but I would really love to give a hat tip to Kevin, actually, for kind of pointing out that tech needs to also make it easier for clinicians to do their jobs, right? Like, I think this is so important. I've seen a lot of research that says that technology and AI not only doesn't save time for providers, it actually adds time, right? And I think that we need to be really mindful of burnout and of retention of healthcare providers, particularly in safety net settings where it's already very difficult to recruit and retain providers where they're most needed. I will say, to my own practice, some of our early AI tools, like, for example, like the ambient sort of like future of like listening to patients. Patients are really wary of having like a speaker like listening to them talk about their mental health issues. There are some things that like I think are great ideas. They're hard to actualize. But recently, my practice actually provides sort of draft emails to like interpret lab results and help communicate them really clearly to patients. And I found those really helpful. I do think that they need to be personalized so they sound like they come from a human being. but I do think things like that could be time savers and in turn could be useful tools to reduce burnout.
Thanks so much. I think to unpack that a little bit further in terms of so the patients that you treat, how are you viewing the technology in terms of how you think they would like it? And that'd be great to understand.
Oh, that's a good question. So, like on the app from an app perspective, or just from using the tools?
So we can use ambient as an example. So, Dr. Snyder's point, do you think people are comfortable? This is a sensitive subject. Do I want AI listening?
Yeah. Just for the most part, not just from me, but also from colleagues who are two different systems that I have colleagues in. Our patients are okay with it, and they agree. We have to ask each patient, right, if they're willing, because that's not part of the consent. And so overall, I would say people have been fine with it. I think on the flip side, notice that during like intake notes versus a follow-up note, it hasn't been as great, what's been transcribed and ready for our review. So that's my N of one in our clinical setting, but this is with, there's about 15 child psychiatrists and probably about 100 child therapists in this particular model that I'm working with. And so there's work to be done, but to your earlier point, Dr. Snyder, that part worries me about the research that's coming out about AI. One was out of Boston and MGH, just recently out of JAMA, right, that you think AI scribes are saving you all this time, and it was like 5 minutes at the end of it all. And I think that worries providers on the back end, because it's like, well, are you just going to start from the system, or are you going to just start putting more patients in my schedule? And as I'm not a primary care doctor, but I know a lot of primary care doctors that are already seeing like 15-minute full physicals, you know, and you're like, what's happening in 15 minutes? And so, but that is a worry from the provider side too, right? Like AI is the thing, and yet research is starting to come out. And so I'm not against it at all, and I think most of us in the field aren't against it at all, but what I would love to see is more research dedicated to it, and different models from your FQHCs, your CCBHCs, to your, like, you know, I'm in a startup world in the job I'm working. So it's a startup company. It's not an academic medical center or your public hospital, you know, in a city. And so that sort of worries me. The other thing I just wanted to say, and it was a little bit about what Colin mentioned earlier too, about just maybe it was like crisis services. And unfortunately, you know, literally just Friday, I had a kid that I had to send for mobile crisis intervention. The mobile clinician goes out, and the only way I found out is because mom told me later. They came and they went and they said, you know, she doesn't need to be hospitalized. And I'm like, wow, you know, there was no one called me, and I'm the one who thought that she should go in to an inpatient, that she needed a higher level of care in that moment. And that literally just happened Friday. Then no one called me. Then I'm searching around. Then mom gives me a call again. So mom is the care coordinator. And that it should not be happening in 2026, right? We really need to have systems of care that coordinate with each other, that I could maybe, that's where I want to get like a text or something, like your patient has just been hospitalized. And then, but that the parent who is scared and frightened, just like that kid, is sort of, everyone's sort of freaking out because it's a crisis and she ended up being hospitalized, that, you know, we don't see how, that's how I would love to see more connection happening in that care coordination piece. So I really know what's happening with my patients, and maybe, you know, less of, you know, the AI scribe for me. I feel pretty efficient in my notes, but maybe I'm just giving myself a pat on the back. But those things are important. I think, you know, having providers at the table thinking about it in real life, what's happening. And on the flip side, I do think that integration and really coordination, that anything, you know, where do we innovate in that space? And if it's there, how do we get it to more spaces?
So welcome other thoughts in terms of across, you know, what did you hear today, even including now? You know, so AI is here. AI will continue to have more of a role. I think the question on how do providers adopt it, luckily you guys are all sitting there, and then Tim's over here. So I think maybe some conversation on what does this look like in terms of bringing providers on and actually enabling them to offer better care to the patients that they want to see.
I'm very happy to jump in. I mean, in terms of the things that surprised me or kind of interested me about this particular conversation, I think the discussion about new models of care is really important, and some of the, you know, the points about how you can deliver things differently, and then how we can lower the technical barriers of entry to those things. And I think making the technology disappear into the background to make it so easy for both patients and providers that it doesn't become a technical burden on the providers themselves to try and use these new things is actually make it really, really easy. And we've seen that adoption, you know, the technical adoption by baking it into the technical platforms like NetSmart, where, you know, they're across NetSmart, for example, that have adopted that ambient scribe technology and some of the care consolidation, the records consolidation tools. You know, the adoption has gone up by 275% with all of the clinicians that are using it across NetSmart. So I think we're seeing a real uptake of clinicians by adopting that technology. But it's also, as you say, also how you can get patients to be stewards of their own care. And it shouldn't be parents that look after their own children, but it should be easy. And again, we're fully supportive of the HHS push for AI, you know, and cloud adoption more broadly to enable people to manage their own care. And I think the tools are now getting there. And I think we're at a real pivotal point where we're putting care really back into the hands of individuals, mediated through proper consent and all of those tools as well. So I think we're at a very exciting time.
Yeah, I mean, Dr. Durham, to hear you describe the experience you have, I think it resonates with those of us who think about how do we deploy this in a meaningful way. And Dr. Elling put it very, very nicely. I mean, we have, through AWS, the ability to go build these in really impactful ways. But I do think, Mark, there's another part of the question, and that is that there is the barrier of having the technology meet the moment, equipping the individuals using the technology to get the most from it. But the other part of it is, in this space, there remain meaningful economic barriers to adopting it. And so I think about programs like what Nate's representing. It's great to hear him talk about IBH, but I think a couple of things. Number one, this program that has the potential to be groundbreaking is that because health IT is one of the core pillars of that, and we need more of that in some of the programs that don't have that as a piece of it. But second, we dramatically underfunded it. We're of the view that we should have another $140 million in that program to really extend the potential benefit of what we think it could be super impactful. But then third, we've also got to be specific about how those dollars can be used. We need to create mechanisms where we can reimburse AI behavioral health use cases. It is, in the absence of meaningful use for behavioral health, because we don't have it today, we need to go find those targeted programs that have prioritized technology, fund them properly, and then ensure that we're capturing the use cases for AI that can be the most impactful in the next couple of years.
Yeah, I would add from a provider standpoint, we're actively involved in AI deployments. We use NetSmart as our core engine, and then we supplement where needed. And all of our AI initiatives are focused on cutting admin costs, in particular on clinical support. So, the number one chief complaint, I think, since the beginning of time from clinicians is I spend way too much time documenting and redocumenting, rereading. It's painful. It's one of the primary sources of burnout. So we now use ambient scribing. We use an MA-led kind of interviewing solution that takes the physician out of it at the beginning, and they come in and read the notes and ask follow-up questions. And we're adding all these little efficiencies. But the one thing that we do struggle with, Michelle, this is to your point, I think, is how do you redistribute the found resources? And I think we're at the very beginning of this. We're ahead, I think, of most providers in the behavioral health space, and we're really struggling with it. And I think providers are going to need this guidance. I think it is okay to recapture some costs. We need to find a way to pass on lower costs to the customer. We need to find a way to reduce the cost of care. So it is okay to recover some of that cost. But you also have to give clinicians time back, right? So they don't spend 20 minutes with a patient, they spend 25 now, right? And then you want to be able to create more room for other initiatives that you couldn't otherwise afford now. So how do you redistribute the benefit of AI so that everybody in this sort of chain wins? It's not, use AI, get 20% efficiency, and then have physicians do 20% more work. That's not going to solve your problem. So we're struggling with that. I think it's something that we're going to see as a major trend as people get more involved in AI projects, and this is going to bubble to the surface a lot over the next couple of years. I'll leave it at that. Let others speak. But
no, yeah, thanks, Colin. So I've got 10 minutes left as a group. I think if we can maybe go around, I'll start with Matt first. Really talk through prioritizations. So really concretely, what should we focus on? What should we be thinking about that would have the biggest impact really today and then in the coming years?
I think hearing everyone on the panel talk about this is really bringing home to me that we need to make a priority perhaps to my mind as a practicing attorney, the sort of small bore but really important care coordination tech that would prevent what happened with you, Michelle, where the doctor recommending something is not looped into a treatment, because that can lead to exactly the kind of care problems that employers would rather not pay for. The second thing to be related is that I want to put a plug in for patients in collaboration. Sometimes I think the provider and the payer community wind up feeling antagonistic. But something that this conversation is really bringing home to me is that a lot of just like on the regulatory side or the payer side, on the provider side, making technology work and making processes work better takes time. Sometimes there are, I don't want to call them false starts, because ultimately you learn by experience, and if you see something doesn't work quite the way you expected it to work, you pivot and make something work better. And that's something I have a lot of familiarity with from working in the federal government and working on regulatory initiatives. So just kind of an overall pitch for remembering that making the system get better will just take a fair amount of work and a fair amount of time to get through. So thank you.
I'm going to blow your mind, Michelle, but we have this thing called encounter notification services. So it does exactly what you want, which is to notify the physician that their patient has had an inpatient or ER visit. And it's like really low-level tech for HIEs. So if that's something you're after, your Health Information Exchange can provide it to you. That's our most popular product. And, you know, going back to the workflow and education, when we bring in a new clinic to our exchange, we don't say, here's something and it's out of the box and this is how you're going to use it. We take an approach of learning their needs and then trying to incorporate our tools into their existing workflows, right? That's better for the patients, for the providers, for the support staff that's doing a lot of that pre-visit planning. So I'll just leave you with that. If you're not working with your Health Information Exchange, I highly encourage you to. If you don't know who it is in your state, reach out to me. But as far as, you know, the future and AI, things that we want to focus on, and I think every state's probably going to be a little bit different. For us, I think patient access is needed. I think the capability is there. What I'm struggling with at the moment is the identity piece, right? How do I know that Nate who's requesting those records really is who he is? So once I figure that part out, we hope to have a patient access tool. And then, you know, just as selfishly for your HIEs, you know, we're your last mile. We know your providers. It's all about choice, especially when you're dealing with states in the South. I know there's been a lot of conversations about a single EMR, but at the end of the day, people want choice. And an EMR does a lot more than capture healthcare records. It's also the provider's billing systems, and they want to have those local codes so they can bill appropriately for their own organization. So things to think about when we're talking about a single EMR for all. Just keep choice in mind.
And we can help you on the patient matching piece.
So I solicited feedback. We meet monthly with a group of behavioral health clinicians who are at a variety of EPIC organizations to kind of talk, just get their insight into how we're thinking about the future. And I solicited feedback from them on this question about if you could say something to the government, what would it be in terms of a meaningful change that would help you? And the consistent theme was related to 42 CFR. I think it was 42 CFR Part 2. It's obviously something that was very well intentioned, but there's been improvement with, you know, single consent and trying to make things easier in that regard. But a lot of them still felt like this is something that's really kind of a burden when it comes to like getting the right information about the patients that I'm caring for. Two of them actually work both in San Francisco. They know each other personally. They work at different organizations though, and they said they constantly struggle with like they're seeing patients that they know are getting care elsewhere, and they're still finding they're like missing out on getting certain pieces of information. So it's a tricky thing because organizations also I think tend to like they're overly conservative with how they interpret it, and they all interpret it a little bit differently, which can cause barriers as well. But I think Mr. Kennedy made a great point earlier when he was talking about just the patient safety aspect of it as well, and how, you know, we really want to make sure that this information that could change how you're, you know, providing anesthesia to someone in a really meaningful way that can impact patient safety is readily available. And then the other point I wanted to make was, you know, I think we talk a lot about like ending the stigma around mental health, and I think this is something where the intention is to make people feel safe about their mental health, you know, substance use kind of data. But I think when you're telling patients that, you know, this is all this other data out there, including like HIV information, this is the one thing that is different, that's like other, that we're gonna like restrict, it almost serves to like kind of lean into that stigma. So I think it's obviously a really tricky area, but I think the one thing that I heard the most from a number of the clinicians that I talked to was around 42 CFR Part 2.
I think I'll reiterate a little bit of what I said earlier. You know, I guess Anne just proved my point that the text exists somewhere, right? And I just don't have it where I'm working. But that the tech and the EMR and everything is out there, and so I'm going to hone in on the message that whatever we move forward with, and how do we give states and clinics and providers the right resources to implement it well. Or else it's just going to be sitting on the shelf, right? And no one's really going to be using it. And so really investing in that to make good meaning of their clinical workflow and how they roll it out. The other thing when we're thinking about stigma, because I just thought about this, is, work with a lot in primary care and in pediatrics. And, there's a lot of stigma even within those walls, right? When we start integrating mental health and substance use care. And so even though I'm saying training and technical assistance, or maybe around integration or a new workflow, some of that is literally us teaching around mental health and trying to reduce stigma even for providers, nursing staff, medical assistants. And it's a culture shift when you're saying now you're going to treat mental health and substance use in your primary care clinic. Some states probably do it really well, and other states, there's just a lot of work around that area. So training is about the infrastructure and IT and make sure billing and everything, but it's also just straight didactic. Let's talk through cases, and let's remember that these are people and families that are coming in for care.
So we'll skip the federal colleagues and move to Sarah.
Thanks. I think a last kind of thought, we've talked a lot about quality outcomes and kind of coming up with quality measures throughout the day. And Michelle, you mentioned that Meadows is working on this. We've also been talking about this quite a bit internally. And one thing that keeps coming up is that we have, today we've been talking about behavioral health, we've been talking about mental health and substance use, but we're really talking about a lot of different things, kind of clinically, how they present, and across acuity and across levels of care, treatment looks different. Like we've talked a lot about sort of the physician and the patient in a session, but a lot of the care that gets provided is provided in group settings, is provided non-clinical care, right? That's sort of case management and family support. So I think we have to get to the point of identifying some universal quality measures and quality outcomes that we can track and kind of use as our North Star as we're evolving these systems. But we also have to kind of understand the complexity of the patient population, the complexity of the whole system, the different levels of care, and even across ages, right? Like we're talking about adolescence to the entire lifespan, and just all of those complexities make it more difficult to navigate. Not that we can't and shouldn't do it, but I think it goes to the point that many of you have made that we have to have all of the stakeholders at the table to kind of come up with a system. Because what I've heard all day is that everyone has kind of the same goal of improving care and improving quality. So.
I think my takeaway at the end, in terms of introducing some of this, the AI technology into this environment, is really making sure we have an appropriate risk-based oversight system in place. So making sure that we're able to introduce those things that we can quickly in an appropriate framework. And we don't necessarily need to over-legislate or treat all AI tools the same, and especially when we're building out new pathways. So I think that's where I'd like to make sure that we don't over-legislate and that we maintain the appropriateness.
Seconded. I already asked for $140 million for IVH, so I'll make a more modest ask at this moment. Just thematically, I think we need to make sure that we consistently lean into the things that are working. And one example of that is the CCBHC program. It may not be perfect, but it is highly impactful. I shared with you an example of how we're using technology to support the CCBHCs in Missouri, and they have been able to generate hundreds of millions of demonstrable savings. And so we've got to lean into programs like that. So I will make one specific policy request that's an example of that, and that is the CCBHC program continues to have a restriction on satellite sites. And that's not a restriction that we place in other programs. And so if we can remove that, it would allow these programs, which are highly effective, and organizations which already work in different settings, to go extend that into places like jails, like we've talked about, into homeless shelters, into acute care ERs. We've got the proven track record of the delivery of services and the technology to support those different modalities. So We need to look at those policy adjustments that we can make that can extend to things that are working well.
I guess my final thought is we all agree that the overall mission here is improved quality, improve access to high quality care at lower cost. I think we have an administration that's willing to make big, bold moves right now to get that done. And I think so. There are kind of two focal points. If I had to Pareto, in our organization, we tirelessly Pareto everything out, right? So what's the biggest impact, the highest ROI, least effort, and I think it's one, a meaningful regulatory shift and support toward value-based care across Medicaid and Medicare for behavioral health populations. That means maybe some enforcement with health plans. It means creating kind of the environment and tools to allow that to happen, including interoperability and EHR use. And then it's completely lost my train of thought. I had a really important second point.
I'm sure.
Really good. I was going to bring it home.
No, so I'll bring it home instead. So grateful for everyone being here. This is fantastic. I think it's just the start of the conversation. I mean, we really need a cross-care coordination systems implementation that providers themselves want and can actually use. I think AI will be critical across this, and so I think to your point, risk-based adoption to help really drive that clinical awareness and then patient awareness of the use of AI, I think will be important. So to Pareto myself, we're joined by Dr. Stephanie Herodopoulos, and so I'd love to invite her to give closing remarks. If you can stay seated while she joins.
Am I stopping you from leaving today? Am I the last 5 minutes of a very long day? Because I have to make it interesting then for you. But I'm Stephanie Herodopoulos, and I'm a family medicine physician coming from Florida. I served as a physician in the front lines for, over 20 years. And then I did a lot of public health initiatives while I was there. We, most notably, I think that's most pertinent to the crowd that I'm speaking to today, is the anti-pill mill bill of 2011. Do you remember the Flamingo Express going down to Florida I-95 to all those unscrupulous physicians that were overprescribing narcotics in Florida? You remember all that. Well, that is where I think my probably public health entree started. At the time, the Attorney General was Pam Bondi of Florida. My husband was president of the Florida Senate, and I was on the front line seeing what was happening to families. And I had I couldn't, with my moral conscience, not get involved in trying to make sure that the anti-pill mill bill, which is multi-pronged, PDMP was one of them, do-outs. We didn't have that before 2011. So unfortunately, people could go doctor shopping or doctors could overprescribe and people were getting addicted and lives were falling apart, and we saw those ramifications. So with that said, I told my husband we need to get this done, and Attorney General Pam Bondi and I worked in the background making sure that we had the votes, and it passed bipartisan, unanimous, and it was really unusual for a policy to have such a direct effect in improving health outcomes on a granular level where it's saving lives immediately. And it really did, and if you look at the data, it really made a huge improvement. So with that said, after that, I helped with increasing the awareness of neonatal abstinence syndrome, serving on a statewide drug task force, and then wanting to apply to the Florida Board of Medicine to be on there for making sure that the unscrupulous physicians were maybe not continuing to have a medical license. Now, I know the root cause of a lot of addiction and mental health issues have changed. The landscape's changed since then, where it's not doctors overprescribing so much, and it is maybe fentanyl and other substances that we see out there. I do want to bring attention to you for your awareness of 7-OH or 7-hydroxymetragenine. Have you heard of this substance? You have? That's being sold at gas stations and vape shops, and unfortunately, this is the source of addiction that doesn't require prescription or for you to go and buy narcotics on the street. This is right at a gas station and a vape shop, and it attaches to the opioid receptors in your brain 14 times more potent than morphine. And this is a problem, and this is a problem that we're seeing in our society. So I know that you're all very interested in this, but I wanted to bring it to your attention so you understand something that I am very passionate about and wanting to bring attention to. From the Office of the Surgeon General, I was able to sit as the Chief of Staff and Senior Advisor, and now the Principal Deputy Assistant Secretary of Health and Policy. We have a megaphone to increase awareness and also some policy steer and grants that within OASH and collaborations or COAGs. So I welcome your ideas going forward in the future. I want to hear about how you think we can improve health outcomes with technology. And I have an open door policy. So whatever you think, I'm sorry I wasn't here all day so I can hear all the comments, but I'm sure between Sam and the good doctor, they can give me a readout of what possible next solutions are to improve health outcomes. So I welcome the input. I'm glad that there are so many states that were represented here today that did have some remarks prepared, but I thought I'd go off the cuff. It was, I heard Louisiana, Minnesota, Utah, and Ohio that exemplify this collaboration with HHS and seeking to innovate and partner at the state level based on local knowledge of needs. MRSS model presented by Ohio, which specifies a 60-minute response time for any person under 20, actually particularly resonated with me. And as the Office of the Surgeon General, it's tasked with the MAHA strategic report in addressing substance abuse issues among the youth. And MRSS undoubtedly will save not only money, but precious young lives. So as my public health career started in this space, I'd really love to continue it through the office. But through the close relationship with the Office of the Surgeon General and the Public Health Service, we're aware of the Public Health Service Officer outreach in the DC area, working with the DC Behavioral Health to address addiction and homelessness. Dr. Captain Nawaba does really great sessions in teaching people how to use naloxone. Once someone is identified with an overdose, she's taught over 10,000 people how to use it to save lives. I think that that's somebody that you can get in touch with and learn from. But anyway, we'd like to do data capture and share vital parts of our ongoing partnership. And as we move forward in the long overdue work of linking mental health and substance use care to chronic disease prevention and treatment, we will also need to evaluate the role of telemedicine and carefully examine the risks and benefits of some newer technologies, such as AI and chatbots. So I'm grateful for this coming together of state, federal, and private sector expertise, along with vital inputs from payers, providers, patient advocates, and other partners. Just to say, I'm going to finish with this: mental health is health, and the systems we use to provide and coordinate care need to reflect that. So thank you for your time today, and thank you for coming together for this roundtable that's so instructive to help make America healthy again and improve health outcomes on a community and granular level. Thank you.
Yeah, thank you so much, Dr. Herodopoulos. And thanks, everyone. This concludes today. Grateful for everyone being here and hopefully can continue the conversation. Thank you so much.